And for that, I invite the people on the dais, Dr. Abhishek Dagar, Dr. Deven Tulli, Dr. Sandhya Makhija, Dr. Pankaj Varshne, Dr. Parveen Mongre, Dr. Om Prakash, Dr. O.P. Anand sir, please. So I'll request till the time Dr. Bali is getting his talk loaded. Can I request? Okay. I'll request Professor Kirti Singh. Okay. Dr. Abhishek Dagar sir, your talk is loaded? Okay. So you can start the session. Dr. Abhishek Dagar is going to talk on posterior segment issues for phacosurgeons. Dr. Abhishek Dagar is a renowned cataract surgeon from Venu Eye Institute, and he needs no introduction. He has multiple presentation at all state, national, and international fora, and is a well-known, reputed, and very popular invited guest speaker all over the country. Dr. Abhishek Dagar, please.
Thank you. Thank you for the kind words. I thank the Delhi Ophthalmic Society for inviting me for the talk today and this very innovative session on didactics, the first of its kind. Yeah. So can I have my talk, please? So essentially, my talk has a few very basic fundamental points. As cataract surgeons, we are sometimes very intimidated by retina or posterior segment issues. So I have tried to capture a few points which are essential in everyday practice, which should help all of us in getting to do our cataracts or anterior segment work better. Can I have my talk, please? Someone can just get it on the screen. I think that main guy knows where to put it, this guy. Yes, this is like what happens when we don't want anything bad to go. We have those very important patients or that very critical surgery, and something bad happens. So videos will run. You sure? Thank you. So essentially, I'll just touch very briefly upon some complications or the few complications of cataract surgery, CME, and cataract surgery or the issues in diabetics, and very briefly touch upon endo and TAS. So cataract surgery, during cataract surgery, there are two major mishaps which we would really want to avoid. One is the posterior displacement of the nucleus or the nuclear fragment or heminucleus, and the or rent which happens while doing a very simple cataract surgery. Now the key factors are the pre-op. During the pre-op examination, we should possibly look at all these factors, and if the PPC well known, pseudoexfoliation, we tend to miss it out because now less and less of it is seen. But PXF usually has very weak zonules, and because in a busy OPD or in a fast pre-op screening, we tend to miss the PXF which might be behind a dilated pupil, and the zonules which are weak then tend to be a problem. trauma, most of the patients don't give a history of trauma. Small pupil, we encounter a lot of patients with small. So essentially, these are the points in which you would tend to have a problem, which would then be a surprise. Essentially, it's not a surprise. We have missed these points. Now, post PPV cataract surgery, a lot of times patients, a lot of diabetics, they've had some kind of a posterior segment intervention, say 10 years down earlier, and when they present with cataract or a mature cataract, we are not aware of the history, or we sometimes don't ask the patient the history. The patients don't elicit the history, and you've got a MAT CAD in a diabetic, had PPV earlier, or maybe even a simple anti-VEGF injection, and you've got a compromised posterior capsule. So these are things, little things which, if kept in mind, especially in patients, which would then land up in trouble. So essentially, what to do and what not. Essentially, everybody has gone through these slides. These are, some decade-old photographs from the earlier books. But the problem is that while doing this surgery, we don't remember these photographs. We don't remember what we've been taught. We've heard these things countless times in all CMEs. The first thing is to freeze your movements. I think that's essential, and maintain the. कोई बात नहीं मैं. Isn't it there on the screen? ये बीच के सोफे हटा लेते हैं. So essentially the very same thing I was talking about, even in a presentation, this is what we face all the time in cataract surgery. That we are not prepared and prepared well enough. I think that's good now. No problem. I think that's fine. It's. I'm glad these things happen, because this is what would be the take-home message, that we start off in a normal case, and we think that everything would go well, and you suddenly end up in problems. I think a lot of times we've seen a lot of problems happen because we get a lot of anti-VEGF injection patients. So you understand that anti-VEGF injections and multiple anti-VEGF injections in a diabetic with a cataract usually compromise the posterior capsule and the zonules. And it's fine, the logo video. And see what should not be done. The phaco probe and the instruments are brought out as soon as you recognize a PCR. So, the logo video shows things which should not be done. I'll play it again if we have time. And right. No problem. Essentially, I'll come back because there would be other talks also. So the lower video, see what are the things which should not be done. So when you recognize a rent and the surgeon did not recognize the rent early enough and went on to do carried on with the phacoemulsification, a lot of fluid is going into the eye. And when they recognize the rent, they suddenly jerk everything out and see the vitreous must have been there in the phaco probe. And when it was pulled out, you would actually... It's not just the rent happening at that time, you will have an RD, say 5 years down the line. So these are things which, during the surgery, try and freeze your movements, just don't jerk out suddenly. Try and do a good anti-vitrectomy with possible cortical cleanup. You don't really need to take out all the lens matter. Place a suture at the main incision. Please remember that after an anterior vitrectomy during phacoemulsification, the eye usually goes into a hypotony. During the surgery, because we've got a lot of things working in our mind, and there's a speculum which is holding the eye tight. When you remove the speculum, the post-op, the patients will go into hypotony and will have a leaking section. So placement of a suture at the main incision is critical in a PCR case. Early recognition of PCR obviously is the way to go. Now the gray zone, this is an old video, I'm sorry about that. The problem is that when we have a kind of a nucleus drop or a rent or a casualty in the phacosurgery, a lot of places a PPV or a vitrectomy or a posterior segment intervention is done together or on the same sitting. Now this is very questionable. Why? One, because our informed consent, and consent is for the cataract surgery and not for PPV. That's point one. Point two is that the costings, this could be possible in say a government hospital or a charity institute, but these are two separate surgery which should be done separately. The patient is not aware of the added procedure and the complications of a vitrectomy. And in most of these cases, lengthening the surgery when the anesthesia is going off, or maybe it's a topical case, would actually complicate this procedure further. The point I'm trying to make is that even if the facility is there to do a PPV in a nucleus drop during cataract surgery, it should be very cautiously gauged and cautiously thought of before we suddenly jump into getting a posterior segment surgeon into the picture and trying to do a PPV in cataract surgery. I repeat, there are 2 or 3 things which go against it. One is the consent, one is the medical legal problem. The second is the actually adding comorbidity to the surgery, and the results might or might not be the same. An ideal timing for a PPV post cataract surgery complication would essentially depend on the cornea clarity. Please remember that the cornea which is clear on table, you had a rent, you had a nucleus drop, you feel that the cornea is clear enough. The cornea goes down the next day. The cornea does not remain clear the next day, so always give a week, 10 days before you actually move on to doing a posterior segment intervention. Remember, the cornea which seems clear when you have a PCR is not clear the next day. Manage the comorbidities, manage the secondary glaucoma, manage uveitis, and then get your posterior segment colleague to do the intervention if needed. The larger or the longer time you stay, the better the recovery would be. The eye gets time to heal, you can gauge the comorbidities and actually treat other things. Rushing into a PPV as soon as you had a cataract surgery is strictly a no-go. Now, when do you have a posterior displacement of IOL? Again, these are things which are usually unrecognized. You've done a good cataract surgery, but what happens? You've got an unrecognized PCR or zonal lysis. You've got weak zonules, you've got trauma. I again repeat, anti-VEGF injections. If a patient has had anti-VEGF injections, please be sure about a good dilated examination and look at the bag and the zonules. Or you might have a posterior capsular defect which might or might not be recognized earlier. And a previously vitrectomized eye. A previously vitrectomized eye, usually the anterior chamber goes deep during phacoemulsification. In the OPD you might miss it because the patients don't give a history of a PPV done 10-15 years ago. But on table you'll see that the whole lens diaphragm goes back while doing phaco, and you actually might have problems. So this video also shows that even if you got a rent, see in this case there was an unrecognized PCR and the surgeon pushed the lens into the posterior capsular defect. But if you've got the right instruments, you've got a bimanual anti-vitrectomy setup, and so remember that the vitrectomy or the anti-vitrectomy, the fluid and the vitrector should be different. They should be approached, they should have 2 different instruments. It should not be a coaxial vitrector, which was there earlier in a lot of machines, but now you have 2 setups. So an IOL explantation is recommended in all these cases, but should be deferred to a later stage, and secondary IOL today is possible in most of the cases. Now a few medical issues which sometimes are confounding, and So the risk factors obviously for a CME are a complicated cataract surgery. There could be pre-existing risk factors which could have been missed out. Diabetic retinopathy or an RVO, an old RVO, or some kind of a pars planitis, not an active uveitis but a pars planitis which had a subtle CME which we missed. So again, some very few good studies have come around recently in the last decade which push for an OCT. You would be surprised if you do an OCT pre-op, there are almost 20 to 30% of the patients in cataract, patients who've come for cataract would have some kind of a macular problem. And it is almost nearly, I think, essential now that you do a pre-op OCT macula, especially if you are doing a premium IOL, a so-called IOL in which the patient is paying extra or more and you're promising more than the normal. You would be surprised at how many cases you pick up in which the result would be affected by a CME which you missed on a slit lamp examination, which because of the cataract you don't see, or because you are too enthusiastic selling a premium IOL and later you land up in trouble. So essentially doing a pre-op OCT macula, even if the patient is not paying extra for it, try and get it done. It saves your skin at least in 1/3 of the premium cases. Management, obviously, everybody knows is topical NSAIDs, and sometimes a lot of people give anti-VEGFs and refractive CME. I think a second intervention in a patient with a refractory CME post-op who's already very disappointed in you should be deferred. Try and get a second opinion, try and get a colleague to see it, try and get a good counseling done. We use topical NSAIDs pre-op and post-op in addition to antibiotic steroids. I think they work very well. Now, patients with diabetic, the diabetes, the problem is the moment we see diabetes or a diabetic retinopathy, as an anti-segment surgeon, we sometimes tend to go ORI or don't do the cataract surgery or kind of miss it out. So the patient who's had diabetes, these are key things. As a physician, we are all physicians. We've all done our MBBS, and I think just get a profile done, look at the control of the diabetes and any associated diabetic comorbidity in the body. Now the problem is that these patients, and a lot of patients, almost 30 to 40% of patients of cataract in your practice would be having diabetes. You ask every second patient, they say, diabetes, hai, sugar, or they won't tell you unless you ask them. The problem is that if there is a pre-existing macular edema or if there is a pre-existing central involving diabetic retinopathy, the chances are that it will likely increase in a cataract surgery, and the patient will then blame you. Best in a diabetic patient is to get an OCT or get if possible, a fundus photo, which you show to the patient pre-op. Show to the patient and tell them that cataract is the one thing you're looking at and taking care of, but the diabetic retinopathy is already there. I'm repeating, most of the patients then later blame you for the diabetic retinopathy. So try and get the diabetic retinopathy sorted out and counseled about to the patient before you proceed for a cataract surgery. Now, which are the patients in which you should try and get a VR consult? And these are any center involving diabetic retinopathy, or when you see a bleed or a PDR, or a patient who's got anti-VEGFs or injections or a diabetic retinopathy treatment before they came to you. Always get a diabetic retinopathy referral or a cross consult with a VR, because that is going to save your patient post-operatively. So the patient already knows that 30% or 20% of the vision is down because of diabetic retinopathy, and you've done a good job with your cataract. So,
Dr. Abhishek, can you summarize?
Yeah. So the diabetic maculopathy with after cataract surgery tends to progress, and so prevention is obviously try and be careful about very good atraumatic surgery in the diabetics, and look at the comorbidities. When not to give anti-VEGF, a lot of people give anti-VEGFs with cataract surgery. These are the situations in which you should not be giving. And again, get a VR consult or get a person or a colleague who knows about diabetic retinopathy and foveal ischemia and patients which have a TRD which you might be missing. And now this is a new one. I don't know how many of you've had these cases. The higher end phaco machines or the so-called better phaco machines, the intraocular pressure or the the very high level of fluid dynamics in the eye sometimes cause a damage to the optic nerve. You've got I've seen at least 5, 7, 10 patients in which the cataract surgery went uneventful. Everything is good to go post-op, and you see that the patient is not recovering good vision. Remember that these are the patients in which, because you've got the bottle height at 100, or you've got very high intraocular pressure while doing the surgery, or you're doing a very fast surgery at very high rates, the optic nerve gets affected, and this is a particular kind of an NAI. And the problem is that if this patient comes to you for the second eye surgery, you should be slowing your parameters, going down on them, and these are surprises which at least we've seen and very difficult to manage. A very quick thing on TAS, because in our institute we are using intracameral cefuroxime, which we've using since 2007 odd as per the ESRS, and we're not having any kind of end-off or anything. The TAS, a very small point. The problem in TAS is that the signs are more than symptoms. End-off, everybody recognizes. TAS, the patient looks very scary. You're scared to death. And actually, it is something which can actually
Dr.
get
Abhishek,
resolved.
can you please, because this...
Thank you so much.
Thank you.
Thank you. I'm sorry I overshot time. I wasn't sure in the start.
That was really
Dr.
wonderful
Abhishek,
talk.
sorry, we want to hear you. We wanted to hear you more, but we have a lot more interesting topics. But you really summarized everything very well. The posterior segment issues, the main thing is that one has to be really, aware and alarming thing, any alarming thing.
Dr. Kirti, can you be there on the dais?
Good fundus examination, good preoperative examination, and good systemic workup. Thank you.
Thank you.
Now we invite Dr. Professor Kirti ma'am. Everyone knows her very well, Director Professor Guru Nanak Eye Center. And she's been a doyen in glaucoma surgeries and glaucoma management. And she'll be talking about combined cataracts with glaucoma filtering surgeries. We welcome you, ma'am.
Thank you. The topic is little different. It is phaco in coexisting ocular comorbidities along with glaucoma. So, and I was told it has to be a video session. So it's going to be a video. So maybe it's a good opportunity for us to have such a close interaction, because normally we want a full house, but sometimes the quality is more important than just the quantity of the house. So thank you to us for this opportunity. And I've titled my topic as phacoemulsification in coexisting ocular comorbidities in sticky situations, when the surgeon is in sticky situations. So I'll just be sharing some videos when we face these sticky situations. And this is a patient of uveitis. Very often in uveitis, you have pre-existing inflammation. You must try to control the inflammation before you do the surgery. Be in a quiet eye. Capsule often is sticky, fibrotic. Rhexis may be a little difficult. Invariably, these patients are young. The cataract is soft, and PSC is pretty common. Now in this patient also, it was a little intumescent and a soft cataract, and the Rhexis escape is there. So with the Utratas and with the intravitreal scissors, we recaptured the Rhexis and complete the Rhexis. But you have that weak edge here, which you have to be careful of. Now the phaco normally is pretty simple in these patients, in uveitic patients, but you just watch what's happening when the phaco aspiration is happening. There's a bleed. Is it visible there? There's some problem in this thing. The Amsler sign was there in this patient, and very rarely we see it, but it's not visible very well here, but yeah, here it is. You can see the Amsler, the bleed of this thing. Why it happens, nobody knows, but invariably Fuchs patients do pretty good post-op. Polishing has to be done. And in their young patients, minimize the CE damage, and zonules in uveitic, not in Fuchs, but your zonules can be compromised. This is another patient where we had after phaco, I found it it was a relatively young patient, did a meticulous polishing, but the capsule was fibrotic. Now, if you are trying to achieve vision, this will not give really good vision unless you go for a YAG later on. So we attempted what we do in children, the gimbals technique. You just initiate the PCC with a sharp cystitome, put high viscosity viscoelastic beneath the rexus, beneath the posterior between the posterior rexus, and start the PCC. Now we have a hospital where we don't have all the time Helon available, so this is, mind you, being done in the oro high visc only. Often the PSC area is thinned, so when you are attempting this removing of the plaque, be very gentle and step by step to cut the fibrous plaque, and we required a needle, we required a scissor to cut the plaque. And the rest was just the insertion of the normal lens, and you have a PCC so that this patient can see. These patients again will have very frequently cystoid macular edema. So the consent and as the doctor before was been saying, that you have to take the consent before that this is pre-existing. This has been shown multiple times in different forums, but when you have a small subluxation, you can just use iris hooks or capsule hooks. Again, we do with what we have, so we have iris hooks more frequently, and really thanks to Dr. Gupta because he made that so easy with the Madhu instruments. Otherwise, the things were expensive. Now, this is a little harder cataract, so I'm doing the divide and conquer technique. I've anchored the subluxated area with just the iris hooks and absolutely low phaco, low height, visco-coaxing the nucleus fragment out from the unstable area and carrying on the phaco a little bit in the anterior chamber. Because I did not want to put a CME or a CTR, I thought I could get away without it, and that's what I'm trying. So patience, I mean, you just can't be very rapid in this, you have to be just patient. This phaco is happening above the rexus plane. I am in the anterior chamber partly, and I'm being very slow about it so that the endothelium is not damaged. So we could get away with that, and the IOL is stable, and we did not need to put a CTR. So you have to analyze how many clock hours, and if on table it had increased, we would have definitely put it in a CTR. Like in this one, we do need a CTR and we needed a CME also. Same iris hooks were put, but this subluxation was more than 9 clock hours. And the rexus again is very difficult to initiate. You have to be very slow and steady. Utratas would help you out. You can do the spiraling technique, have a smaller rexus in the initial part and then gradually increase it. Small rexus is technically easier to do, and if it's a soft cataract, you can do a phacoaspiration and remove it and then increase the rexus at a later date. Now here you're putting in the iris hooks first. CCC is stabilized. The small CCC is stabilized with the iris hooks. Now we have thankfully the capsular hooks. This is a little older video. And I'm trying to do a phacoasp just with the education aspiration cannulas and dialing in the CTR. Then, this could have been done before also, but I was trying to see if I could balance, if I could stabilize the bag with just this CTR. I could not. So then I've made the flap for the CME, and the CME flap has to be made in the area which has a maximum dialysis. And this is the railroading technique which you're all familiar with to put the suture in. And this is the CME being dialed in, and the CME has to be anchored. It's not a very good quality video, but it was the one which was showing all the 3 things, so I decided to use this one. When you are anchoring now, we do a very smaller steetle flap also. And Hoffman technique can be done, but in this patient we have not done the Hoffman. This is another thing which we see very commonly in our setup. We have patients with filters which are failing, But they're not totally failed yet. So when you've done a phaco, very oftenly in ACG conditions, the iris is thick and the PI has a tendency to be blocked in the trabeculectomy side. So this, in this patient, the iris kept coming out. It's like a floppy iris. So we do a temporal PI.
Dr. Kirti, can you summarize?
Sure. Right now? Right now or one more? One more video? Okay. And I've done a needling, intraoperative needling along with phaco. Initially, I used to do an intraoperative needling with 5-FU, but now I do it with mitomycin because 5-FU doesn't really work, and thankfully we don't have much DAS. So this is the last video which I have of an overfiltering bleb. It is a very shallow AC. There was a corneolenticular touch. She was a young girl, and the lens thankfully was very soft, but it was overfiltering, persistent shallow AC, and she developed cataract, and we had to remove this lens. The cell count in this patient was just a mere 1500. The whole iris lens diaphragm was displaced upwards, bulging clear lens. So here we did get viscoat, did hydrodelineation, and we removed very slowly, again patiently removing, because this bleb we are not scared of failing. In fact, we want the bleb little bit to fail. I used the iris stroking maneuvers many times. However, because of the constant shallow AC and the corneolenticular touch, I have done something called as the internal revision, because where this is the PI site, the PI site had to be reformed and the visco removed and the bleb would subdue. So in these situations where you have sticky situation and the surgeon is in a sticky shape, remember what cataract actually meant. Cataract was, from the Egyptians, the word came up from the rapids in Nile, wherever it had an obstruction. So whenever you are in a sticky situation in cataracts, just improvise and devise, and patience is the key. Thank you.
Thank you, Dr. Kirti. That was really a wonderful talk, the way you demonstrated how to do in coexisting glaucoma and also the subluxated, displaced, dislocated cataracts. Can I invite the next speaker, Dr. Jatinder Bali? Is your talk ready? I think the next speaker should be ready. Yeah. After Dr. Jatinder Bali, Dr. Subhash Dadia. Okay.
नहीं मेरी
In the meantime, Dr. Kirti, like if you had shown a first case with peripheral extension of the tear, and what happens like if the tear goes behind and into the posterior capsule? You get the anterior tear as well as the posterior tear. What will be your approach?
If you can't get back the rhexis, it has escaped into the posterior capsule and you have the cape. It depends on what is your type of cataract. If it is a very hard cataract, I would convert to an SICS and take out the cataract. If it's a soft one, I may still attempt what I did before, levitate the nucleus out. Or you can also do the technique of scaffolding with a hydrophilic IOL, keeping the nucleus out and doing a phaco there. But usually, a soft nuke cataract to take out, do the phacoasp, and then decide whether you have to do vitrectomy. Obviously has to be done, whether you can put it in the sulcus or you would need a second sitting. Having said that, vitrectomy, when you do, you have to put that trypan blue, the triamcinolone, because you have to remove all the vitreous pieces, because if the strand is sticking there, as shown by my previous speaker, later on you can get an RD from there. And that area always is weak. So it depends on which type of cataract I have, and we convert to SICS pretty easily because our students have it all the time and they just go superior and convert it.
Right. Thank you, Dr. Kirti. And one of the important points when you have the extension of the anterior capsular tear, you have to be sure whether the tear has gone into the posterior capsule. Has it crossed the equator of the capsular bag or not? So that becomes very important because during the surgery you are always worried that whether it's extending to the posterior capsule or no. So your parameters has to come down. You have to be very slow phaco, and your manipulation should be very restricted. One of the important sign Dr. Rohit Om Prakash has published, that is called as the flap fluttering sign. If you have a capsular tear, anterior capsular tear during the phacoemulsification, you have to see how the flap is fluttering, whether it's fluttering anteriorly or posteriorly. If it is fluttering anteriorly, both the flaps, it means your tear is still within the equator. If it starts fluttering posteriorly, like it moves, the flap moves posteriorly, that is the sign you know that now the tear has extended into the posterior capsule. So that is the point you have to either stop and then see what you can do, as Dr. Kirti has said. Thank you.
Right. So now we have Dr. Jatinder Wali, and he's going to talk on managing astigmatism in manual small incision cataract surgery.
Good morning, ladies and gentlemen. And at the outset, I want to thank the Delhi Ophthalmology Society, its executive, and all its members for giving me this opportunity to talk to you about managing astigmatism in small incision cataract surgery. I have no financial disclosures to make for this presentation. And the first question that comes to mind is why in this day and age of where you have toric IOLs and you have flax, why are we talking about managing astigmatism in small incision cataract surgery? Well, the original thought, our goal is not basically getting zero astigmatism in small incision. The thought process has been changing. For lower order aberrations, for astigmatism, a minimal myopic astigmatism probably gives your patient a more comfortable near and intermediate vision. I'm not against implanting toric IOLs and the other procedures. Go ahead and implant them. The point is that you can achieve gratifying results even with simple IOLs. So now, how do we go ahead and try to get minimal myopic astigmatism in small incision cataract surgery? Now, if we look at all the meta-analysis that have been there, we'll broadly agree that, for conventional phacoemulsification, we're looking at an astigmatism and a surgically induced astigmatism of, say, 0.5 diopters, and for small incision, 0.8, 0.9 diopters. So that is surgically induced astigmatism. What happens if you place this incision on the steeper axis? You are actually reducing the astigmatism. You are correcting the astigmatism. So these are all those meta-analysis. I won't go too much into the details of it. I'll just take you back to our original thinking, where when we are younger, the vertical axis is steeper, and then it starts shifting, and we start getting against the rule astigmatism. So basically, what people are doing in small incision is they're placing there are 2 or 3 ways of reducing the astigmatism. One is, of course, you place your incision on the steepest axis, and that means your standard incision on the steepest axis, or you reduce the incision size. But whenever you do that, some sort of a nucleus management, some sort of a phaco-fragmentation will be required. So I will give you an example of how it is being done. So this is placing it on the steepest axis. You mark the 3 o'clock and 9 o'clock with the patient sitting down, and then you make the patient lie down, align the 3 o'clock, 9 o'clock, and mark like you do for your torics. You mark the superior pole only is required. You can mark both. If you have a callisto, fantastic. Then mark your distance, mark your incision, and place your incision on the steepest axis. Now, how much of an incision to place? There is a nomogram for it, which has been published in November issue of IGO. It's called the Boramani algorithm. That was a curved incision. Now, this is a 7 mm straight incision. So what we did was we did an audit of a fairly large number of cases, And we came up with, so we did an audit of a fairly large number of cases, and we realized that, you know, the superior incisions gave us almost a linear linear relationship. So this is a 5, 6, and 7 millimeter. And then temporal ones gave us a lower astigmatism. So depending on what is the amount of astigmatism you want to correct, you are going to fashion your incision. The curved incisions give you lower astigmatism compared to the straight incisions. Here we use just a frown and a more curved frown. The extreme of this more curved frown is when you do when you reduce the size of the incision. So we have something called the 2 mm Sahu incision, and I will just briefly show you. So what here we are doing is we have done a little bit of Whitfield cautery is done, and we mark a 2 millimeter chord incision. We've marked 2 millimeters. I hope you are able to see that. And then we take, see, this is a 2 millimeter. The 2 millimeter chord is marked. And we take backward incisions from here. These are called back cuts. I will fast forward it a bit. So we proceed with the surgery. The rhexis is completed. And then we enter the chamber. Of course, we've talked of, you know, you will need to have some sort of a nucleus management. You'll have to fracture the nucleus. So you can do it in the tunnel, you can do it in the chamber, and now people are even doing it in the bag. Many ways of doing it. I have some videos of the snare, which is a very repeatable way. Yes, of course, there is a minimal, there is a learning curve involved there. Now suppose you've completed your surgery and post-operatively you end up with astigmatism. What are the options available to you? There are those limbal relaxing incisions we used to talk of, and we have different nomograms which are available. So what I'll just show you a small one. So we've marked it there. The catch is the thinnest, 90% of the thinnest pachymetry is what you are aiming at. And you will just join the 3 dots here. What has been done is the steepest axis, our LRIs are now marked, and we will just join these 3 dots here. I'll just take 1 more minute, right? And this probably will be clearer. So here, and this is a 30 degree which has been marked, 30, 35 degrees. There are different nomograms which are available. This is the Napa nomogram. And of course, we have, then of course you have the femto, the subepithelial and other modalities which are available, which I'm really not going into into. And what we are trying to say is that it is possible to get minimal myopic astigmatism because your aim is not to get 0. You want to come close to 0, and it is possible for you to calculate it. And to help you calculate those, there are a number of calculators which are available online. Thank you so much.
Please come. Maybe that was very nice talk, exhaustive talk and you have rightly told that even it's possible by Amulya Sahu 2 millimeter incision to do phaco and also decrease the amount of astigmatism. What is the length of the inner lip of the incision in Amulya Sahu's incision?
Sir,
External is 2
what people have been doing is, Dr. Sahu propagates that inside you open as much as you want. But there are people, especially Shankardeva Netralaya, Guwahati, has been propagating that, the inner incision should also be around 4 millimeters, because what they're doing is they are fracturing the nucleus in the chamber. So what you get is 3.5 or 4 millimeter nucleus. So you need just a 4 millimeter inner lip and a 2.5 millimeter, because you see what happens is the scleral lip is capable of distending in either direction.
Because
So
why I asked was, the astigmatism is dependent not only in the incision within the scleral incision within the astigmatic funnel, it also depends on the length of the internal incision. If the internal incision is more than 4 millimeter, astigmatism will be affected.
Sir, actually what we've done is we've done an audit of a large number of series, like we've done an audit of the surgically induced astigmatism of a very large number of cases for 5 mm, 6 mm, 7 mm, straight versus curved, and then we've also done it for the 2 millimeter and 3.5 millimeter. 3.5 millimeter has been around since I think 2005. That was when it was presented for the first time in the AIOS. And this 2 millimeter was presented, I think, came up somewhere in 2015, 2016. And it's just been published, I think last year, we've published the results of the astigmatism.
Dr. Bali, have you tried any loop technique to crack the nucleus, which can definitely possible in the back to crack the nucleus in 4 pieces or 2 pieces?
Sir, it is, I have a video of it and it is fantastic. It actually, when you do it, it is a snare. My loop is just a snare, and there is a small learning curve to it, but once you've mastered it, you're not going back to any other thing. The only thing is that, when you actually bisect it or trisect it, they tend to stick to each other like glue. So you need to put visco in between and then separate it.
Yes.
Right. Thank you, Dr.
Nice.
Bali.
Badhiya talk.
Yeah, may we have the next speaker, Professor Subhash Dadia, and he's going to talk on management of amblyopia after pediatric cataract surgery. Dr. Subhash Dadia is professor at Guru Nanak Eye Center and is the unit in charge of squint and amblyopia.
At the outset, I would like to thank DOS Executive. Good morning, ladies and gentlemen. And
Can we have Professor Rohit Saxena on the dais, please?
So basically, pediatric cataract is one of the major cause of preventable childhood blindness. And early diagnosis and treatment are crucial to prevent the development of irreversible stimulus deprivation amblyopia. The management of pediatric cataract should be customized depending upon the age of onset, laterality, morphology of cataract, and other associated ocular and systemic comorbidities. However, it is very important to treat amblyopia because amblyopia is one of the most common cause of monocular loss of vision in children. With advancement of cataract surgery techniques, congenital cataract is very well managed by the surgeons. However, the treatment of amblyopia is not so managed by the persons. Postoperative amblyopia is still an unavoidable complication of the cataract surgery. And this amblyopia management is still major obstacle to achieving good visual outcome after childhood cataract surgery. A critical period for visual development has been described in the first 6 weeks of life, during which the vision is subcortically mediated and infant is relatively resistant to treatment of amblyopia. So basically, we must do the cataract surgery in unilateral congenital cataract by 4 to 6 weeks, and bilateral congenital cataracts, they must be operated by 6 to 8 weeks of life to prevent development of stimulus deprivation amblyopia, stimulus and strabismus and nystagmus. And prompt optical rehabilitation and occlusion therapy can result in good visual outcome with fusion and stereopsis. So basically, refractive power at birth is approximately 30 or more, and by 5 years, it is reduced to 20 to 22 diopters. So this means IOL, which can give normal vision in infants, will produce significant myopia in later childhood and adulthood. So there is role of undercorrection in pediatric cataract. and in oil power calculation. Unlike adults, visual outcome after a successful cataract surgery in children depends on timely management of amblyopia, especially after unilateral cataract extraction, and generally patching after pediatric cataract surgery is continued until it is believed that child is no longer at risk of developing amblyopia. However, there is no consensus regarding amount and duration of patching therapy necessary to achieve good visual results. Extensive occlusion therapy during early infancy may disrupt the development of binocular vision, so that is not advocated. Compliance with patching has been shown to be associated with good postoperative visual outcome in unilateral and bilateral cataracts. Therefore, educating the parents about importance of amblyopia therapy post-cataract surgery is very crucial. So we must educate the parents that after cataract surgery, the patching should be continued. It is crucial to provide approximate optical correction of the refractive error as soon as possible after cataract surgery in child in order to minimize the disruption of process of visual development. Uncorrected aphakia in many cases may be as damaging to vision as cataract itself. Spectacle or contact lens correction of aphakia should be provided before the second post-operative week after pediatric cataract surgery. So it is very important, refractive correction must be provided to the children after within the second post-operative week of the cataract surgery. Ametropia, that is exceeding 1 diopter of hyperopia or 4 diopter of myopia in pseudophakic eye, should be corrected with glasses or contact lenses because it is amblyogenic, and usually it should not be delayed beyond 4 weeks. Bifocal correction to optimize both near and distance vision may be helpful for visual rehabilitation of preschool children, and it should be definitely provided in school-age children. Occlusion therapy for documented or presumed amblyopia is the last and often the most critical element of post-operative care in cases of unilateral or asymmetrical cataract. Self-adhesive patches should be applied to the better seeing eye, but there are others like Opticlude. Then atropine penalization may be tried, but that is not as good as patching. So basically for infants under age of 6 months, a few hours of patching in a day is very appropriate. Beyond 6 months, occlusion for half the waking hours or more should be the goal. Between 1 to 3 years, patching is typically very difficult and may lapse altogether. And from 3 to 5 years, although effective amblyopia therapy is usually possible, significant improvement in acuity can often be obtained even if earlier efforts were met with failure. So 1 to 3 hours of occlusion therapy daily to maintain vision at the best level achieved ought to be continued until the child is about 10 years of age. So basically in children's, we don't advocate aggressive patching because that may disrupt the binocular vision. So with persistent post-operative efforts, ultimate visual acuity of 6 or better can be achieved in most children whose treatment is initiated within few months. So basically this Wright and Park et al, they warn against aggressive amblyopia treatment following pediatric cataract surgery. So basically very early treatment could give better visual results. It was concluded that occlusion treatment of amblyopia more than any other factor will be determine the visual outcome. So basically early surgery, accurate optical correction and occlusion therapy are the criteria for proper management of amblyopia following cataract surgery. Thank you.
Thank you, Professor Dadia, for the excellent presentation of management of pediatric cataract amblyopia after the cataract surgery. Dr. Dadia, in the meantime, I'll request now Dr. Bhalla to come over and give his presentation on IOP rise during and after cataract surgery. Dr. Daria, what is the maximum anisometropia we can very easily tackle with the amblyopia therapy? Or like after giving the amblyopia therapy, like when you take off the amblyopia therapy, then what is the anisometropia which the patient can take up easily?
Sir, what is the amount of an isometropia?
What is the maximum limit for the anisometropy after the pediatric cataract surgery? Because generally they develop anisometropy because we are not putting the correct IOL power, or they tend to develop myopia later on.
Usually, 2 to 3 diopter can be corrected with glasses. And more than that, it requires either contact lenses or the refractive surgeries. So, if it is more than 3 diopter, usually it is not tolerable in children and it can lead to diplopia.
Okay, it means up to 3 diopter, like we can easily give the glasses. If it is more than that, then we have to give
So,
contact
either
lenses.
we have to give the contact lenses or we have to try other modalities.
Other modalities, okay.
So would you advise, like on table, if you see the retinoscopy correction and you put contact lenses on table immediately after surgery?
This is done by pediatric cataract surgeons. My job is to do the amblyopia therapy post-operatively.
Thank you, Dr.
Wonderful
Sir.
talk.
Thank you very much.
Thank you, Dr. Sir.
The topic I am going to cover is IOP rise in and after cataract surgery, because we are so focused on doing our cataract surgery and phaco that we really forget that some patients we have to reduce the IOP, we have to maintain IOP, particularly in advanced glaucoma patients. So IOP lowering effect of cataract surgery, it occurs from 3 to 6 months, and phaco causes decrease in IOP of 1.1 to 2.5 millimeter of mercury for at least 6 months in both glaucoma and non-glaucoma patients. Increased IOP during the first 24 hours after cataract surgery is a major post-op complication, and IOP elevation may initiate at 2 hours with a peak at 6 hours and last for 24 hours. And these are the studies where they have found that about 4.4 patients had IOP elevation of 10 millimeter mercury, and this can be really hazardous. And what it can lead to complications are, it may cause pain, corneal edema, it may precipitate, as Dr. Abhishek Dagar said, non-arthritic ischemic optic neuropathy, vascular damage. So why IOP may rise during cataract surgery? This is important slide. For a typical eye with the anterior chamber depth of 3 millimeter, what volume of anterior chamber is just 0.2 ml, and the posterior chamber volume is 0.04 ml. So the total is 0.24 ml. This yields a total working volume of just 6 to 8 drops, in which we have to remove the cataract and insert the IOL without damaging the ocular structures. So what we have to do is we have to optimize the setting of our phaco machines to maintain the intraocular pressure. And this is an important thing. Acute intraoperative rock hard eye syndrome can occur. Very shallow AC with absence of suprachoroidal effusion or hemorrhage. It usually occurs during uneventful phaco, particularly in hyperopic eyes, and may occur even some hours after the surgery. And why it occurs is because of inappropriate movement of BSS via the zonular fibers. The fluid pressure at the base of column of water is, this is the formula. So what we have to be really concerned about is an entity called mean arterial pressure. And what is mean arterial pressure? It is diastolic blood pressure plus 1/3 of the difference between systolic and diastolic. So if diastolic is 80 and systolic is 120, it is 80 plus 1/3 of 120 minus 80, that is about 93. And mean ocular perfusion pressure is a very important entity. It is 2/3 of this mean arterial pressure minus intraocular pressure. And this is important entity to maintain adequate perfusion pressure, particularly in moderate to advanced glaucomatous patient. I'll give you a clinical example. A patient with systolic blood pressure of 120 and diastolic blood pressure of 70, the mean arterial pressure will be 87. And mean ocular perfusion pressure will be 38 millimeter of mercury. So when you start the surgery, and you have infusion bottle height at 100 centimeter, this is going to induce 74 millimeter mercury pressure in the irrigating line. And what will happen is no function of aspiration, if no leakage is occurring through the surgical wound, this pressure is higher than the arterial input, because mean ocular perfusion pressure will be minus 16. 2/3 of 87 minus 74. So ocular perfusion is going to totally stop during this part of the surgery. In uneventful phaco, Where there is the ocular nerve head is healthy, this may not matter. But imagine if this ocular perfusion stops in moderate to advanced glaucoma patients, you may do excellent cataract surgery, but later on when you find post-operatively, the patient has landed up with advancement and progression of glaucomatous optic neuropathy. So these are types of glaucoma post-cataract surgery. They can be classified into open angle and closed angle. Open angle can be due to the blood in the anterior chamber, where the trabecular meshwork is obstruction occurs by red RBCs, platelets, fibrin. And what we do is management depends on the type of the IOP elevation, the health of the optic nerve, presence or absence of sickle cell anemia. Medical treatment is favored if the IOP is elevated to more than 40 millimeter mercury or persistently elevated to more than 30 millimeter mercury. So we have to take care of the inflammation with frequent topical steroids, and surgical intervention like AC washout is required only if there is uncontrolled intraocular pressure or if the blood in the anterior chamber is too much. Uveitic glaucoma particularly occurs in eyes with pre-existing uveitis or eyes with more severe inflammatory response where you're leaving behind some amount of the cortex or epinucleus or nuclear fragment. And so open angle glaucoma results here from trabeculitis. And secondary open angle glaucoma particularly occurs if you are doing cataract surgery in heterochromic iridocyclitis. Again, treatment is routine, frequent topical steroids, along with you also need to give cycloplegics, anti-glaucoma medications. If IOP, they can take care of moderate rise in IOP, but you may require iridectomy to relieve the pupillary block. UGH syndrome, we were all familiar in the earliest anterior chamber IOLs, no longer prevalent with the modern generation posterior chamber IOLs. Lens particle glaucoma, if residual cortical matter after cataract extraction can cause significant intraocular pressure rise along with corneal edema. So treatment again with topical steroids and anti-glaucoma medication. But if it persists, both the inflammation and intraocular pressure rise is not combated with your medical management, then you may have to do AC wash and remove the residual lens matter. Dislocated lens fragment, this is again more serious than the cortical matter retention, because this may occur during the inadvertent PCR and loss of nuclear fragments into the vitreous, and these are the risk factors which were highlighted in the talk by Dr. Abhishek Dagar. And management depends on the how big are your fragments. If there is dislocation of epinucleus, small amount, it may be managed conservatively, but if there is big nuclear fragments, then you have to do pars plana vitrectomy or the help of the VR surgeon to remove the fragments. So viscosurgical agents can cause significant rise in intraocular pressure, and here if you leave behind, the IOP rise occurs between 4 to 7 hours post-operatively and returns to normal within 24 to 72 hours. And the management occurs depending on the type of viscoelastic. Your dispersive ones, which are difficult to remove completely, may cause significant rise compared to the cohesive one, which comes out in a single blob. And to reduce the incidence of post-op elevation, we have to really see, particularly in glaucomatous patient, if the IOP is risen and there is no reason for this, you should suspect that retained viscoelastic is causing the blocking the trabecular meshwork. And what you can do is, this is a technique, I'll just take a half a minute more. This is a technique described by Dr. Uday Devgan, where this is angle sweep is done to remove the viscoelastic, and this is with injection of BSS via 27 gauge blunt cannula, which is directed toward the angle, and it takes out the viscoelastic that can be aspirated by the, this is capsular block syndrome. So I'll just skip the slides. So malignant glaucoma is another serious entity. To summarize, elevation in IOP may occur early or late in the post-op course and can be associated with either an open or closed angle, and may cause many causes exist for IOP elevation after cataract surgery. Thank you everyone for your kind and patient hearing.
Thank you, Dr. Balla, for the excellent presentation and description of all the situation where we may get the rise of the intraocular pressure. And I think in most of these cases, like what we need to see is, before we start the cataract surgery, we have to be sure the patient is not having any tendency of rise of intraocular pressure. So your glaucoma evaluation before the cataract surgery is very, very important, because you have to see that. Because these are the cases where the pressure may rise during surgery and after surgery also. And especially if you have a very narrow angle cases, although patient may not have the narrow angle glaucoma. Narrow angle, like during the surgery, I've seen many of these cases. If you have a very narrow angle, the pressure starts rising, and it becomes very difficult to manipulate the nucleus, and you have a very shallow chamber, very low chamber. And intraoperatively, as Dr. Bhalla has very well described, removal of viscoelastic is very, very important, because if you leave viscoelastic in the chamber, or even most of the time what happens, the viscoelastic is left behind the IOL. So it's always better to go behind the IOL with your irrigation cannula so that you completely wash out the viscoelastic from the capsular bag. And that is the viscoelastic which is later on going to go into the angles. And he said that angle sweep technique is also very good. So very nicely explained, Dr. Bhalla. Thank you very much. Dr. Alkesh, you want to ask something?
Thank you, Dr. Bhalla. You explained so well. I just wanted to a particular situation, like you are doing cataract surgery, you're still going to put the oil at the end of the surgery. Suddenly pressure started rising. So how you will be able to insert the IOL? In that situation, what should we do? Should we defer, or still we can manage putting IOL?
I think, yes, I just briefly covered that intraoperative rock hard eye syndrome, where sometimes what happens is there is inadvertent, particularly in hypermetropic eyes, the BSS may leak through the zonules posteriorly, causing, then it becomes really very difficult. Either go slow, try to reposit the iris with cohesive viscoelastic through the side port, not through the main incision, and try to insert the IOL. You can also give intravenous mannitol 20%, you can give a bolus dose of 20 cc right then. And even after these measures, if you are not able to do, please don't struggle, don't try to push in the IOL, wait for some time. You can put a suture, close it, and take up the patient again after 2 to 3 hours, either on the same day or next day. Nothing is going to happen. Main thing is that the IOL should be inserted without any complication. Visual gain is more important than your completion of the surgery in the same sitting. I think be patient. And the one thing what I want to tell in phacoemulsification in normal patient is different from phacoemulsification in glaucoma patients. So you go slow, lower down the parameters, lower down the bottle height. So slow motion phacoemulsification is very important technique to be undertaken in these glaucoma patients.
Thank you, Dr. Bhalla, for your excellent explanation.
Thank you.
Thank you, Dr. Bhalla. Thank you very much. And now our next speaker is Professor Rohit Saxena. Yes, ask something? Okay, in the meantime, I'll just call him up. And Dr. Rohit is going to talk on binocularity post-cataract surgery.
This was an excellent talk by Dr. Bhalla, but basically this reminds us scenario of Dr. Sonsung Harry's recent advances in the blood supply of the optic nerve head. We know the optic nerve head is supplied by the posterior ciliary artery, which is a branch of ophthalmic artery, which in turn arises from the first branch of intercarotid artery distal to the cavernous sinus. So any condition which will interfere with the blood supply of the posterior ciliary artery will not produce changes only in the choroid, but in the epiphyllary choroid, characterized by the cavernous degeneration of optic nerve. So the filling of the blood in the posterior ciliary artery and epiphyllary choroid depends upon the difference of the intraocular pressure and perfusion pressure of the optic nerve head. So basically you have to keep the pressure low. The perfusion will increase the blood supply. This is the basis which Sonsung Harry, who did a lot of work on retinal circulation, is the genesis of ischemic optic neuropathy. Exactly.
So by whole that mathematical calculation was based on the work of Sonsung Harry only, sir.
Retinal circulation first angiography. He did his post-graduation from Punjab, then he was given a fellowship from England, then he was in the Department of Anatomy in Punjab, then he moved to the USA. Great work on the recent advances of optic nerve head blood supply.
I think for everyone who doesn't know, Dr. Gohar Ahmed has come all the way from Srinagar. An excellent comment, sir. Thank you for your comments on this. I think who has a...
Notice.
So one last comment
Dr.
before
RP,
we proceed with the...
Dr. RP, that for this phaco, for this OBD-induced secondary glaucoma, the best thing is to do a hydroimplantation. In the left hand, you are holding the irrigation and implant the IOL through this, and you are guiding the IOL through the left hand only. and it's so simple, faster, and all the drugs for secondary glaucoma, all management is unnecessary.
That's true. That's
Simple
true, Doctor.
hydroimplantation.
Very
Anybody
right.
can do it. Anybody, simple.
Very rightly said, hydroimplantation is a new technique
And
because.
you are doing the same go with the implanting in the back.
But you have to, with the hydroimplantation, the only important point is like you have to practice it very well. And your infusion.
For the phacosurgeons.
Yeah, you have to practice it because not everyone can do the hydroimplantation easily. Because viscoimplantation is very easy because you are not hurting the capsule, you are not hurting the tissues. Thank you, Doctor.
Thank you, Dr. Saha. So now we
Saha,
proceed
for the
with
beautiful comment.
Dr.
Now
Rohit
I'll request Dr. Rohit to please start his talk here.
Thank you, Dr. RP, Dr. Bhalla, the entire DOS executive for giving me the opportunity to talk about binocularity in a cataract session. So we understand that there's a growing need for binocular vision, and we can see that the changing world and changing technology all around us. And the future of cataract surgery, in fact, everything ophthalmological intervention that we're doing, there's actually more to vision than just 6/6 and 6 vision. So this is just visual acuity. We need to actually even look at patients with visual fields, contrast, color, and stereopsis deficiencies or issues which may be actually responsible for a not so happy patient post-operatively. I'll first cover binocularity or stereopsis following congenital and developmental cataract in children, which is very, very important, somewhat covered by Dr. Subhash in his talk. So I'll just talk about this survey article which we published, which was a review, systematic review and meta-analysis of all data that was available in literature, in published literature on outcomes post-cataract surgery in children. We actually went through 272 records, papers, publications, case reports, and we finally were able to include 30 case reports, publications in this review that we did. I'll just run through the key findings of our review which we did. So these were all the analysis that we did about the unilateral, bilateral cataract with strabismus. So this is congenital cataract with strabismus, without strabismus, unilateral and bilateral. So the key understanding that we realized was, of course, these are the mean values of stereopsis that was achieved. So the proportion of achievable stereopsis was more obviously in bilateral congenital cataract versus unilateral cataract, whether it was with or without strabismus. Again, proportion of achievable stereopsis is more in children who presented without strabismus than those who had strabismus to start off with even before the cataract surgery. So strabismus or misalignment presenting at a very, very early age with cataract was a poor prognosticating factor. In unilateral congenital cataract, those children without strabismus, of course, the conventional learning and thinking says that by 6 to 8 weeks we should intervene, but in the entire review found that at 4 months was the major significant difference in outcome. So while in India we are unfortunately not able to get these children early enough, but even by 4 months, if we are able to remove the cataract and put in some form of visual rehabilitation. In fact, at our center, we are more and more aggressive putting in intraocular lenses in infants and younger children because of the ease of early rehabilitation that we can do. So, obviously, pooled stereopsis was significantly greater in children when operated less than 4 months of age and given visual rehabilitation than post. This data, of course, when you compared it with developmental cataract, you found a huge difference. So developmental cataract, whether with or without stereopsis, really did not make a difference. So both bilateral and unilateral did not make a difference in stereopsis outcomes, nor did the presence of strabismus make a difference. So the key factor in this was that they already had developed good stereopsis before the cataract actually broke the fusion, broke their binocular development. So in these children, which were defined as cataract developing after or noticing or being picked up after 3 years of age, the outcomes were significantly better. So the key points were birth to surgical time 4 months was a crucial interval for stereopsis, better stereopsis in bilateral congenital cataract than unilateral. Obviously, stereopsis dropped by almost 10 to 15% in congenital cataracts with pre-existing stereopsis, and no association was found between strabismus and stereopsis and developmental cataract. This is actually another study that we did. This is a functional MRI imaging, and this is the pre-cataract surgery visual rehabilitation, visual pathway from the optic nerve to the occipital lobe, and you can see after visual rehabilitation, you can see the significant improvement in the pathways that we are. I'll again quickly, briefly touch about adult cataract surgery binocular outcomes. These are, of course, part of ongoing studies that we are doing at our center. But again, it's very important to now realize that stereopsis is one of the factors that may be responsible for patient dissatisfaction. Up to now, I, in fact, almost always believed that cataract extraction and IOL is actually reducing accommodation and reduces the binocular vision recovery post cataract surgery. However, one would say that over time our understanding is changing. Factors that have affected stereopsis in pseudophakic patients is, of course, age. We realize older the patient, poorer binocular outcomes, difference in visual acuity. So you need to get the visual acuity as good and close as possible, because clearer the image is going to the brain, better the stereopsis. Spherical equivalent differences, axial length differences, pupillary diameter differences also have made a huge difference. And of course, IOL design, decentration, and tilt have poorer outcomes. These are some of the ways which we are testing both for binocularity and for stereopsis. So I'll quickly run through the outcomes that we have experienced till now. Like I said, I up till now comprehensively believed that stereo outcomes in monofocal IOLs is the best both for distance and near, and we have found that 90% of patients have a stereopsis of less than 100 arc seconds, which means better than 100 arc seconds, which is the limit for useful stereopsis. So about 100 is considered useful, and almost 90% would have less than that. And a greater difference in spherical equivalent between the fellow eye is the risk factor for poor outcomes. So therefore, monovision is a poor intervention technique. Please do not think that monovision, allowing a patient to see distance and near simultaneously without glasses, but it's very poor for stereopsis and may be a cause for poor outcomes. EDOF lenses is now again increasingly showing some very good outcomes, and you can see near stereopsis of 50 arc seconds in almost 50% of the cases we've studied, and 90% achieved 100 arc seconds or better. So EDOF is again coming out with very good stereo outcomes, which are nearly comparable to monofocal outcomes. Again, our previous experience with multifocal was rather disappointing, and we did not find them to be useful, but the newer generation multifocal IOLs have again come out with very good outcomes, both for distance and near and intermediate. So about 50 to 100 is the mean stereo outcome. So newer multifocal outcomes, despite the cutoff of the light at different stages, still permits good stereo recovery in the newer multifocal outcomes. So I'll just quickly summarize. Stereo acuity shows a significant improvement after cataract surgery with multifocal implantation, although as of now it is still below normal levels, and probably understandably because of the various factors about image and illumination. Could this actually be a factor in patient dissatisfaction? And although we are achieving better results, but yes, this may be a factor why patients are not so happy sometimes post cataract surgery with multifocals. This is, of course, an indication for future research. So I thank you for the opportunity to be here and present. Thank you very much.
Thank you, Rohit, for the excellent and wonderful presentation. Because this is the subject we all come across in surgical practice, and because these days we have been into more and more into multifocal EDOFs and trifocal IOLs, and because you have to assess the patient before, as Dr. Rohit said, like you have to be very, very sure like which patient is suitable for the multifocal, trifocals, and EDOFs. And Rohit, what are the practical, when you are doing this work on research based, what are the practical points you ask the patient, and what are the practical points patients tell you about the stereopsis and the contrast?
So, of course, contrast is again now improving in many of the EDOFs don't have significant contrast-related issues, at least the ones which we have experienced. But the binocular issues, patients do talk about having difficulty in performing a lot of usual tasks like moving down the steps and their activity. They need a readjustment. We know that multifocal IOLs need a rewiring of the patient brain. So the binocular system is taking time to adapt, and the previous thought that, quickly move in multifocal IOLs in the other eye is an important factor that is assisting, recovery of practical, useful stereopsis and depth perception in these patients. So that's what our experience has been. If you delay it, then the patient dissatisfaction actually is greater as compared to an early binocular involvement.
We are also into a lot of patients where we have a monofocal IOL in one eye and the trifocal in the other eye.
Right.
Do you have some experience with these patients?
Unfortunately, no. In fact, I would say they would not do so well as far as at least stereo outcomes are concerned.
So in terms of stereopsis and in terms of especially the contrast,
yes.
We can be sure how much is the contrast loss with the EDOF and how much is lost with the trifocals in comparison to the monofocal IOLs.
So, of course, not in the same patient, but yes, comparing a group of monofocals versus EDOFs versus multifocals have moderate contrast reduction. EDOFs did not have significant contrast reduction as compared to the monofocals. And as I said, stereopsis, of course, still I would say the best is with monofocals, but EDOFs come very close, and the multifocals also now, our patients are fairly satisfied. We are also measuring them for intermediate stereopsis, and they are performing fairly well.
Any international publication on the loss of contrast with the EDOF IOL in your experience, something very good one?
I can't offhand say, but yes, recently there has been a lot of work on the EDOF as far as contrast is concerned, and even our experience has been fairly good as far as, multiple now studies available with the EDOFs. We had one Rajesh had done with the Indian EDOF lens, the upper lens, and again we had some very good stereo outcomes, and contrast was very, very good as compared to monofocals.
Right.
Thank you,
right.
Dr.
Thank you,
Rohit.
thank you, Dr.
Dr.
Rohit.
One
Thank
more
you very
thing,
much.
especially with unilateral pediatric cataracts, how do you, I'm sure it's an important issue
in fact, yeah,
address.
I would have hoped
and
we had
what,
discussed
what
more on that,
IOLs,
yeah.
what lens you would like to use?
So for children, I would say less than 7 years, I would say don't even think about a multifocal. Always go for a monofocal because of the clarity of vision that a monofocal will provide as compared to a multifocal. As I said about unilateral cataracts, we are increasingly, even in infants, going ahead and putting in the IOL, even at 6 months of age, provided the eye size is normal. So you don't have a small cornea or a small eye which would preclude you putting a lens comfortably.
Yes, sir,
So,
Dr. Bashir, you have some questions?
Sir, recommend. So now that's I think that's a topic, I think, for a huge discussion that is there. But binocular wise, binocularity wise, or I would say that a patient who has a pre-existing misalignment, a strabismus, or was operated for one like that, or poor binocularity to start off with, I would suggest that do not put in multifocals. Patients who have pre-existing field defects, do not put in multifocals, including EDOFs, because we've had experience of patients who had neurological problem, infarcts and all in the brain with field defects, who performed very poorly with multifocal IOLs. So these are clear, definite patients, I would say, are not suitable for multifocal IOLs, including even EDOF lens.
And Thank you, Dr. Rohit. And let's leave the discussion for the lunch.
A patient has multifocal in one eye and monofocal in one eye. Can you go for multifocal in the other eye, or just put the
as I said, we don't have Dr. RP also actually talked about it. I think he may give his experience. He had an experience of a few patients.
So we can continue this discussions over the lunch. Thank you, Dr. Rohit, and wish you all the best for your forthcoming ventures. And we invite Dr. Vinay Garodia for his next talk on PC RENS, anterior vitrectomy after PC RENS. He will be giving practical tips and tricks. Dr. Vinay.
First of all, I'd like to thank the DOS executive for inviting me over to this wonderful event. And I think let me start by giving you a simple Guru Mantra. I think lunch is around the corner. So a simple way of avoiding PC rent altogether, and if you follow it, it would never fail, is don't operate. So if you don't operate, there's no question of listening to this talk, you can start enjoying your lunch. But in case you don't want to listen to me and still you want to doggedly operate, then unfortunately you'll have to bear with me and listen to my talk. So as I say, every cataract surgeon, and this is a topic for cataract surgeons, not for non-cataract surgeons, every cataract surgeon must know how to do anterior vitrectomy and how to give intravitreal antibiotic injections. Because you never know which case of yours is going to be having a PC rent. And if you don't know how to do a good anterior vitrectomy, you have got no reason to be operating cataract surgery. So I think this is a must skill that everyone should know. And the same with intravitreal antibiotics. If you have an end-off, don't wait. Give an intravitreal antibiotic and then refer to us. So PC rent, as you know, is the beginning of most of the complications. The list is endless. I mean, everything kind of starts with PC rent almost. And it also gives you a lot of insomnia and peptic ulcer as well if you don't manage it well. So what is important to remember is that don't be scared of vitreous. We guys keep cutting vitreous right, left, and center all over the place, and these patients do very well. So doing a vitrectomy doesn't spoil the eye. The vitrectomized eyes do very well. In fact, they have better vision than the non-vitrectomized eyes because there's no PC out there, so there's no opacity, so you get a better vision than non-PC rent eyes. But you should know the principles of anatomy and vitreous complications also, because you should not fiddle with it. So don't drag the vitreous, don't cause any tractions. If you know the basics of vitreous, you are safe. Do not act in a haste or a reflex. It's obviously many times you get very scared if something happens. Take a calm breath, be calm, and you'll do well. You have to be ready in each and every case with your instruments. Now, this is very, very important that you and your OT staff should know how to manage PC rent. The protocol should be in place. At that time, you're not going to be thinking what to do. You should be prepared in each and every case for this and have a plan of action in place. So what I recommend is that in your OT, there should be a PC rent kit available. Everyone in your OT should know where those items are kept so that you're not going around searching for it. At that time, the surgeon is in a bad mood, he starts shouting, don't do that. Keep calm. So what you have to keep is keep a sharp and sterile 25 gauge cutter with you. And also keep a new 25 gauge cutter as a backup also. It's not the time to be miserly. If you have a problem, open a new pack. There's no problem. And a new and a sharp 25 gauge trocar, that I'll be talking about the new technique for which you need a new and sharp 25 gauge trocar. Viscoat in case you've got a PC rent and you want to manage the vitreous there. And you should have an inventory of 3-piece IOLs with you. Because in case you have a PC rent, you should have a set of IOLs to be implanted in the sulcus, so that's important. And in case you have got a retina setup like mine, then you should be ready for the drop nucleus also. Then you have a phacophract tip and a handpiece which is ETO'd and kept ready as in sterile position, and a 25 gauge vitrectomy pack. So this is the basic PC rent kit that every OT should have, the top part at least. Now, how to manage is recognize it early, prevent the extension of PC rent, release any undue pressure that might be there. Do not take out the instruments immediately. So don't have that burnt reflex of taking out the instruments. Be there, push the visco from the side port, and then only remove the instrument so that there's no sudden surge, upsurge of the pressure, pushing more vitreous into the anterior chamber. And you do a dry aspiration of the cortical matter. If there's no vitreous loss, check the status of vitreous, and then after that you can implant the PCIOL in the bag or in the sulcus depending upon the situation. Now, So what you have to do is, in case there's a vitreous loss, make sure that the wound is nice and tight. In case you have enlarged the wound, make sure you put the sutures there because you want a nice watertight wound. Use the automated cutter. I mean, every OT should have a vitrectomy machine out there with a working automatic cutter. And do anterior vitrectomy without any traction. So, I mean, these are the basic parameters. You should use moderate suction, maximum cutting rate. Do not use coaxial irrigation. I think that is everyone knows now. So irrigation has to go from another separate port, and the vitrectomy has to go from the separate port. Irrigation, you can use a 23 gauge cannula, and cutter tip should always be visible to you. Don't do blind vitrectomy. So it should be visible, and the cutting tip should be facing anteriorly. So what you do when you have a PC rent, the vitreous tends to come out from the wound, and this basically causes the traction at the vitreous base and the fovea. Now, vitreous base traction can cause a tear, and a foveal traction can cause a CME. So what you have to avoid is any outside traction of the vitreous. So instead of cutting the vitreous at the wound margin, you must take your vitrectomy cutter well through the PC rent into the anterior vitreous so that the direction of the push is into the eye, not out of the eye. If you can follow this basic principle, you will avoid most of the complications of PC rent. Do not pull out the vitreous, push in the vitreous, suck in the vitreous which is coming out rather than pulling it out. So this is a case where the two side ports have been made and the vitrectomy cutter is being used. And for removing the cortical matter, just cut off the vitrectomy and use it as a suction thing to suck out all the residual cortical matter. avoid damage to the residual capsule, complete vitrectomy, ensure round pupil, implant a PCIOL. As it was pointed out by Dr. Kirti, if you can use triamcinolone, that is also a very good option. But if you are confident of seeing the vitreous without that, you can do that way also. So it depends on your comfort, but don't hesitate in using some triamcinolone to visualize the vitreous. Now, what I'm going to be describing is an alternate way that you can handle by using the pars plana route. In this, what I do, I first implant the PCIOL in the sulcus. I make sure the wound is tight. After that, you make a 25 gauge trocar entry, 3 to 3.5 millimeter from the limbus. You do the infusion through the anterior chamber, and you put the cutter through the pars plana trocar. So your cutter is behind the IOL, not in front of the IOL. But make sure you use a sharp trocar, don't do any twisting, and go do the thorough-anterior vitrectomy and the residual cortical removal. So this is one case that I'll show, that this case was operated by my fellow, and you can see that the staining was unequal. And despite that, she went on to do the phaco surgery, and you can see that she could not complete the rhexis, so she converted that into a can opener technique. Now, she managed to do the phaco, things were quite all right, but towards the end of the surgery, you could see that the moment she takes out the irrigation IA handpiece, there's an extension of the PC rent that happens. There's a whole of PC, you can see it now. Now you see the whole PC rent has come up there. Now this is the time when I was called into the OT. I went in, I implanted a Sensor 3 IOL in the sulcus. After that, the wound was stable. I made a trocar opening. Now what you have to see is that when you're going in, don't twist the trocar. Because if you twist the trocar, the valvular entry gets converted to a circular opening, and then therefore the water tightness goes away. Infusion is coming from the side port, and now with the cutter, you are doing the anterior vitrectomy. After finishing the anterior vitrectomy, then you go on to tackle the residual lens matter, which you can just use the cutter off and just peel it off nicely. And at the end of the surgery, you have a very, very quiet eye, and it is still stays a sutureless procedure. I'll just forward it. So this is the end of the surgery. You can see the eye is very quiet. The advantages are you implant the IOL first, so you minimize any further damage to the capsule, avoids pulling the vitreous out, and minimizes the traction of the vitreous base because you're inside behind the lens that you're going. Easy to clear the residual cortical matter, and there is no distortion of the wound and cornea that happens in this particular case. Now, if you have time, I'd like to show one more case. If it's okay. Yeah. So this is another case. This was being operated by me, and it was a very, very soft cataract, and you see there's a PC rent that occurred. So I decided to, here you see I'm pushing the viscoelastic through the side port before taking out my equipment. I formed the AC. I decided to straight away make a trocar entry for infusion. And then I enlarged the incision slightly because of the Sensor 3. It goes in through 3 millimeter incision. I implant the IOL. You note that here the IOL has opened upside down, but I don't care because it's a biconvex lens. So this is the only issue that we had in this. Now you make the 3 ports and you go on with the pars plana vitrectomy. Interestingly, this was my first topical vitrectomy surgery that I did because this patient was under topical and the patient was cooperative. OT was ready. It took me 15 minutes for doing the whole vitrectomy, and the patient cooperated for a topical vitrectomy surgery also. So that was the first for me. It was unintentional, but it happened that way. So here you see I'm doing the anterior vitrectomy. I'm teasing off all the lens matter. All the cortical matter has been cleared up very nicely, you can see. Now you go behind, complete the vitrectomy, and now since the lens, which was very soft, that was the reason for the PC rent, I utilized the same reason to clear up the whole lens by using the cutter alone. And you can see you are kind of eating up the pieces of the lens slowly. And this whole surgery, the vitrectomy part took about 15 minutes, and we could do under topical. And this was the post-operative result of this particular patient. The patient had an excellent vision. So just to summarize, it is best to avoid PC rent, but in case you do have a PCR, if you manage it well, most of the times you will get a very good result. Thank you. I would love to have any questions.
Thank you very much. Thank you, Vinay, for the beautiful presentation and beautiful videos. And this is, I think, one subject which was very important and from the anterior segment surgeon's point of view, because we come across this situation in many a times. And then we land up into what to do, like whether to go anteriorly or posteriorly, because you have shown very nicely, like in one of the cases, you just make a pars plana port and then go inside. So this, how this technique and going through the anterior route has the difference?
So what I do in pars plana, the advantage is I have already put in my IOL inside. So that difficult part is already over, because sometimes when you do the vitrectomy, the eye gets a bit collapsible, it's not very stable. Putting the IOL at that time, then you're scared because you may have damaged more of capsule. Put the IOL in, seal the wound, end the story there. Now you go from behind. One advantage, you're not going to pulling out the vitreous. You'll be keeping the vitreous inside the behind the lens. So yeah, there's no traction that is going to be happening. Second, there's no distortion of the wound that often happens when you're going from the anterior side. The moment you dip in, there's a distortion of the corneal wound that happens. So the whole thing happens in a very, very controlled manner. So I find it very easy, and all it needs an extra step is how to make a trocar entry. If you can manage to keep a sharp trocar with you, one trocar set comes with three trocars. Each complication will use only one trocar. So one set which costs about 6,000-7,000 rupees, you can manage 3 complications very well. So I think it's an investment worth making.
Yeah. In that technique, like what about the vitreous which is already there on the anterior surface of the lens?
So you are basically going to suck it in.
Acha, you suck it out.
Because from the sides of the lens, it's going to suck it in. So rather than, I don't manipulate at all in the anterior chamber.
Right.
You just push in visco, put in the IOL, and then do every vitrectomy after that.
Right.
So rather than sucking it out, you're sucking it in. So that's the beauty of it.
But can the anterior segment surgeon do this? Because we haven't.
I think it's only a mental block.
Okay.
All the anterior segment surgeons are giving intravitreal injections nowadays. Yeah. Unfortunately, they don't give intravitreal antibiotics. That's the problem we have. But they're giving intravitreal injections, all of them. If they can do that, all they need to do is put a trocar. As I said, if you put the trocar, don't twist. Because if you twist, there's a kind of a planar incision that you're making. The moment you twist, you make into a circle.
Right.
Then the wound is going to leak.
Right.
But if you have a sharp trocar, you just go in a single way, it would not leak.
Right.
So, I mean, that's a very small trick we have to learn.
That's good, yeah. Very nice. Dr. Alkesh, you want to say something?
Just adding on.
Any risk of the lens becoming unstable after you've done the vitrectomy or you're removing the lens matter or something? Because initially, once you put the IOL, there's a fair amount of lens matter. It gives you a greater confidence. When you start removing, there is a possibility. I mean, of course, if you have a very nice anterior capsular excess, maybe.
I mean, even if you've got a substandard anterior capsule also, if you're careful about not using the cutter when you're tackling the vitreous, the residual cortical matter, that is a trick you have to learn, that first you finish the anterior vitrectomy, make sure that area is free of vitreous. As long as the vitreous is there, I would not recommend you to be using suction because then you're causing traction. Do the anterior vitrectomy, then you have cutter off, and then just tease off the thing. In that situation, you are very unlikely to damage the capsule then. So therefore, I have never faced it, but then of course, if for a beginner,
Dr. Bhupesh, can you load?
Thank you, Dr. Vinay, for the beautiful presentation. And in the meantime, I will request Dr. Bhupesh to be ready here. And then we'll take the...
So the eye is usually very soft. So the trocar cannula, normally it won't go.
See, the eye normally gets soft after we have done all the interventions in the PC rent. The moment the PC rent happens, if you just leave it there, make sure the wound is nice and wound is secure. If you not enlarge the incision, push in a bit of viscoelastic, it is very, very safe to do that.
In that situation, if the eye is soft, so what? How can we put the trocar?
Push in visco, make sure the wound is intact, and because you are going to be anyway doing the anterior vitrectomy, so pushing a bit of visco is not a problem.
I think Dr. Abhay Vasavda is a very strong advocate of pars plana vitrectomy, and he recommends pars plana vitrectomy in vitreous loss even for anterior segment surgeons. You have very nicely shown it, how it is possible, because
it's very
you're
easy
not
with trocar system coming in. So
exactly, because
easier.
from anteriorly, you rightly said you are pulling the vitreous, whereas you go through the pars plana, you are cutting the vitreous. And judicious use of cut IA and IA cut mode, I think that really helps. Free the vitreous, free the area of the vitreous, only then you use aspiration.
Yes,
I think that is the key.
That's important. So I'm going to reduce my incidences of RD surgeries, but we will do that. Thank you.
I think now we'll invite Dr. Bhupesh. Dr. Bhupesh is a cornea surgeon, and he's going to talk how he deals with the cataract in corneal surgery, along with the corneal surgery. Dr. Bhupesh.
Thank you, Dr. Bhupesh. Dr. Bhupesh is, I think, straight away coming from the airport right to the venue to deliver his talk. That speaks volumes about his dedication.
Thank you, Dr. Bhalla and Dr. Alpi, for allowing me to present in this session. I'm slightly late for my talk. So I'll be speaking on open sky cataract surgery. So as a cornea surgeon, we commonly encounter this situation when we have to remove the lens also along with the cornea. Although we never like this surgery, because it's always preferable to go for keratoplasty and then plan cataract surgery later on. But sometimes you have to do combined surgeries. And in this presentation, I'll be discussing some of the tips and some of the situations where I managed this combined surgeries. So no financial disclosures. So triple procedure is a cataract extraction plus intraocular lens implantation along with PKP. And this is an effective surgical technique for patients with both corneal and lenticular opacities. First described by Taylor in 1976. If we talk about the outcomes of this triple procedure, the studies have shown that the outcomes are good and almost graft clarity is maintained after these surgeries in almost 70% of the cases. And the best thing is about this surgery, patient gets quick visual rehabilitation. So coming to the indications, visually significant cataracts, mature cataracts, corneal perforation with lens plastering the cornea, high vitreous upthrust, ruptured anterior capsule, subluxated cataract, and intraoperative lens damage. In these situations, you have to go for combined surgeries. This is another, again, I've already shown. Third thing. Okay, so coming to the challenges. So what are the challenges in this open sky cataract surgery? The first thing is a difficult surgical technique because you're not confident in doing rexis in open sky because you don't have a tamponade, so rexis run is very common in these situations. Then cortical matter removal is again a challenge because with bimanual it's very difficult to remove the cortex. You get a lot of reflexes and chances of PC tear is quite high in during the cortical removal. Then intraoperative pitfalls are also there. High posterior vitreous pressure because most of these cases are chronic inflammatory cases. There's a lot of inflammation is there. Sometimes cases are perforated, so vitreous upthrust is quite high. Then problem in intraocular lens power calculation. All these corneas are bad. You cannot get K reading in any of these cases. So either you have to go for the other eye. If it is one eye patient, you just have to approximate and put the average lens of 21 or 22 diopters. Then problem in intraocular lens implantation. If your axis is not good, axis extended, lens won't settle in the capsular bag because there is a vitreous upthrust, so you cannot put the lens. And then after all these things, results are unexpected in many of the times. So coming to the pre-operative preparation, we have to look for the lens status before planning the surgeries. If you think that you can skip surgery for a few months, maybe 6 months, then it's always better to leave the lens inside and do it after 6 months because when you do the cataract surgery in second sitting, you can take care of astigmatism also in these cases. If there is any sign of peripheral anti-synechiae, look for phacodonosis or lens subluxation, check for the IL power. If involved eye has a bad cornea, then IL power can be calculated in the other eye after checking the axial length. So intravenous injection mannitol is almost essential in almost all cases of triple procedures with a standard dose of 3 to 5 milligram per kg body weight. I always prefer to use acetazolamide tablets also along with mannitol, at least 2 tablets stat given 30 minutes before the start of surgery. Good ocular massage is essential, although not in perforated cases, but in other cases, always do good ocular massage, soften eye, and then start the surgery. And pupillary dilatation with mydriatic should be done, although many times dilatation is not there in these cases. So coming to this first case, and this is a case of corneal opacity with significant cataract. You have to mark the cornea and then do the trephination as other routine cases of PKP. So I was talking about this step. Rexis is quite difficult with the cystitome. So preferred thing is just give a nick with cystitome and then use the Rexis. Give gentle hydro and you just see the pressure. Lens is automatically coming upside. You don't have to do anything. This is because of the posterior vitreous pressure. Just wait for it and remove it. Simcoe cannula works very well in open sky cases. You can remove the cortex easily with Simcoe cannula. Just keep on pushing the fluid inside the rexis and it will come out. You don't have to pull much. And then lens is implanted. At this step, sometimes due to the posterior vitreous pressure, lens keeps coming out of the rexis capsular bag, then you have to just tap it with the one instrument, dial both the optics, both the haptics, and then it will stay in the bag. Just see how I'm doing. Just tapping with the other instrument, the center part, and lens will stay in the bag. And then keratoplasty is done. Coming to the little bit more challenging case, so this was a perforated case. You can see total corneal melt with the fungal infection, central perforation is there, lens is plastered on the cornea. And in these cases, you know that posterior vitreous pressure is going to be very high. So what is very important is to use the Fleringa ring in these cases. Fleringa ring stabilizes the globe, prevent intraoperative hypotony. You have to put 4 cardinal sutures and then it will stay in C2. And then start cutting. You can see the lens is already popping out of the bag. Just you have to remove it. So always after dialing or after hydro, just wait for it automatically it will come out. And then it is removed and graft is sutured. So many times after almost all precautions, you land up in situations like this. So this was a case of repeat keratoplasty. And as soon as I did the trephination, I removed the corneal button. You can see there is an absorbed lens. This was a traumatic case, and this is absorbed cataract. And as soon as I removed the cataract, the whole vitreous has come out. So there was a expulsive hemorrhage. So we should avoid these situations. These situations are really scary, but you'll end up in these situations also sometimes. So always try to close this thing and with your hand or with the corneal button and just wait for some time to blood to settle down and then do it. So in this case, the pressure was so high that I was not able to close the wound, and I tried with 10-0, but it was breaking, so I used 2-0 silk and just waited for some time. You can see here, and then I replaced with 10-0 sutures. So this is a novel technique where they do the core vitrectomy in such cases to reduce the intraoperative pressure, and this works very well in all perforated cases of combined surgeries. So this is the last part of my presentation, the small pupil surgeries. So as in cataract, we encountered the small pupil, but in triple procedure also we commonly encountered the small pupils. So we use the same device as cataract surgeons like Malligan ring and Zepto devices. These works very well.
You'll have to summarize.
I'll take
Summarize.
Yeah. 1 minute more. So this is a very good device, and the role of Malligan ring in these cases is it reduces the posterior pressure and just hold the capsule and give you sufficient dilatation also and reduce the pressure also. So this is a small clip. You can see the pupil is not dilated, and I use the Malligan ring. And the surgery becomes very easy after putting this device. You see the bulky brown cataract, and you can nicely put the lens in the bag under direct visualization, and then remove the Malligan ring. And this is the last thing. This is a Zepto device. This also works very well in all small pupil cases in open sky, and this makes the fixed automated rexis. So this was the case. You can see this is a corneal scar after removing the button. The cornea was non-dilating. I tried with the visco, but it didn't dilate. Then I used Zepto. What you have to do is just go behind the iris without damaging it. centered the Zepto device on the lens. And once you're sure that you are behind the iris, just press the button. And the job is done. So it makes the surgery very easy in small people, open sky surgeries. And then graft is placed. So this is another interesting thing, and you can see the nice rhexis margin. So you cannot see anything, but you can get the good rhexis with this device. I published this paper also, and so in therapeutic cases, we should avoid cataract surgery along with therapeutic keratoplasty if we can avoid. Rate of postoperative inflammation is very high in all therapeutic cases, and increased IOP is there. And if you land up in PC rent, then chances of endophthalmitis is again there. So cataract surgery with DSEC, in few cases we have to go for combined surgeries like with DSEC as well as cataract surgeries. We should avoid PC rupture in these cases, otherwise lenticular attachment can be a problem. So in conclusion, triple procedures are good and safe surgical options in all the preoperative and intraoperative precautions are well taken. Zepto and malignant ring are useful tool in cases of small people open sky cataract surgery. Thank you.
Thank you, Bhupesh, for the wonderful presentation with beautiful videos. Thank you very much. And now, because of the time constraint, we'll go ahead with the second session is now a quiz. So along with the quiz, we'll start the lunch also. So those who are going for the lunch, they can go for the lunch also, and those who are here for the quiz will stay here. And then at 2 o'clock, we have a very, very important session, Science Behind the Art, and that is going to be a very interesting session. So please be here with us, and thank you very much for being with us here in this beautiful session. Thank you very much. Thanks a lot.
I think you've gained knowledge in the first session. It's time to gain some hard cash also, and it's going to be fun. Good mixture of scientific and fun questions. So I'll request all of you, lunch is also there, but enjoy the quiz also. So all of you kindly stay back. We are just going to start with the quiz.
voting pads, you can exchange with that. With that, I request Dr. Bhalla to start his questions. Thank you very much.
करो क्वेश्चंस निकालो ये तो किसके सिस्टम में क्वेश्चंस का इसी में तो थे
वो लगा है, वो चल रहा है
कहाँ पे
ये ऑडियंस वाला है जो मैं प्ले कर रहा हूँ, ये अभी नहीं चल रहा है,
तो वो
इसको बिल्कुल टच मत करना,
वो लैपटॉप का तो लेके आना
वो प्ले करेंगे, ए भी विल प्ले ना,
तो उसको बोलना अमन को कर क्वेश्चन शुरू कर
Aman, you can start the questions.
There is no negative marking.
There will be negative marking if you counter the quiz masters. Quiz masters are always right.
Yes, quiz master decision is final. So we start with the quiz. The first question is, this ICL has holes. What is the size of the central hole? The choices are A 336 microns, B 306 microns, C 360 microns, and D 330 microns. Start the timer, Aman. Aman, timer. So the time is up. Let us see how many of you have answered correctly. Can you just show the chart, Aman? So 94% have answered it correctly. I think.
You can adjust the screen size. Make it a little bit up.
Just adjust the screen size. I think this was, Aman, no need to show it now. We'll show it after leaderboard, after 10. So the answer was indeed 360 microns. Let's come to the second question, Aman. This great individual, can you diagnose his eye disease? A. Louis Braille, one eye trauma and the other eye sympathetic ophthalmia. B. Louis Braille, both eye trauma. C. Helen Keller, both eye ROP. And D. Helen Keller, both eye trauma. I think this was an easy question. Most of you would be answering it correctly. Let's see how many of you have answered it correctly. Yes, Aman, show the next. Yes. Oh, great, great. I think I have started with easy questions. Most of you are able to answer it. 74% have answered it correctly. Yes, indeed, this fellow is Louis Braille, and he suffered trauma in one eye and he lost second eye because of sympathetic ophthalmia. So I think great start to the quiz. You are all going to be richer after you leave this hall today. So let's come to the question number 3. Regarding the layers of the choroid, what is true? A. The inner layer consists of connective tissue containing melanocytes. B. The inner layer contains branches of short posterior ciliary arteries. C. The capillaries of the middle layer are lined with fenestrated epithelial cells. And D. The basement membrane of the RPE is a constituent of Brooks membrane. Start the timer, Amar. This is a question of anatomy. I think most of the residents should be able to answer it correctly. So let's see what the scoreboard is. So yes, the basement membrane, the correct answer has been given by, Aman, you are not showing it correctly. The basement membrane of the retinal pigment epithelium is a constituent of the Brooks membrane. That is the correct answer. I think we can ignore this. He is not showing it correctly.
No, no, he's showing correctly, sir. D है ना answer.
हाँ, but दोनों green दिखा रहा है ना?
No, no, it's not
C भी
green.
दिखा रहा
The
है.
blinking one is right.
Okay, blinking one. So the basement membrane of the retinal pigment epithelium is a constituent of Brooks membrane. D is the correct answer. So again 75%. I think, Praful, next time I have to come with more difficult questions. Again, it's based on a personality. Stevie Wonder, we all know who he is. He was blind. Can you name the disease? A, primary open angle glaucoma. B, proliferative diabetic retinopathy. C, ROP. And D, age-related macular degeneration. So let's see what the scoreboard is for this question. Yes, he was suffering from ROP. And anybody from the audience who can tell one of his famous number, he'll also get a prize.
What number?
Stevie Wonder. No? No take us for chocolate? Okay, we increase it to pen drive.
What is the question? So Dr. Gagan answered it.
I love you. I love you. I just called to say I love you.
Dr. Gagan. Okay.
So who is the winner
Nobody
of chocolate?
Nobody. They are so focused on the questions. They
Give it to Gagan, Dr. Gagan.
give one chocolate to Dr. Gagan, please.
Is it a chocolate or something else?
No, it's something big. Gagan, you have to open it and see. But open it outside. Okay. Now let's have the next question. The poor candidates for refractive surgery may include A, pathological myopia, B, keratoconus, C, history of HSV keratitis, and D, all of the above.
Timer.
So let's see the scoreboard. So you see how gentle the quiz masters are. We want all of you to be winners. So 93%, more than 90%, I think almost all of you have answered it correctly. It includes, all these are contraindications for refractive surgery. They are poor candidates: pathological myopia, keratoconus, and even history of HSV keratitis. Next, come to the next question. Latanoprost Bunod 0.024% is a recently approved glaucoma medication. It belongs to which class of drug? A, prostaglandin analog. B, ROCK inhibitors. C, adenosine receptor agonist. And D, nitric oxide donating moiety. Start the timer. I expect another score of more than 80% in this also. Let's see. Am I right? Why? I think this was a very, very simple question. Only 36% of you have answered it. Okay, next, let's go to the next question then. 100% sulfur hexafluoride expands by how many times over 48 hours? A, 2 to 2.5 times, B, 3 to 3.5 times, C, I think this is 4 to 4.5 times. It is, please take it 4 to 4.5 times, and D, does not expand at all.
So AD is excluded. AD is excluded.
So let's see the scoreboard again.
Answer. Okay.
Yes. I think 57% of you have answered it correctly. It does it.
It should have been
indeed.
100%. Sir had already given you a clue.
So
B is not.
Yeah, 57% of you have answered it correctly. Even if you don't know the answer, you could have guessed it. The clue was given. So let's go to the next question. During a complicated cataract removal case, the lens and capsular bag were both removed and anterior chamber lens was placed. The first day post-operatively, IOP is 50 millimeter mercury, iris is bowed forward around the intraocular lens. Which of the following measures would be most effective to manage this case? A, topical glaucoma medications and close observation. B, laser peripheral iridectomy. C, increased frequency of topical steroid. And D, paracentesis to release aqueous fluid. Your timer starts now. I think this was a practical but very simple question. I expect more than 80% again answer in this. Let's see the scoreboard. I expected better response. See, the peripheral and the iris is bowed forward around the intraocular lens. This can happen. It is sort of iris bombay. Why it is occurring? Because of pupillary block. So to relieve that, what do you need to do? Peripheral iridectomy. So laser peripheral iridectomy is the answer. Right? Okay. Let's go to the next one. A 35-year-old lady with a history of Stevens-Johnson syndrome and severe dry eyes present with bilateral corneal grafts that have failed twice in both the eyes. Her eyes are extremely dry. Her visual acuity is counting fingers in both the eyes. B scan of the patients reveal no posterior segment abnormality. What would be the best treatment for this lady? A, PK. B, osteodontokeratoprosthesis. C, phototherapeutic keratectomy. And D, EDTA chelation and scraping. It's a difficult question with simple answer.
Answer.
Let's see. Show the scoreboard.
Okay, 100%.
Okay. There was nobody who could not guess it correctly. Right. Only the terms are difficult. Answer is very simple. Let's go to the next one. A 2-year-old girl presents with bilateral severe ptosis with obstruction of both visual axes. Her eyes are set far apart. Her father has similar features. What is the most efficacious surgery for this scenario? A, aponeurotic repair. B, frontalis suspension with silicone rods. C, levator LPS resection, and D, frontalis suspension with facial sling. Start the timer. Next में आ जाओ. एक और. So let's see the scoreboard. Okay. So you all are doing very well. I think you people have come prepared. So frontalis suspension with facial sling is the answer, and 60%. So about 2/3 of you have answered it correctly. Great. I think great going by all. Let's give a big round of applause at the end of the round 1.
It's 10 questions. So can we have the scoreboard? Aman?
Please show the scoreboard and let's see who are the top winners in this first round.
Is it possible, or we should? Nahi. So okay, we move on to the next question.
Let's move to the second round, to be done by Dr. Sandhya Makhija.
Thank you and great going by everyone. So next, quickly come to the next question. The most likely outcome following inadvertent suturing of orbital septum into subcutaneous tissues while repairing a partial thickness eyelid laceration is A. Ectropion, B. Lid retraction and down gaze, C. Entropion, B. Blepharoptosis. Timer, please. So let's see the scoring. Okay, most of you all have got it probably right. Answer is B, lid retraction in down gaze. So almost 58% people have done it correct. Great. Let's go to the next one. So, which of the following regarding onchocerclasis is false? You have to say which is false, okay? Onchocercae vulva is like little twist up. Is transmitted by the bite of Simulium black fly. Skin findings are rare in this condition. C is microfilaria may be seen swimming in AC and may induce an anterior segment uveitis with glaucoma and cataract. Chorioretinal optic atrophy is common in advanced disease. Timer. You must have seen these cases of onchocerciasis. You have to say which is false. Okay. Let us see the score. Okay, well done. 85.7% people have said B, and the answer is B. Skin finding is not rare in this condition. So well done. Let's go to the score. Are they showing the score? No, okay, so we will see the final score later on. Okay.
Move on to the next question.
Next question. Long questions. There are 4 anatomic regions in the anterior optic nerve. Which of the following regions is incorrectly associated with eye? Option A, superficial nerve fiber layer supplied principally by recurrent retinal arterioles from the settle retinal artery. B, prelamellar region supplied by branches of short posterior artery, ciliary arteries and branches of circle of Zinn. C, lamina cribrosa region supplied by branches of short posterior ciliary arteries and branches of circle of Zinn-Heller. D, retrolamellar region supplied solely by branches of short posterior ciliary arteries. Question of anatomy. Hope you have brushed up with your anatomy. And I'm totally out of anatomy now. So let us see the response and let us see the correct answer. Okay, the correct answer is D. Retrolamellar region supplied solely by branches of short posterior ciliary arteries. And I'm happy to see most of you have got it correct.
Because retrolaminar region is also supplied by recurrent pile vessels. Na? So this is the incorrect association.
Yeah. For me,
Next.
actually, I would think it's a difficult question.
Next
This anatomy
question.
and all is totally out of head now. So great, wonderful. So let's go to the next question. The site of origin of neural impulses leading to leftward pursuit movements is A. Right frontal lobe, B. Left frontal lobe, C. Right parieto-occipital lobe, and D. Left parieto-occipital lobe. This I think probably you would know. Let's see the timer. Origin of neural impulses leading to leftward pursuit movements. Okay. Hope you all done correct. Let's see the response. Oh my God. What a similar response of all. So anyways, the correct answer is D, left parieto-occipital lobe, and we have 34.8% people with the correct answer.
In pursuit movements, always stick to your side. Left is left, right is right.
Okay. So going to the next question. Identify this device. This must be very easy. Type 1, Boston Kypro. Type 2, Boston Kypro, LVP KPRO, or Dolman Type 1 KPRO. You must have seen this device in your OTs. Just think correctly and identify. So hope you have identified it correctly. Let's
Wait. You can put this to the audience.
Audience, okay. Let's see
Anybody
how many
from
of
the
you
audience?
can identify it.
Anybody from the audience can answer this question?
How many
You'll
of
get
you,
very
if
good
anyone-
prize.
Anyone?
Who can
Dr. Arvind, sir.
identify?
हाथ तो उठाओ.
घबराओ नहीं, बता दो.
Type 2.
Why? What did you see? Why this is type 2? Not
This
type
is
1. So
stem.
there is a stem.
Stem,
Okay, so
yes,
that will. Okay, give her one chocolate.
And a clap.
Puneet.
Dr. Arvind also answered it correctly, yeah. He also gets
Doctor?
one chocolate. Two
Dr.
chocolates.
Arvind, so 2 chocolate. Bhalla sir missed all the audience questions, so now we can generously distribute chocolates. Two chocolate. One to Dr. Sainaz, one to Dr. Arvind sir.
Yes.
भागो माइक्रोविजन.
माइक्रोविजन
तो खड़ा
तेजी से भागो एक
दौड़
बीच
के
में.
देना. हाँ, वहाँ पे. Yes. Next question.
So going to the next, everyone sharpen your
So इसका
brains and
इसका response तो दिखाओ.
get set for the next question.
So this stem is for to bring it out through the skin, no?
Indication of this device. Uveitis, dry eyes, CME or DME, A, B, C, D. Timer. Timer, please.
CME means
Indication.
cystoid macular edema, not DOS CME.
नहीं समझ में आया. Think.
Answer.
Let's see the answer. How many of you have clicked correctly? Okay.
Okay, these are classical punctal plugs, okay.
54.2% only.
Punctal
I
plugs
guess-
are used for dry eye. Of course, you.
This was easy. I mean, different views were shown, but okay. Many of you probably couldn't correlate. Anyways, confused.
Next question.
Let's go to the next one.
That's the explanation.
1.5 full rotation of Hesburg-Baron vacuum trifines will cut how much?
Timer, fast.
0.126, B 0.300, 0.380, D 0.105 mm. For those of you who've had your posting with retina consultants. 1.5 full rotation
Okay, audience.
will cut how much vitreous?
Anyone from audience? Anyone? Yes.
380.
380 mm.
380. Why?
Because one full rotation cut around 250 micrometers. So
Okay.
375 it will be around.
Okay. Right answer. Give her a chocolate.
Give her chocolate.
Introduce yourself. You are?
Dr. Priyanka from UCMS Hospital.
Dr. Priyanka from UCMS. Okay. It ताली तो बजा दो. Give her a round of applause. Next question.
Great. Let's go to the next one. Indication of this technique. Ptosis, Marcus gun jaw winking, congenital MR palsy, dry eye. What is this technique shown here? Indications. Okay, done. Let's see the score, the answer. Oh,
Okay.
not many people.
Anyone
could
from the
say.
audience? What is this technique? No edge. What is
The
happening
answer
here?
is D, dry eye. Now, what is this?
Neuronotinization.
What?
Neuronotinization. Sural nerve implant is given.
Neurotization. Okay. Thank you.
Great. Give him 2 chocolates here. Great.
Okay, so no, it's a penultimate round that I am going to conduct. Can we have the next question? Okay, see this drop? What is this mechanism of action? It increases the reflex tear secretion, it increases the basal tear secretion, it corrects neural damage, or it provides growth factor. This is the FDA approved drug for some indication. How does it act? Timer? Okay, anyone from the audience? Only one. Usko do.
Give chance to others. Anyone wants to volunteer?
वही तो
यार ये
Answer
टेबल
is
पे
B, increases basal tear
प्रफुल्ल तेरा
secretion.
आरपीसी क्राउड एक ही टेबल पे बैठा है इनको 2
Answer
टेबल
is-
पे बिठाओ.
Increases basal tear secretion.
Why? Why not reflex? It's a nasal spray.
N-acetylcholine, it acts on the N-acetylcholine receptors.
चलो ठीक है. Okay, right answer. Give her a chocolate. Next question. So the 3 focal points. See this IOL. What are the 3 focal points that this IOL offers to the patient? For near 25 centimeter, intermediate 60 and infinity. Near 40, intermediate 75, then infinity. Near 35, intermediate 75 and infinity. D near 40, intermediate 60 and infinity. Timer please. So there are 3 focal points for this IOL. Response? Okay, so answer is D. Okay, next question. So this is Alcon Panoptics trifocal. So it has 3 focal point. For nearest is 40, intermediate 60, and then for distance is infinity. Next question, please. Okay. The FDA approved concentration of pilocarpine hydrochloride to treat presbyopia is it 1.5%, 0.15%, 1.25 or 1%? Timer? Okay, I think we can take this question to the audience since this is related to cataract. Anyone? Not from that table. Dr. Bhalla has something against you people.
Please, please.
So he won't allow you.
It's 1.25%.
1.25.
25. 1.25.
25. Are you sure? Show the response, please. Even I have forgotten.
0.15.
The C is right, 1.25%. So this is the FDA approved drug. You know, there are a range of concentration that have been used for presbyopia. But this drop, which is approved by FDA, is 1.25% pilocarpine. So we can move on to our next question, please. Okay, you can introduce yourself if you have a mic.
Please give mic to her.
Sir, I'm Dr. Srishti from Army Hospital, RNR.
Thank you, Dr. Srishti. Next question, please. Okay, it's there. See what's going on here. See this image. What is being done here? Is it somebody performing convo scan? Is it a keratoconus management protocol? Is it somebody doing VR surgery using a biome? Or is it a treatment for myopia? Timer. Okay, so let's take this question to audience. Anybody from the audience, what is this procedure is known as and for what disease this is used? See the shape of the cornea before and after. Wait, pointer is not working, yeah?
So what is the choice, sir, of A, B, C, D?
Okay, what has happened to the shape of the cornea before the procedure and at the end of the procedure? So cornea is getting flat. So in which disease flattening cornea will help you? It's myopia. So this is basically orthokeratology, okay? So in orthokeratology, put a contact lens overnight. In the morning, the cornea will become flat. So that will help in myopia treatment. Okay, response?
They are put during night, they cause corner reshaping. Reshaping.
So give one chocolate to sir. Sir has explained this so nicely.
And in the morning, the myopia gets disturbed for a couple of days. It is also said that, not said, it is proved, that it regresses the progress of myopia by 40%. I have seen this procedure being done at Kellogg's Eye Center, USA, Michigan.
Thank you, sir, for that information. Please give a chocolate to sir. Next time we may invite him for the quiz master. Next question, please. Okay, see this image. This is the interpretation of one investigation. What is the maximum visual field that you can evaluate with this instrument? Is it 30 degree? Is it 60 degree? Is it 10 degree? Or is it 5 degree? Timer. Response? Okay, most of you could guess it correctly. This is basically microperimetry, right? No, most of you guessed wrongly. So the maximum visual field is 29 degree that it can assess. So right answer would have been 30 degree. Next question. Okay, see this image. Okay, so please see on the right side of this, and what would be the Arden's ratio for this patient? Is it 0.38, is it 2.58, is it 1.29 or is it 1.26? Timer. यार अमन ये म्यूजिक कहाँ से लिया तुमने? किसी मंदिर से लिया लग रहा है.
Can you keep it audience? No.
Yes. We can. Dr. Bhalla wants to take this to the audience. Audience, please. Anyone?
Or they will answer it. See, it's a very simple question here. Please.
Anyone from the audience?
B 2.5.
Why do you say so?
Sir, amplitude 12.4 divided by 4.8.
Okay, that's the right answer.
Give,
right?
give him the chocolate.
Introduce yourself.
So it is light
Dr.
peak
Yogesh
divided
from
by
PDM.
dark trough. So you can see it is 12 divided by almost 4.8.
Next question. Okay, see this, and the logo stands for which of the following? A, NPCB, B, WHO, C, IAPB, D, Site Life. Timer, please. Response? Okay, this is the logo for WHO. I thought all of you will answer it correctly. Anyway, next question. Okay, the pathogenesis of Wesley ring. Wesley ring, you know, this is the immune ring. That involves which of the following? Is it A, the complement system, B, the T cells, C, NK cells, D, B cells? Timer. So immune ring basically, right? Okay, responses please. So perfect. This is the complement system that is involved in formation of this ring. Next question. Okay, the following structure is not involved in Bittis corneal dystrophy, crystalline dystrophy, right? So is it A, retina, B, cornea, C, sclerosis of the choroidal vessels, or D, optic nerve? Which of the following is not involved in this Bittis crystalline dystrophy? Timer.
The full and difficult questions you have to give clue also here. Please read his expressions also when he is asking difficult questions. That's why he's turned his face.
I think you people can sit here. Sir is already answering all of them correctly. Response?
Not in.
Okay, so D is right answer. I think sir has already answered this. So you can give him one chocolate or one of his friends because he has already got one.
Because other friends are really motivating him, sir.
Yes. Give him a round of applause. It's not the resident only, it's senior people are also answering so nicely.
It's
so
really
good to
great.
see. Next question. Okay, this is probably the last question of my round. See this, what is the right sequence? Is it halos, glare, starburst, or is it glare, starburst and halos, or is it halos, starburst and glare, or is it glare, glare, glare? So when you, once you put multifocal L, this problem may occur. So what is the correct sequence? Timer please.
Are we also eligible to get chocolate?
President sir can decide. So response, we can ask this to audience, I guess. Anyone from the audience?
Yes.
Sir is saying B.
Sir,
Okay.
B, glare, starbursts and halos.
Sir has already got one. Sir, too much of chocolate is not good for you, sir.
Please?
B, glare, starbursts and halos.
Okay, first sir answered B, then you B. Your answer is?
So B,
B.
glare, starbursts and halos.
B. Okay, so first, second, third, three B's. Response? Okay, B is the right answer. So
B is the right
please give sir a chocolate because he's the first one to answer this. Puneet, bhag ke aao.
And Praful, 2 chocolates on the dais also.
Please give sir a mic also to introduce.
Chocolates on the dais.
Microvision, see, you are not giving anything to the persons on the dais.
We are
President sir
taking
is
note of it.
Asking for a chocolate. अब तुम देखो अगला क्या sponsor करोगे. Next question.
Who answered this question? Glare and halos.
Sir, introduce नहीं किया क्या? पुनीत?
Introduce.
Yes, sir. Mic दो sir को.
साहा तुमने बताया? What is the difference between glare and halos? How did you answer? Anyone can tell from there
I
the
saw
difference
thing.
between glare and halos?
Glare dazzles you, and halos are around you see the things, and the photographs are very clear. And whoever takes a photograph, he knows what is glare and what is halo.
So glare is a dispersion of light, and halos is the
circle. And anybody who
what you
takes a
call
camera
photo-
and knows that this is the glare.
aura. Yeah.
Okay, see this image, and what is your diagnosis? Most likely this cataract is because of uncontrolled diabetes mellitus, surgical trauma, intravitreal injection, or is it a phacomorphic glaucoma? You could see that intermittent cataract. Timer? See the photo carefully.
Intravitreal injection.
Okay. How many chocolate do you have left with?
I think chocolates are there or gone.
Puneet, how many chocolates are left? 5 only. Okay, then we are not going to give any chocolate for this, but anybody from the audience? Surgical trauma. Why? That's the right answer. Okay. Anyone?
Like a rosette form.
See that there is a hole. You see?
There's a hole in the anterior capsule.
And there is an outline of some phakic IOL. If you
Yes,
see carefully.
linear mark is
Yeah,
there.
so this is the phakic IOL induced trauma during surgery, and that led to this intermittent cataract. Thank you. I think next round will be by Dr. Alkesh. This is the last round. Okay, so play it cautiously. And sir has prepared very, very tough questions for you. So don't use Google. And I could see few people are searching in Google. Google is not going to help you. Thank you very much.
नहीं ऐसे नहीं ऐसे
So for excellent conduct of quiz and everything, Microvision want to facilitate our president, sir.
Sir, 1 minute. 7 questions. So first question, what is the most common type of collagen? in
Alkesh, एक
vitreous?
minute. This is a chocolate to be given to our president, but it will be shared by all.
I'm not sure.
Yes. Continue with the questions, Dr. Alkesh.
Yeah, timer on. What is the most common type of collagen in vitreous? Yeah, display the answer. This is mainly for the participants. So, correct. This is the correct answer. So, most of the people have answered correctly. So, type 5 and 11, they form the core, and 9 is the outermost. Next. What is the typical of optic neuritis associated with neuromyelitis optica? Painless vision loss, longitudinal extensive optic neuritis, bilateral enlargement, and younger age.
The press on the pad, sir. Voting pad.
Yeah, time over. Answer, please.
The answer is B.
Yeah.
Really, questions are tough.
So most of the people.
Sir, correct
Answer-
wrongly. It's
Huh.
19%
Answer
only.
is B.
19, only 19%
only
have answered it
19%.
correctly.
So long segment of the optic nerve are involved, involving the intraorbital, intralenticular, and intracranial parts. This is very typical of NMO optic neuritis. Next question.
Next question.
Next. The most common quadrant for the branch retinal vein occlusion is
Timer.
Start the timer. Can we have this as audience question, Alkesh? Okay, okay. No, this is competitive question only.
Yes, answer please. So answer is C. So most of the people, anybody can explain the reason why like this? Yeah, please.
Maximum arteriovenous crossings are present in this quadrant.
Pardon, sorry?
Maximum arteriovenous crossings are present in this supratemporal quadrant.
Most common, correct. Yeah. So next question. What is the absorption wavelength of light for fluorescent sodium? Yes, answer. So lot of people answer well. That's good. Next question, fifth.
Response?
Yeah.
ये timer
Not coming.
क्या है?
This is a Mizo Nakamura phenomena is seen in. No, this is not the question.
ये क्या हुआ? ये glaucoma drugs are.
Sixth question, please.
Which of the following
Next
anti-glaucoma?
is the seventh. Next question.
Okay, you can ask this question first. Ask this question.
Yeah. Caution with Fuchs endothelial dystrophy. Which drug?
Please press the buzzer. Please press the buzzer. These are all competitive questions, no
With
audience question.
Fuchs endothelial dystrophy. Which drug to be used with precaution?
Next question.
Yeah.
Yes,
So
this is
next
the
question is Mizuwa Nakamura phenomena is seen in which of these? Yeah, that's good. Anyone can explain this phenomena? Anyone can explain this phenomena? Yeah, please.
Congenital night blindness.
Shine the light from the temporal side,
Congenital
then
night
it-
blindness with atypical pupilla, basically described by a Japanese ophthalmologist, Okaji's disease.
Next question. Pardon? Answer is already there, given. A. Oguchi disease. So next is Kohler's sign is associated with pituitary adenoma, optic nerve meningioma, pineal gland tumor, and frontal lobe tumor. हाँ बस answer please. Oh, few people answer. So the people who answered correctly, can somebody tell what is this Kohler sign?
Sir,
He will
Because
get a,
of pinealoblastoma, the Perinaud syndrome occurs and
oh, that's fine.
convergence.
What is color sign?
Sir, convergence retraction
No.
nystagmus.
Anyone else? Anyone else? You will get a special chocolate.
Sir is going to give you a special chocolate, dekho.
Anyone?
This is large size, you will get a double XL chocolate.
Yeah.
So lid retraction.
No, that is not a complete answer. It's a incomplete answer. Can you just complete the answer?
So lid retraction in up gaze.
Somebody said lid retraction in
Up gaze.
up gauge. Is it right?
Upper
मुझे नहीं
lid
पता.
retraction. Okay.
Upper lid. Okay.
That's fine. Yeah. Upper lid. Thank you.
So so we completed all the questions for the number 1, 2, 3. Now there will be 10 fun questions. Okay, this will be addressed to all of you. Anybody can answer, and the first 7 will get pen drives, and then rest 3 if chocolates are left, then they will get chocolate. Okay, so there will be 10 questions. In the meantime, they will compute your score, and the results will be announced. Okay, so can I have my PPT, please? Yeah, so first come first. So you can fight among yourself to get the mic. Whoever catches the mic, he can answer this. So see this image. Identify this person. No, you have to raise your arm.
Go ahead.
Somebody please go with your mic.
Rahul Gandhi.
अरे माइक्रोविजन बाद में खाना तुम लोग
Rahul
सारे गायब हो
Gandhi.
गए। Mic
Rahul
तो दिखाओ।
Gandhi. Rahul Gandhi.
किसने बोल दिया? किसने बोल दिया?
Sir, answer दे दिया sir. Rahul Gandhi.
No, it's up to our president sir. Sir कौन आंसर करेगा इसको बताइए।
तो आंसर हो गया सर। Sir.
Microvision, please take the mic and go to anyone you wish for. It's up to you. Please go to this side. These people are already participating in scientific quiz. Yes?
It's Rahul Gandhi Pappu.
But sir has already got one. Anybody else?
Pen drive.
So this was a chocolate question.
Sir, pen drive.
Rahul Gandhi.
Yes?
Rahul Gandhi.
Gandhi. Sir.
Rahul Gandhi, okay. You can come and collect your pen drive. Pen drive, please. माइक्रोविजन यू प्लीज बी अलर्ट है ना जो पहले हाथ उठा रहे उसके पास जाओ तुम वहां दोनों खड़े हो अरे यहाँ पे वो तू अपना ही अवार्ड उधर दे रहा सेक्रेटरी को देने दो भाई चलो नेक्स्ट क्वेश्चन प्लीज सो हु इज दिस टेल अस द फुल नेम ऑफ दिस पर्सन एनीवन एवरी डे यू सी हिम अभी देंगे फुल नेम प्लीज नोबडी इज हियर फुल नेम डॉक्टर वेयर इज डॉक्टर बाली आई वाज एक्सपेक्टिंग हिम टू आंसर दिस माइक दो ना माइक्रोविजन वाले क्या कर रहे हो तुम Vladimir Putin, Bhupesh. You are making a hybrid of Putin and okay. You can give it to him. His name is Volodymyr Zelensky, okay. He was basically a stand-up comedian. So this was the day when he was doing comedy. Okay. Now see, yesterday only this gentleman, he became the 7th richest from 4th richest because of one report. So this is like fill in the blanks. This was the agency which gave some report.
Hindenburg.
Full
Hindenburg.
Spelling.
Hindenberg.
Slow, sir, slow.
E. Junior E.
HIE, then?
Hindenberg.
HIN you said, right? Anybody? Who is saying HIEN?
HIEN.
Sir, HIEN.
HIEN.
So it's HINDENBURG. Give it to Dr. Bali, please.
Or give me the 1 lakh crore, yaar. That's more important. It's poorer by 1 lakh crore, yaar.
You have to invest in share market for that.
Okay, that's the prize money.
Okay, identify this person. He is also recently in news. Rohit Saxena, sir, please. Dr. Rohit Saxena, ko do. He's Elon Musk. Okay. Now, see this movie. Okay.
Tom Cruise.
So
Tom.
who is the director of this movie?
Top Gun.
The director of this movie. Anybody? Who is the director of this movie? It's Top Gun Maverick, right? It's an excellent movie, but who is the director of this movie? No one. Oh God. Okay, so we are going to save one pen drive. Dr. Bhalla has already generously distributed, I think, almost all the prizes.
Joseph Kosinski.
So it's Joseph Kosinski is the director of this movie. Okay, so okay, now I don't this.
गगन से चॉकलेट वापस ले लो.
This movie is again in hit list.
Pathan.
Mike.
Sir, बोलेंगे which is the famous song?
ये किसको डॉक्टर गौहर
मिला भाई इनको.
सर आ जाओ. आप भी आओ ना सर.
See, our quiz is going on and there something else is going on. Who is this person?
एक और.
So see this, India is really proud of this thing. This is a
पुनीत
indigenously.
एक और.
Raise your hand, then the mic will be given to you. अरे वहाँ पे दो सर को उस बेंच से कोई आंसर नहीं है.
Tejas.
So it's LCA Tejas. Very okay. So now see this person. How many single men's Grand Slam this gentleman has won so far?
19. 19.
अरे हाथ खड़ा करो. कौन बता रहा है आंसर? 19. Anybody?
Sir, 20.
Who is saying 20? Okay, give it to her. So he has got 20 Grand Slam singles. Okay, this is the last question. You know this guy, right? So how many goals did he score in the World Cup final? And he was almost
3 plus 1 penalty.
Lionel Messi's dream.
3 plus 1 penalty.
Guys, one down.
5.
In World Cup final.
Final 3. 2 plus 1.
Plus penalty. He attempted
2
one
plus
penalty
1.
also.
3 plus 1.
Who is saying 3 plus 1? Sir, combine it 4. Okay, give it to Dr. Bali. Sir ने लिया हुआ है तो anybody new? Sir ने भी एक लिया है. Anyone? Tityal sir, please. Puneet, Tityal sir, please. वो सर आपको आप तो एग्जीक्यूटिव में हो. भूपेश और डॉक्टर बाली से 2 अवार्ड छीना जाए, ये भी एग्जीक्यूटिव में है. सो ओके, द लास्ट क्वेश्चन. अरे इसमें म्यूजिक है, म्यूजिक चलाओ. ओके, देयर वाज अ सॉन्ग. म्यूजिक है क्या इसमें? देखो.
This is the last. Praful.
ओके.
Only.
लास्ट वन है ना? ठीक है. Can anyone name this gentleman?
S. Rajamouli.
He got the Golden Globe for
S. Rajamouli.
राजामौली. इसका जो भी है अवार्ड छीनो इससे. गूगल देख के गलत आंसर कर रही है बिल्कुल. So this is M.M. Keeravani. Okay, he is the music composer of this Natu Natu song for which he got the Golden Globe. Okay, so with this we come to conclusion. Thank you Microvision team for sponsoring this. Thank you President sir, thank you Secretary sir, Joint Secretary and Treasurer sir for this wonderful quiz, and thank you all of you to participate. And can we have the
I have
winner?
just one question. Why did you not play Natu Natu?
It's not playing. The song was there, but it's not working. I don't know why.
Sure. Thank you, Prafulla, for handling such a beautiful quiz here, and thank you everyone for being with us in
We'll
this.
announce the winner in the
Thank you very
final
much.
grand ceremony.
Anything else?
The grand
Winners,
winner will
winners.
be, yes.
Results, no?
We will compile the result, and the first 3 will get prize of checks of 25,000, 10,000 and 5,000. Just wait for it. Wait for it. And the best part of this was
seniors scored as many, they gained as many prizes as the residents. I think that's big cheers to everyone. Big round of applause. Can we have the panelist of the next session, please? Dr. Tityal, sir. Dr. Namrata Sharma, Dr. Subhash Dadia, Dr. Alkesh, Dr. R.P. Singh, Dr. Gagan Bhatia, Dr. Bali, Dr. Kirti, Dr. Vinay Garodia, Dr. Sandhya, and Dr. Praveen Malik.
सही अभी पहले वाला है पहला टॉक मेरा ही एक मिनट में कॉपी करने इसलिए लगाना पड़ेगा ना खाना मीठा भी खा लिया था गुड आफ्टरनून सर हाय
Good afternoon, friends. Welcome to this afternoon session after the lunch and terrific quiz session. I'm going to take you through the basics of cataract surgery, science and art of basics. In that, we have right from understanding the machines, understanding the basic steps of phacosurgeries, and we have people who have been doing these surgeries for decades and decades, and they'll be the best person to give us basic tips for doing a best surgery from the given circumstances, which may be your machine, your patient, and the scenario. We have, along with me, Dr. Subhas. Alkesh is not here. Actually, he's having a suitcase. He'll come after some time. R.P. Singh, I can't see. Gagan Bhatia, Dr. Bali, Dr. Arun Baveja, Research Prof. Sanjay Dhawan, Professor Banati, Kirti Singh, the Director, Dr. Vinay Garodia, Sandhya Makhija, and Parveen Malik. So we have a large list of panelists. I think their contribution will definitely be fruitful in understanding the basics. So we have a first presentation that is by our one of the most effective senior-most faculty of our DOS, representing not only the Delhi, the country, across the world, Dr. Sudhang Bharti. He'll be talking to us on an evolution of machines, perspective or history from the pioneer. Dr. Bharti, please.
Thank you, Professor Tityal. I thank Dr. Rajendra Prasad and Dr. Bhalla for giving me this opportunity and inviting me here. And before I start, I must admit that I feel a little, like an antique and a veteran here when I'm talking about the history. You talk about history only when you are very old and you remember your old days. So this is the perspective of history in the phaco machines. And all of you know Charles Kelman introduced phacoemulsification 50 years ago. And Alcon's lineage goes back to Kelman's Cavitron, the first commercial phacoemulsification unit. And where he got his idea from was a dental unit which could make a hole in the tooth. So Cavitron, total 50 units were made, and one of the industrial grade stainless steel unit is on the display in the company's research and development site in Lake Forest, California. And the phacoemulsification, or phaco as we normally call it, it requires skill
but surgeons got outcomes that was significantly better than what they would get with extracapsular extraction in those days. So this is where, you know, how the phaco took over the previous cataract surgery, the extracapsular cataract extraction at that point in time. And I must also inform the audience here that SICS came much later after phacoemulsification. So I think SICS was another reason, because it was definitely a procedure which requires much more skill than ECCE or SICS, and that is why SICS came much later after phaco was either not possible because of financial reasons or skills that SICS was invented. DAISY was the first system introduced in 1986, and DAISY, the full form is Digital Aspiration Irrigation System for Cataract Surgery, and this was introduced by Stores, which later became part of Bausch & Lomb. And as I remember correctly, 1990, Dr. Hari Mohan purchased the DAISY system much before 1990, and that was something which we were always looking forward to, because he was one person who was always ahead of his times and was investing in the technology at that point in time. The ability to go through smaller incisions made a big difference surgically. The Legacy Series 20,000 coincided with broad availability of high-quality foldable IOLs, enabling smaller incisions for the entire surgery. With this approach, outcomes improved further. There was greater and more rapid patient satisfaction, and once exotic phaco approach became standard. So as I was, and this was the editorial during that time. The title of the editorial was "We Disown Them." And lot of surgeons in US, they started advertising phacoemulsification as a walk-in, walk-out and quick recovery and all those fantastic terms which were, you know, coined by the US surgeons for everything later on also. So the US phaco surgeons started advertising the better results and quick recovery after cataract surgery with phacoemulsification technique. And this is the time when this editorial in JCRS came. We disown them. There was a lot of hue and cry about few surgeons advertising and killing the practice of other surgeons who were not able to do phaco. Gradually this happened, the same thing happened in our country as well, where I remember when we started phaco, lot of media coverage was done for phaco, and a lot of surgeons who were not able to do phaco at that point in time went nearly out of practice and became either medical ophthalmologist or more or less their practice was limited to refraction. I started phaco in 1993 after visiting the OT of Dr. Della Pena in California. In 1992, I attended the academy meeting in Dallas and attended the OTs of Della Pena and also David Davis. And then I realized that this is the technology which is going to take over everything else in cataract surgery. And to tell you honestly, there was no way to learn phacoemulsification at that time except for the fact that you could learn it the hard way by teaching yourself. So there was no institute who were teaching phacoemulsification, no fellowships, nothing for phacoemulsification at that point in time. And I admitted after 6 months of struggling with doing phaco, I admitted that this is the investment which was in 1992, it was 8.25 lakhs, 8 lakhs 25,000 for buying an Opsys machine. I realized that this was something, because at that point in time I was doing ECC in 10 to 12 minutes, definitely less than 15 minutes, and I could not finish a phaco in less than half an hour. So it was very, I realized that this is a very tough system. And I admitted to one of my colleagues outside Delhi. My first machine was Opsys, followed by MMP, and the revolution came with the non-compliant tubing, which improved the chamber stability, and that was the thing. And then next machine was Diplomax, and first buyer of Sovereign I became in India in 2004. This was celebrated with a huge banquet dinner in Bombay. Infinity Phaco unit was introduced in 2003, followed by the introduction of torsional ultrasound WASL in 2006. And I shifted to Infinity in 2005. Today's phacoemulsification system incorporates plenty of advanced technology and clever design elements that make cataract surgery safer, faster, and less taxing for the surgeon. And fluidics is the way in which fluid is moved through the eye during surgery, and easily broken up nuclear fragments are removed from the eye, and there is no disturbance in the eye. That is what the job of the high quality fluidics. Last 3 slides. Okay. So Centurion vision system changed from gravity fed flow to constant pressure and active fluidics. This was targeting the pressure in the eye and variable rather than static input pressure. And the AMO's White Star signature started with the fusion fluidics, which is chamber stabilization environment, and gives a peristaltic technology, a combination of peristaltic and Venturi system, where greater followability, and also this sense that occlusion at the tip has occurred and automatically implements changes to minimize any surge. And the Stellaris is, they're basically a Venturi system, but it decouples vacuum and flow, which leads to lower flow and high vacuum at a decreased likelihood of surge. And also a dual linear foot pedal technology, which all those surgeons who can manage it are using it fantastically well. Thank you very much.
Thank you, sir. We'll take questions at the end. I now invite Dr. Harbans Lal. He's a known cataract surgeon, head of the department in Gangaram Hospital, and president of All India Ophthalmic Society.
Thank you, Dr. Bharti. I think we have some time for a setup. Dr. Alkesh, good afternoon. I think 2-3 things were important in the journey of phaco development. One was the energy control, and second was the heat control. And that could be, understood by various change in, phaco fluidics and phaco dynamics, which is going to be covered by Dr. Harbans Lal. You all know he's a pioneer in phacoemulsification surgery in the country. And he has been teacher to various groups of people. That includes students, the postgraduate people, fellows, and the teachers. So he is a teacher to teacher in phacoemulsification. His book in phaco widely known across the country. And he's the right person to make us understand the entire phaco dynamics in 7 minutes.
For the kind words, and I thank DOS for giving me this opportunity. So I'll be, as we know, phaco dynamics covers power and fluidics. And we know that the power could be continuous, burst mode, pulse, which may be hyper pulse with some modifications. I'll be coming to the only practical tips. Continuous phaco causes more collateral damage to the endothelium and wound burn and poor holding. So it can be used only for making trenching, though hyperpulse can also be used for making trench. Burst mode is rarely used, and only when the density of the nucleus is uniform and you feel you will need a uniform energy. For a direct chop in a very hard cataract, one can use the burst mode. Otherwise, we usually prefer to have the surgeon's control on delivery of the energy. Power settings, when we talk soft cataract, you should keep the phaco settings less than what you need, what you feel will be needed, so that you don't bite through. If you feel 20 is good enough, you probably can keep 15 or 10. You don't really want to have a big hole for holding. While on the other hand, when you are operating a hard cataract, the energy should be more than what is needed, so that you can bury and don't unnecessarily keep on giving the energy without actually trenching or cutting. So in two situations, rest, of course, according to the grade of density, you can keep your phaco settings. When we talk of the fluidics, there are two things. One is the inflow, which is gravity fed, and the outflow, which could be through the wound or through the tip. And when we talk of the inflow, it is the bottle height dependent in most of the time, till we have got active fluidics now. And 100 centimeter of the water column is equivalent to 74 millimeter of mercury of IOP inside the eye. So this may cause general stress, particularly discomfort to the patient. We are doing a topical phaco, and fluctuations of the iris, fluctuation of the IOP and repeated iris prolapse. So I usually prefer 2 to 3 feet bottle height, 60 to 90 centimeter, except in some exceptional situations. So bottle height you can increase when you are doing a very high vacuum phaco, flow rate settings, particularly in harder cataract. Lax posterior capsule, which has got a tendency to come into the your phaco tip, you can keep bottle height high. And a high volume surgeons, when he doesn't have a time to really modulate, wants to go straight away, press on the pedal. And you have to decrease the bottle height when you are doing a low vacuum or hypovolumic phaco, particularly in cases of PCT, shallow anterior chamber, iris prolapse, generalopathy, and some of them may be extra safe surgeon and do not want their patients to have discomfort, so they try to operate. They may take a little longer, but in a low bottle height situations. So vacuum is equivalent to the how much is the holding power is there, and the holding power depends upon area into the vacuum settings. That means 3.14 multiplied by the RR is the power which will hold. That means if the tip size is, if the phaco tip bore size is 0.3 millimeter, and then the holding power is say 0.28, I'm not writing the units, but if it is 0.6, it is 1.13, that means nearly 4 times. So whenever you need a very high holding power, like in hard cataract, you need to have bigger bore than a smaller bore. And when you want having a less holding power in a soft cataract, epinucleus or cortical limbo, you don't need such a big bore, and you can operate with the micro tips. Flow rate is how fast the things will happen, whether it's a vacuum buildup or material sucked into the port, which may be either the nuclear fragment or even the iris or the capsule, whatever it comes over there. So the flow rate will decide how fast the things are happening, and the vacuum will decide how strong you hold it. So these two things are to be kept in mind. Then we come to the customized settings, and that will depend upon a space available in the eye, size of the pupil, capsular axis, endothelial cell count, floppiness of the iris, density of the nucleus, whether there is a PCT or not, and whether you're doing it under topical or local, and stage of the surgery, whether you're doing a trenching, chopping, aspiration of the nucleus. So it's a dynamic process. So let's say 1 or 2 examples. When you are operating a hard cataract, use a regular tip because you need a really very, very strong hold to chop these spaces. And I usually keep the vacuum setting of 600. And you can continue once you are chopped. If the anterior chamber is deep, like in myopes, you can continue the same settings because there is enough of volume. If it is a normal AC, you can reduce after chopping to 500. If it is shallow AC, you can go to 400 vacuum settings. And at the end of the aspiration, we went to the last second segment, I reduce it to 500. When I go to the last segment of the removal, because these posterior capsule in a hard cataract is usually floppy because the nucleus was of such a big size, I will reduce it to the 400 vacuum. Not only we need to lower the settings, but remove the side port instrument to prevent the leak from the side port. You can use the viscoelastic, and if the capsule is very floppy, you can put on a CTR when you reach to the nearly last stage of your hard cataract surgery. In a softer cataract, very soft, of course, you can remove the IA, or you usually keep the vacuum settings. It is like a epinuclear plate. You don't have to have a very high vacuum setting, so 200 to 400 millimeter of mercury is good enough. And in high myopes, generalopathy, vitrectomized eyes, AC is deep, so even if it is soft cataract, you can keep high vacuum settings because there is enough fluid inside the eye. In cases of shallow AC, hypovolumic phaco is a good idea. Keep the low bottle height and low vacuum settings. Don't keep bottle height very high. If there is no space in the chamber, there is no point of keeping bottle height. And nowadays, whenever I do AC depth, which is less than 2 millimeter, I actually do not do any hydro procedures, and straight away start with the trenching so that I can reduce some of the volume and create a space in the eye. And then if need be, most of the time you can rotate the nucleus without hydro. If it is not, then you can do the hydro at that time. And if the chamber is deep AC, you can keep a low bottle height to prevent distress. Like in high myopes, you don't need, because even in the low bottle height, there is enough fluid in the anterior chamber, so you can operate comfortably over there. And hypovolumic phaco is must whenever there is a PCT, iris prolapse, shallow AC, or Epis syndrome. And in cases of rhexis margin tear or descemet tear or uncooperative patient, poor visibility, spine problem, neck issue, all these situations, though you want to have a less suction power to control it better, but you don't have to lower the bottle height. So it is a hypovolumic on a suction front, but the infusion front remains high. So slow down. If you are not feeling great today, you had 2-3 pecks in the night and feeling very groggy. If there is a VIP patient, a patient is one-eyed and a premium IOL, so patient's eye is more important than your time. So slow down at that time. Thank you very much for your kind attention.
Okay. Thank you. It was a wonderful two talks on initial basics of phaco machine and dynamics. And we are going to shift to our biometry now. We'll take 1 or 2 questions from the audience because we have a time constraint. Any questions from the audience?
Dr. Bhalla, are you ready?
Okay. Amongst the panelists, any queries? I think we have understood the
So
entire...
two masters have just spoken.
Yeah, yeah.
And the third master is introducing.
Ye question thodi hua, yeah.
So you wanted a comment. You asked for a comment from the panel.
Okay, okay. But it was a very nicely, you can say, concisely, precisely, given by an expert, what should be your parameters, how you should tackle the, hard cataract, soft cataract, deep chamber, shallow chamber, and the parameters was beautifully explained. Yep. And that is what we learned from our experience, how you manage your machine, because each machine may behave differently in different hands. So you have to have a machine which is friendly to your settings and for your patient, your eyes, patient's eyes. And people keep asking which is the best machine available nowadays. The perfect answer is whichever machine you have to make yourself perfect on that situation. So any machine is good. It is how you practice through that machine to get a best outcome for that particular case scenario. So today we have a generation of machines which have come through various changes in our software, hardware, and we have every machine today, right from the Indian machines also, they give a very, very nice fluidics and a phaco power modulation. So we say that today everything is perfect. It is only us to drive them in a proper manner. Dr. Bhalla, please now shift to the biometry.
Yeah.
Let's have, but that's also a very important area for us.
Yeah.
And 6.5 minutes is your time.
Thank you, sir. Even after excellent cataract surgery, the patient may not be satisfied if the refractive outcome is not optimum. So in next 6 minutes, I'm going to describe how we can really improve our results. See, in earlier times, cataract was removed first and spectacle prescription given last. And today we calculate the power of IOL first and cataract surgery is done afterwards. And since 75, only 2 parameters, basically keratometry and axial length, has been used. But today we have the formulas to customize the power of IOL to achieve near plano results in even highly refractive eyes. And there are a group of patients who, if you break news to them after cataract surgery that they require glasses, they are extremely disappointed. And what are the major sources of prediction error? ELP prediction is the major source of error, 35.5%, followed by axial length and keratometry measurements. And few subjects in the field of ophthalmology are not very interesting because they involve the use of mathematicians, and we ophthalmologists by nature are not very fond of mathematics. And what were the hurdles in accurate estimation of effective lens position with the older formula? Because they had some assumptions. That is, shorter eyes and flatter eyes were supposed to have shallow anterior chamber and shorter effective lens position, in contrast to longer eyes and steeper K eyes. But Holiday taught us that there are 9 types of eyes. Even in eyes with normal anterior segment, 80% may have longer axial length, shorter axial length, and 90% may have longer axial length. And in eyes with normal axial length, 2% may have shorter or longer anterior segment depth. So relationship between anterior segment size and axial length is not proportionate in 80% of short and 90% of longer eyes. So older formulae are bound to fall in short and longer eyes. And there was some more assumption also that cornea was treated as a thin lens with refractive index of 1.33, whereas exactly it is 1.37. So it gave us correct result only in average eyes, but not in atypical eyes. So if we keep using the older formulas, only 1% of surgeons achieved accuracy more than 92% within plus minus 0.5 diopters. And this was Rayner Medal lecture delivered, which said that 91% of eyes you can achieve greater accuracy of refractive correction. So I'll straight away come to the newer formulas. Prediction theory says as you increase the number of variables from 2 to higher number of variables, like we have 7 variables in Holiday 2 and 5 variables in Barrett, your accuracy may increase. Then we have artificial intelligence, ray tracing, and then there are factors to really predict your effective lens position. SRKT used A constant, Haigis used A0, A1, A2, Hoffer Q and Holiday 2 had personalized anterior chamber depth, and Barrett has lens factor. But if we use, what are lens constants? These were typically developed during later stages of regulatory process when contact ultrasound, biometry and plano-convex lenses is used. So if we keep using the original lens constant and do not optimize, you are bound to have some error. So how do you can optimize? Either you can go with your results, or there are software available like Haigis ULIV website, or Dr. Holiday's or lens constant, or drhill.com. So if we optimize our lens constant, you can see within plus 0.5 diopter, we can improve our accuracy from 18% to 70%, and within 1 diopter from 50% to 95%. Barrett Universal 2 formula, making waves, recommended for all types of eyes. Hill RBF uses artificial intelligence. Olsen formula uses ray tracing, and LADA super formula is an intelligent formula because it combines the best performing portions of multiple third and fourth generation IOL formula. Kane formula uses axial length, keratometry, anterior chamber depth, lens thickness, CCT, and gender of the patient. EVO 2.0 formula also is a very important formula which is giving us very good results. So what is the use of intraoperative aberrometry? It is not going to make lens calculations obsolete in the newer feature. Indications is only in post-refractive surgery and astigmatism correction. And ray tracing IOL formula is superior in odd eyes with extreme axial length, it is not outperforming the current third generation formula. And since they are dependent on the accurate estimation of effective lens position, no reason to switch to them. Hill RBF formula not only gives us IOL power, it also gives us accuracy level, that is whether your results in the bound or out of the bound, depending your patient's data matches with the data base of the Hill RBF. So if we compare Barrett and Hill RBF, both are current, both are more sophisticated, although they use completely different premises, but they give result which are within 0.25 diopters of each other. So what should I do? Should I use multiple formula? Douglas Koch follows this policy. But Holiday Barrett says use specific formula for specific condition. So what is the best way to deal with short eyes? The best way is either use median, not mean of Holiday 1, Holiday 2, or use simply Barrett and Hill RBF. So conventional wisdom or smart wisdom. Conventional wisdom said Hoffer Q, but now is the time to change. So problem in longer eyes is we get hyperopic surprise. So these formulas do very well. I use Barrett and Hill RBF, and so these are the current newer generation formula: Barrett, Hill RBF, Olsen, Kane, EVO, Panacea. And if we see, this is meta-analysis which was published, and they found that in shorter axial length, Kane, EVO 2.0, VRFG, Barrett, Hill RBF, Pearl are outperforming all other formulas. And in longer axial length also, Kane, EVO, Barrett, Hill RBF are giving us very good results. This was another meta-analysis published in JCRS done by Mellis in 2019. So what are the steps you can take to maximize the likelihood of getting better outcomes? Optimize your lens constant, validate your measurements, and these are the validation criteria. If you get, I'll just take a half minute more, sir. To summarize, take measurement yourself because ophthalmologist is the most important member of the team. Don't remove yourself from the team. Don't delegate your responsibilities. Don't remove yourself from this process, particularly in odd eyes, myopic, post-refractive surgeries, eyes, or shorter or longer axial lens. Spend extra time counseling patients with short eyes. Just don't keep doing what you have always done. Stay informed about the latest developments. So 90%, we are stuck at 90% within 0.5 diopters. Why? Limit is not the formula. Limit is the least count. And the least count for keratometry is 0.25 diopter. For axial length and anterior chamber depth is 0.1 to 0.2 millimeter. So that is the reason we are stuck at 90% or not better than 90%. And another problem is there is ISO permitted tolerance. See, if you want to, you got the calculation of 21.3 diopter. The nearest power available is 21.5 diopter. But for 21.5 diopter, ISO permitted tolerance is 0.5. So even if you have done good surgery, you will still get error of 0.6 diopters. So can we use single formula for all eyes? It is doubtful. But right now, the formula which comes closest to this is Barrett Universal 2 and Hill RBF. These are the accuracy range of commonly used formulas by axial length. So
ये क्या चीज़ है?
So 90% is now achievable. So we are on the verge of level of accuracy for refractive outcomes, never before seen in ophthalmology, but to fully enjoy this, use validated measurements, optimize lens constants, and adapt to new technologies. And we are grateful to all these ladies and gentlemen for bringing us to this level. Holiday, Wang, Koch, Warren Hill, Thomas Olsen, and Barrett. Thank you everyone for your kind and patient hearing.
We have a question from the audience.
You can take.
Thank you, Dr. Balla. I think before we take the question, let's. I want to see. Basically, it is the equipment which is important. So, how many of you have the access to optical biometer? Can you raise the hand? Okay, 7%. How many of you have access to immersion biometry? Another 10%. How many have a contact biometry access to? So people are still doing a contact biometry and immersion. Not everybody has an optical biometer.
I think that is one important reason.
So that is also an important factor which will decide which type of formula I'm going to use in these cases.
Sir, one question from you, Dr. Balla.
Okay, let's take question.
Question not regarding biometry. Today's the physical CME series.
Can you use the mic, please?
Today you written physical CME series, Cataract, Dietetics and Dietetics. I don't understand these two words, Dietetics and Dietetics. Can you explain, please?
So we'll come.
What was your
back.
question? Question kya?
Dr. Rajendra Prasad will answer that question.
Please,
so
somebody tells me what is the meaning of Cataract, Dietetics and Dietetics. I can't understand. Dietetics.
Okay, didactics and dietetics.
What
So
does it
basically,
mean?
didactics simply means teaching, and dietetics means food which is healthy for you.
But there is no discussion on food around.
Okay, we'll discuss that point out,
We got
any other question?
All series, no food discussion, no diet discussion.
No, Dr. Narang, at the end of this CME, you will not only be academically satisfied, you will also be gastronomically satisfied, sir.
So the culinary experience as well as the knowledge experience.
But no dietetics around.
So, so we're calling upon Dr. S.K. Narang, and he's going to be telling us about the secrets to a perfect rixes.
Balaji,
And this was aimed at the beginners.
Balaji, what would be the best formula for a normal eyes? One formula today.
Sir, I'm using Barrett Universal 2 right now.
Barrett Universal 2. How many people are using SRKT still? People still use SRKT also. What about the short eyes? You said, which is the best formula?
So for short eyes, I've started using Kane formula.
Cane formula.
And these all are free formulas available online.
Okay. For a longer eyes?
Longer eyes, again, I use Barrett and Hill RBF, sir.
Hill RBF. Okay. And for post RK patients, sir? Post RK patient eyes?
Here I use ASCRS calculator.
ASCR calculator.
ASCRS calculator.
Okay. Post LASIK, myopic LASIK? Same.
ASCRS.
I think that is one answer I wanted to bring out. You have a various, ASCRS, APACRS, sites from where you can really get a good calculation for your patient. So always depend on those formulas which can be, you can get it from these sites, and that might improve your subsequent calculation also.
Also for keratoconic eyes, I think Kane's formula is the best.
Yeah. Thank
Yes,
you,
ma'am.
Dr. Balla. Thank you.
Actually,
for
people are
input.
looking
Thank
up
you,
to Kane and Carmona because it's using extreme gradient boost at, at the higher and the lower end. Sir, please.
Thank you, DOS. And good afternoon, everybody. But I don't see many beginners here. All perfect. All perfect people are there. So my topic is secret to a perfect Rexis is tips for beginners. I'll mainly concentrate on the videos. These are the types of, let's not go into the history. History has already been covered by Dr. Bharti. Capsule Rexis, let's talk about capsule Rexis. Capsule Rexis meets the demands of advanced cataract and IOL implantation surgery, can be reproduced by experienced surgeons and potential for other developments also. So let's not go into that it is curvilinear. Its advantages of curvilinear Rexis is that endocapsular phaco is possible, radial tears are not there, hydrodissection more safe. In can opener, of course, hydrodissection can tear the capsule and the tear can go into the posterior capsule. Zonular stress is not there. Turbulence is contained within the capsular bag. And then the cortical aspiration is very easy because of the round Rexis. IOL centration, especially in cases of multifocals, trifocals, is important. So it is important to have a central Rexis. And it's a closed system. And with intact PCR, still it is possible to implant an IOL in the sulcus, and PCO formation, of course, is minimized if we polish the capsule properly. So these are prerequisites. Everybody knows, pupillary dilatation, microscope, high magnification, zonular attachment. Sorry. So current standard techniques, main technique which we started with is the cystotome. Afterwards, the forceps came, then with the femtosecond laser and the Zepto. There are two types of approaches, one through the main incision, one through the side port incision. And let's talk about the videos, and then I will keep on talking about these points. This is a very important video, not because it is not clear. It is for the beginners, that beginners should preferably be starting the Rexis with the side port. This is one of my fellows who is doing a beginner, trying to do a Rexis from the side port, which is at 12 o'clock. And just because when you start making a Rexis from 12 o'clock, the viscoelastic doesn't escape, and the person is able to complete the Rexis without injecting methyl cellulose again and again. And the person is able to complete the Rexis with ease without instilling methyl cellulose again and again because it doesn't escape. The side port is very small. And the Rexis is completed easily. Here I will like to give a tip to the beginners. What I say, that make the side port afterwards. First open the main port, inject methyl cellulose, inject dye or methyl cellulose, dye and methyl cellulose, and then make the side port. This reduces the chances of DM detachments through the side port. Now, this is another case. This is me who is doing. I am doing this from the main port. I think main port you can do after a few years of side port rexis. And with the main port, because there is some pressure on the posterior lip of the wound, the methyl cellulose escapes again and again. And you have to inject methyl cellulose again. See now, because of I have done so many cases, I am able to complete the rexis in one go without injecting methyl cellulose again and again. And the rexis is good sized, although in previous case it was a small sized rexis, it was done by one of the fellows. So you can see that it is completed in one go without injecting methyl cellulose again and again. Now we come to the rexis in difficult situations. This is a mature cataract, and I'm starting the rexis. It is better initially to start the rexis in mature cataracts through a side port, although I'm trying to do it through the main port. Very small opening, and then I will complete it. This is a smaller rexis. It is advisable to do a smaller rexis in mature cataracts so that it doesn't run away. Argentina flag chances are reduced. And the rexis is completed. This is all done through the main port, not through the side port. And it is really possible to do rexis, to phacoemulsification through a small rexis. Now, next is in intumescent cataracts. Intumescent cataract, there is very high chance of rexis going into the periphery. That's called Argentina flag. I'll take 2 more minutes, please. This is very important. So I'm just after the puncturing, I have rotated. So the Argentina's flags, the chances become very less. And a very small rexis, very small rexis, very small rexis, very small rexis, and complete it with the forceps, because I was not able to proceed with the needle further. And then did the phaco through this. So let's move to the next. This is the phacoemulsification done and the lens implanted, but the rexis is very small. So what we do, we can extend the rexis, we can give a nick in the rexis margin and do the circular enlargement of rexis. And it becomes as big as 5.5 mm with the, of course, lot of practice. It requires a lot of practice to do this. So this is, now, this is very important video, a double rexis. One very small rexis, this is done by one of my associates. It's only 2-3 days back, I think a week back. And then she enlarges it. First does some cortical aspiration with the phaco probe. See, she's doing with the phaco probe. And then gives a nick in the capsular margin, which is, unfortunately, I don't like it. This is a radial nick, because this radial nick can go into the periphery. And then she enlarges the whole rexis. Now this is a rexis in the, should I go to the previous slide? Showing the beginners the last part of it. And see, she's completed the whole rexis fully, and then did the rexis phaco through the reasonably larger. This is a rexis through the scarred capsule. I was not able to complete, so I had to convert this case because the center is scarred, and I thought I will be able to reach the periphery and then complete it, but was not. So we had to convert this. case into the extracapsular. It was not a good rhexis because of the scarring. Now this is the last video, and this has all the ingredients of all the previous. Let's start from the beginning, just 1 minute more. I have given a small nick in the center and the cortical matter flowed out. Now I am sucking that cortical matter with the cannula so that the pressure in the capsular bag goes down. And then with the needle, I am trying to do it, but I am not able to proceed further. Now I shift to the, I think I am shifting the forceps. Then I shift it to the forceps. Again, not able to do, suck more with cortical matter. Then trying to grasp it with the forceps, not coming because there is a reason for it, why it is not coming. This capsule is also scarred. And then I catch hold of the forceps. Struggle, little bit of struggle there, because I couldn't see the scarring because of the white background in the preoperative area. Most preoperative examination, most of the times I don't do the preoperative examination, is done by the residents. And then the rhexis was completed. But it is, as you can see, it is a very, very irregular rhexis. I completed the phaco through this small rhexis, eccentric small rhexis. Now you can see at 6 o'clock, there is a fibrosis in the capsular margin. That's why I was not able to proceed. Now, I have extended the rhexis before inserting the lens. Why? Because I was using a lens which has a history of explosive opening, and if it opens half inside, half outside, it will be very difficult to, put it back inside. You have to incise the capsule, you have to cut the capsule. It gets stuck in the capsular rhexis margin, and that's when the whole case is completed. So we have seen extending rhexis before the phaco, extending rhexis after the phaco, before insertion of the lens. That's it. Thank you so much.
Sir, one question.
Thank you so much.
Sir, one question.
A wonderful exposition for all the beginners as well as the entire, all the members here and the practitioners, already very conversant in phaco. Coming up next is Dr. O.P. Anand. So we'll be taking the questions in the end, right? So with the permission of the chair, we're taking the questions. Dr. O.P. Anand is coming up and he's going to tell us about nucleus management, learning phaco chop and beyond. Again for the beginners.
Good afternoon. My regards to Professor Tityal sir, Dr. Bali, all seniors sitting here. The next step after a wonderful rhexis or a compromised rhexis, you have to manage the nucleus. I always say that cracking ultimately is the key of cataract surgery. You should have the full confidence. What procedure you have to use, what technique you have to use, it depends on the surgeon's experience, number one. The hardness of the nucleus, you have to accordingly change it. And the machine, never forget the role of machine in cracking. So now, with the advancement of the machine, it's very difficult to treat a soft cataract rather than a hard cataract. We know the machines are having tremendous cutting power, holding power. So I'm just showing one case where I'm operating a soft cataract relatively. It's very difficult to hold it. So I always suggest that you should try to hold the nucleus from the center because the hardest part of it. And if possible, you can change the tip. You should use 0 degree or 15 degree needle. In such cases, if you are using a 15 degree, 30 degree or 45 degree needle, it's very difficult to crack the nucleus in back. So this case, I have already cracked the nucleus, but it's not complete because I'm not able to hold properly the nucleus. And finally, you see that I have just taken one part of it, and then the nucleus start coming slowly and slowly. So always ensure that we should keep our energy away from the cornea. Small pupil, again a situation where you have to operate from a small pupil. It is under dilated pupil. The technique for cracking here, that you should have a very strong and effective crack, because people then give much place. You can see just I have tried to hold the nucleus from the center and make a effective cut. So nucleus is already been cracked at one place. I am just making to the other part to get the complete through and through crack. If you don't do it like at this stage, you definitely will not complete your case effectively. You can have the more energy to consume. So to reduce the energy, you have to have a very effective, complete through and through crack, whatever the kind of case and the pupil size is. Another case where the cornea was slightly compromised, but I again try to crack the nucleus from the same technique. It is a little harder cataract. I am making a little trench deep just to have a hold from the depth of the nucleus. So I can give a look here. By that effect, you can effectively crack it. So the same process you have to keep on going. Like you have to re-grab it, and then you have to apply your chopper. You should have a wonderful foot control. Your microscope should be always on the surface of the nucleus. So you may go down just to see whether your crack is effective. You have done it, and in this case, a small pupil, I have done it. Now a series of hard cataracts. So they are always challenge for the phacosurgeon. If you have a hard cataract, you have to reduce the energy. You have to have an effective crack. At least single crack has to be there, by which you can have your further steps little simpler. So look here, that by making 2 attempts, I have just cracked the nucleus. One point I would like to share here, that some modification in the tip you have to do. Once you are not able to hold the nucleus properly, you may have to little more exposed tip. So you have the firm grip by more deeper engagement of the nucleus. One more case, again nucleus is hard. I am going a little down, I am making a trench over here. It is not complete, it is a half trench. So I am going to the deeper part of the center of the nucleus, and once I go it, I just got it, and the nucleus was totally cracked. So once you make in 2 parts, the second half is not difficult. You can definitely, with little effort, you can make the 4 pieces of that and not stop here. You can make 6 pieces, 8 pieces. One more case. So here the nucleus was not so hard, but it was not coming in the grip. So I have to make 2 to 3 attempts to hold it, confirm, and then apply my chopper. Here the role of chopper is there, so many people use little longer. I always use sharp chopper for making this crack, and never very long. And look here, the nucleus is totally cracked, and now your job is simple. The case can be, and one more case. This is looks little soft cataract, but it is not soft. It is sclerotic nucleus. So you just see when I try to handle it, so it gives lot of resistance to crack. So I am using almost 600 millimeter of mercury vacuum here. But one mistake I did, that you see the tip part is not properly exposed. By making 2 attempts, I am able to crack the nucleus in 2 parts. Now I am making the more parts of it. It is hardest one. It's a blue dark cataract. So I have to little more cautious. You see tip is more exposed here, and I am holding the nucleus from the deeper part of it. So once you strongly hold it, it's very simple to make 2 parts of the nucleus, and your cataract is cracked. Your case is cracked, in fact. It helps you for reducing the energy, and whatever energy you apply, it goes into the away from the cornea. So in a very hard cataract, it's advisable you should make more and more pieces. So it is one of the rare case where I don't recommend that everybody should go ahead. It's a compromised rexis. You can see the rexis, the rexis is just coming out. It's already gone. So here we have to apply the force in the pupil plane. we should avoid to apply any force downward. And I just correct the nucleus by applying the force almost horizontally and try to debulk the area. So I have taken one part of it, so I have the space, so I can reduce the stress on the zonules and the compromised capsule. So now I have taken one part of it. The other part I am little scared, so I don't want to go down much. So doing the phaco almost in the pupil plane and slightly in the antechamber. Definitely at this point you have to take care of the cornea. So now the case is gone. I have removed the nucleus very safely. In the last one more case I want to show you here. That is a Morgan cataract. So apart from rexis, you look the abnormal movement of the nucleus here. You try to hold it, it start moving and rotating sharply. So it's very difficult to hold it in the center to just correct. So I was thinking what technique I should use. I cannot trench here. So I just try to hold it with the vacuum in the center of it, and it's running in the eye. And you know that there is no cushion behind. So I am a little safe. So now I have made a grip, and now the nucleus is in my hand, and now I have just induced the crack. So this is the way where you can handle with the minimum energy. So there are some situations, there are a lot of situations where you can just modify your technique. It depends on your experience and machine. Thank you very much, sir.
Excellent cartwheel phaco, sir. Fantastic presentation. So we'll take the questions at the end. Thank you so much, Dr. Anand. Is Dr. Vanati here? Ma'am, are you there? So Dr. Vanati is not here. So we come back to Dr. Rajendra Prasad once again for practical pearls in infection prophylaxis in cataract surgery. So the president is back.
Good afternoon. The topic which I am going to talk about is the practical pearls, which is very, very important subject in a premium cataract surgery, and we all into the cataract surgery. And this is one situation which is a sight-threatening complication which none of us would like to come across in our surgical practice, especially with the premium IL. When you are doing these premium surgery with toric IL or multifocal ILs, toric multifocals, and so you actually are looking for the good result post-operatively. And if you happen to come across the situation of a reaction in the anterior chamber, which could be in the form of the cells or the exudates, then it becomes a problem. So this problem becomes devastating to the surgeon as well as to the patient. And although the incidence is not very high, but this is a sight-threatening complication, and the incidence of the post-operative endophthalmitis has really gone down now these days because of the improved surgical settings, uses of newer topical antibiotics, institution of the intracameral injection. We all are practicing now better post-surgical care. But we have seen that quite often we come across the endophthalmitis, and especially in a cluster endophthalmitis, we all hear coming in the news. And in most of these cases, the common source of infection which is found was in the surgical settings, especially with the sterilization and aseptic handling. Infection stemming from the contaminated irrigating fluid, visco devices. The recently one cluster endophthalmitis which was reported, where the infection came from the visco devices. So these are the things which is not in control of the surgeon. Surgical instruments, air conditioning, water use for scrubbing, IL-related reasons. But one very important reason is repeated use of phaco tip and surgical instruments from one to another case. So this is one another important point because we have to take care of. And there are other sources of infection like patient's own ocular surface, microbial flora could be one of the reason, and many times it's a poor or delayed wound healing, which increases the risk of infection in many of these cases. And if you land up with the complication in the form of PCR, vitreous loss, uveal trauma, or wound burn, so these are the cases which are more prone to develop the infection post-operatively. These are the common isolated microorganisms, but in Indian scenario, it is the gram-negative bacteria and the fungi which is more commonly seen in the post-op endophthalmitis. And many times these cases, they do not respond to any drug, and we'll end up with this disastrous situation where there could be a complete loss of vision. So in all these cases, the prophylactic methods plays a very, very important role. So you have to look into your case, you have to do a proper selection of your case, pre-operative preparation, disinfection of the surgical area, aseptic use of the surgical instruments, pre-operative and intraoperative antibiotic use, post-surgical management. So all these factors are very, very important. So you need to do a systematic approach. You must have a complete ocular and medical history of the patient, thorough ophthalmic examination to be performed, complete ocular investigations, microbial investigations. All these are important from the medical legal point of view also. And you must rule out the high-risk cases which are prone to have intraocular infection, like the age, very old patient, and the dysfunction of the immune system, diabetic patient. You need to do a good control of the diabetic status before you start the cataract surgery. Pre-operative use of the steroids, malnutrition, overweight, low host immune response, chronic pulmonary infection. All these factors should be seen and treated or ruled out before the cataract surgery. Now, during the surgery, perioperative antisepsis is the important point, and the use of 5 to 10% of the povidone iodine to the cornea, conjunctiva, sac, periocular skin for a minimum of 3 minutes prior to the surgery. This is one factor which we all have to take care of and do in all our cases, and this is going to eradicate almost 90% of your bacterial flora from the surface of the eye and the conjunctival sac. And then the second important point is the antimicrobial prophylaxis. We have been using many of these antibiotics in our cases. We use them pre-operatively, intraoperatively, and post-operatively. The goal is to reduce the microbial flora in the precorneal tear film prior to the surgery and to allow the diffusion of the topically applied antibiotic into the anterior chamber. So these were the goals of use of antimicrobial antibiotics before the cataract surgery. But the problem is, the greatest challenge which we come across in the prophylaxis of the ocular infection is identifying the antimicrobial agent and its concentration, what should be used in our cases. Because what we have seen now in a recent time is with the prophylactic antimicrobial failure, the reason for that is the emergence of the mutant microbial population, because many mutation is taking place with the microbes, emergence of the multi-drug resistant microorganisms. So this is another important problem which we are facing now these days. And this happens because of the incorrect or inadequate spectrum of the antibiotic and inadequate drug concentration. So exposing these microorganisms to a non-lethal concentration, if you are using very low concentration, you are actually making them resistant. And this has actually impacted overall practice and our approach to the empirical use of the antibiotics. So these are the antibiotics which we have now at present. And the selection, what we are looking at is the MIC value of the antimicrobes. But what happens, the MIC is not sufficient, because these mutant population and resistant population, they do not respond to the MIC value. And they keep on growing. So you have to look into some other concentration of the drug that is called as the MPC concentration, that is the mutant prevention concentration, which is actually higher than the MIC concentration. So the MPC drug concentration is typically higher than the MIC drug concentration. So this is what we are looking for. And these are the factors we include before we select the antimicrobes. And these are the characteristics of the antimicrobial antibiotics which we have. It should have a strong penetration, high concentration. It should have a broad spectrum activity, faster kill rate, good safety profile, and a low propensity to develop resistance. So if we have all these, and these are the antibiotics we have been using in ophthalmology, but recently, because what we have seen, most of these antibiotics, aminoglycosides or macrolides, cephalosporin, they are getting more and more resistant now because these microbes, they do not respond. So what we have seen now for the prophylaxis, the new drug which has entered is the fluoroquinolone, which has a much better kill rate and much better action on these resistant microbes. And out of these is the levofloxacin, which has come up in our practice now. Levofloxacin is a bactericidal drug. It has a very long duration of action. It's an aerobic gram, and it covers almost all the spectrum of the microbes, and cross resistance is very low. This drug actually its MPC and MIC value is very low, but although the MPC value is a little higher than the getafloxacin, but with the getafloxacin the problem is the concentration cannot be increased more than 0.5%, while with the levofloxacin the concentration can go up to the 1.5. This is a pre-filled drug, pre-prepared, unlike the cefuroxime which we normally make with the high concentration, which is not preservative induced and which could have drawbacks also. But this is a pre-prepared drug, but we have with the 1.5% of the levofloxacin, very highly promising drug. Fast action, good tissue penetration, broad spectrum and safety profile is very high with this drug, with very good pharmacodynamic activity of this drug. Very good penetration through the cornea, and its concentration in the anterior chamber is achieved very high within a minute, and it does not delay the wound healing, and its coverage is almost 93.3% in patients who receive levofloxacin 1.5% ophthalmic solution in most of these cases. So this is the ESCRS guidelines for the surgical prophylaxis without intracameral cefuroxime. If you are not using the intracameral injection, then what the guideline is, you use 4 times a day, 24 or 48 hours before the surgery, 1 drop 1 hour prior to the surgery, 1 drop 30 minutes prior to the surgery, then reapply 1 drop at the end of the surgery, 1 drop 5 minutes later, and 1 drop 5 minutes later again. And post-operative topical prophylaxis should be 1 drop every 1 to 2 hours on the day of the surgery, and from the next day every 6 hours for 1 week, and then for 2 weeks you can use this 2 to 3 times. What I am practicing in my clinical practice is I use levofloxacin 1.5% 4 times a day, 24 or 48 hours prior to the surgery, 1 drop every 15 minutes, 1 hour prior to the surgery. Then I reapply 1 drop at the end of the surgery, and post-operatively topical prophylaxis 1 drop every 2 hours on the day of the surgery, and then from the next day every 3 hours at least for 4 weeks. So this is the profile you should use of the levofloxacin if you are looking for the prophylactic point of view. So the key message is preoperative prophylaxis with installation of antibiotic drops to reduce the microflora in the ocular surface and improve aqueous humor concentration of the antibiotic drug, eradicate the bacteria at the site. Higher concentration, so this is very, very important point, the higher concentration can greatly increase the effectiveness of an antibiotic by increasing the penetration in key ocular tissues and help us to overcome the resistance. But the higher concentration, it should be pre-prepared higher concentration drug, not what we normally do, prepare the higher concentration drug with our own hands. So that is not actually correct. You would have a cross-infection also possible with these higher concentration, but this is one drug. You have a pre-prepared drug with a very high concentration, very effective and very good drug. Thank you very much.
Thank you so much, sir. We'll come back to this is a topic I think which is going to evoke a lot of discussion. So could we go on to the next speaker? Thank you so much, sir. Thank you, Dr. RP. We're calling upon Dr. Arvind Maurya, and he is talking about artificial intelligence and smartphone-based annotating and screening app in ophthalmology. Are we ready? I think I can take a comment from the panel in the meanwhile.
I just
while they're
wanted to
preparing.
know there are also Dr. RP sir, There are also studies in which people have used intracameral levofloxacin for prophylaxis. So what is your comment on that?
And this is going to be
In fact, we are also doing this study, and Arvind is here. We both are doing. We have already done almost 200 cases now, and this study, I think, we'll be able to finish in next 2 to 3 months, and we are looking at around 300 cases. So, and it's intracameral injection. It's really very effective, and the most important point what we have seen with this drug is no reaction in the entry chamber. We were using moxifloxacin earlier, and with moxifloxacin, you could see in certain cases some reaction in the entry chamber. But at least with this drug, we haven't seen any reaction. So that part is absolutely ruled out, no reaction. But the effectiveness, we are seeing it's very effective, the drug. And the concentration, we are actually still evaluating what exact concentration we should use.
So what is your post-op antibiotic prophylaxis?
I think what Dr. Rajendra Prasad has highlighted, that holds true for everybody. I have not shifted to levoflox for a patient because that is a drug we normally preserve for other situations. I still continue with moxifloxacin as a prophylactic medication, pre-op and post-op also, and intracamerally also.
So for levoflox, again, the dose is same, 500 microgram per 0.1 ml, which is pretty much the same for moxifloxacin. And people have reported cases of TAS if you use higher concentration of moxifloxacin intracamerally or use moxifloxacin in larger volume. So whenever you are using an intracameral drugs, I think one has to be careful.
Okay, Arvind.
Good afternoon, everyone. And thank you, DOS, and especially Dr. RP sir for giving me the opportunity. So my topic is nothing to do with cataract, but it is certainly to do the better screening for the better prognosis in the cataract patient. So my topic is smartphone-based annotation and screening, artificial intelligence-based application for the common retinal disorders. So AI is the fourth industrial revolution in the mankind's history, and technology has advanced dramatically in the recent decades. The iPhone Apple is 1 million times more powerful than all computers in NASA headquarters in year 1985. And we can expect it to continue to advance at an accelerated rate in the years to come. And deep learning and AI have become widespread because of the availability of large digital data. And supervised learning algorithms have shown human-level performance. So to get huge data set with good quality control, there is a need of an annotation tool with a customizable feature set. And this multicentric study evaluated the viability of having an in-house annotation tool which work on a smartphone and can be used in a healthcare setting. So supervised learning algorithm like the convolutional neural network, they have shown human level or in some cases better performance in radiology, ophthalmology and in automated vehicles. But they require huge amount of labeled or annotated data and high variance if the grader is a fresher or an expert. And various annotation tools are available like the label box, supervisedly, and the labeling desktop-based graphic user interface. But they have many disadvantages of not being mobile. Progress of graders can't be supervised, loss of data because of hardware issue, no data exchange during the offline mode, and loss of annotation because of the poor internet connections in the periphery. So there are more than 600 million people affected by diabetic retinopathy and other retinal disorders, so they require better screening for early prevention and to evaluate the risk factors, especially in the remotest of the areas. So the objective of this tool were to quantify the amount of damage already done, segmentation of different lesions, and at present IDX DR by M. Abramov is the only US FDA approved AI-based equipment, but it is too bulky and costly. So we followed the ICDR severity disease scale for grading the diabetic retinopathy, and binary module based on CNN, a deep learning algorithm was developed for the referable retinal disease or the non-referable retinal disease. So it begins with 32 retinal specialists and 8 IIT engineers It started with an online tool, Label Box, for labeling of publicly available data set to evaluate the need of a customizable tool. So the advantages were many. We were able to grade multiple retinal images easily in a very short span of time. User-friendly tool using user interface and user feedback, integrated with advanced testing and internal validation sets. It was faster and mobile. We were able to track the progress, and domain expert feedback were also available. It has many special features of zoom capacity of 3 options and green channel for the red-free image, and brightness and contrast slider also to make few of the images which were ungradable to gradable. And we followed the smart image preloading system, that is WebP, so it maintains resolution of images but keeping low memory footprints. So this is a small video. So this led us to develop our own in-house image annotation tool. As seen in the video, adding in annotations for an image is pretty easy. View the image, magnify it, change the brightness, change the contrast as needed, click on the relevant option, choose the extra details, and the annotation is saved. The analytics on the landing page shows the pending and completed images. The graph shows the maximum number of images stacked by the other users in real time and gave the daily target settings. These imaging data sets are generally in the range of thousands and can be overwhelming for a single surgeon, so we chunk them into sets, each containing 1,000 images or less, which a grader can complete within 2 weeks. The issues mentioned earlier were resolved as follows. For faster image loading, we resized images into smaller size thumbnails with a smaller memory footprint and still maintaining the visual quality. We leveraged the asynchronous capabilities of the browser and didn't load just 1 but 3 images preemptively, so the grader doesn't need to wait for the next image to load. The initial interface was basic and evolved based on the grader feedback. It is now designed on a decision tree structure to render the nested subclassification and extra options. So we have seen a total behavioral change where on the online tools, the grader used to work only on the weekends, but on our tool, we have logged users on all days of the week. Average time taken to label a single image reduced substantially. We validated the AI algorithm developed using annotations on this tool on some new testing data sets and found them to have a really high performance scores. So this strengthens our hypothesis that this tool is no different than the desktop-based tools and with added benefits of being portable and flexible. So we wish to introduce more gamification, label optimization to be used in telemedicine. So this is how, when we feed any image, so it decides on the base of this DL-based algorithm whether to refer the patient or not. So in the conclusion, the user feedback and feature usage stats after evaluating over 2 lakhs of retinal images confirm our hypothesis with very high sensitivity. Now, we are able to develop an offline smartphone app which can diagnose patients of common retinal disease in less than 1 minute, 53 seconds to be precise, and very soon it will be available on Google Play Store. And this app will have a definite role in telemedicine and in bridging gap between man and machine. And this app will surely transform patient management in near future. And this study was published in Clinical Ophthalmology. Thank you so very much for giving me the opportunity.
Thank you, Arvind. I think this is the way the future will hold, how to get people getting a proper diagnosis, treatment. AI is the, in thing for the future also. We have to get adapted to these scenarios also. Thank you for highlighting these points.
Thank you, sir.
I think we've finished. We still have time to take questions from the audience one by one. And we would like to have, discussion on those issues.
So could we have the mic, please?
Can somebody give him the mic? Yeah.
So there's a gentleman there. So we have the August panel and, we have antibiotic prophylaxis, we have IOL power calculations.
Yes, sir.
And we have pharmacodynamics. So everything is on the table.
चल नहीं रहा, mic नहीं चल रहा है.
Yeah.
He spoke on Rexis.
Yes, Dr. Narang, sir. Sir, a question for you, sir.
The question क्या है, sir?
Question क्या है, sir?
How to adopt means to prevent Argentinian flag sign and Rexis? What all means we can adopt to prevent Argentinian flag sign and Rexis?
Sir, how to prevent the Argentinian flag in a rhexis?
We'll come to that. We have a talk subsequently on a white
I
intumescent
give
cataract.
only one tip to prevent the Argentine flag. As soon as you puncture the center, rotate.
Okay.
Within a fraction of a second, you have to rotate. If you don't rotate, it is going to extend if it has to extend. It doesn't extend always, but rotate immediately.
And sir, which technique is better, Utratus forceps or needle? Needle.
One another important point is do the lenticular massage. That means take a rounded depositor, or there may be invariable pressure points in the lenticular inside the back. So what I do after dyeing, I just take a rounded depositor, press it. You can call it donut capsular rhexis. Just push the fluid here and there. The lens capsule will become soft, and you'll be able to do it far better. Since I started doing for last 1 year, I had no Argentina flag sign. And if you have got, of course, Jepto and Femto, that is the best.
Actually, the problem is when the pressure inside the bag is more, then you have time. When you don't have time, what you will do? You should use a 23 or 24 gauge needle and press in so that nucleus doesn't come forward. You can aspirate the cortex, loose cortex. And that's the way you can reduce the pressure and then go ahead whatever it suits you.
Dr. RP?
Good.
Sir?
Yeah, any questions?
Sir, Argentinian flag sign.
Argentinian flag sign, yeah, because it's very, very important when you're dealing with the intumescent white cataracts. Your anterior chamber has to be pressurized, make the anterior capsule flat. Don't leave anything like, you don't use very sharp tip object to start the capsular axis. And don't tear the capsule with the capsular axis process in the beginning itself, because either you depressurize the capsular bag before you start the capsular axis. So depressurization can be done with a very good technique which I have invented, that is called as a saving needle microcapsulotomy, because you have to just puncture at the center of the capsule so that the fluid is evacuated, you decompress the bag and then start the capsular axis.
And sir, Dr. Tetial, sir. So Dr. Tetial is actually speaking about this in the next session.
Okay.
Sir, a few comments. We don't want, the talk to be revealed, but...
No. Let me summarize the entire session. Like, most important thing was, as we discussed, Dr. Harbanslal and nicely, Dr. Bharti nicely highlighted what should be your machine, what should be your settings, and because you have to know the machine first before jumping onto the surgery. People buy machines without realizing what are the beautiful adjustment can be done for those machines, and that we have to learn. Then comes the different surgical scenarios. And to achieve those, I think you need to first rehearse yourself, do a surgical training, see videos, get analysis from other colleagues, how this could have been better than what you have done, or achieving some thumbs up from other person, you are doing quite all right. That gives you courage to do a better in a difficult situation also. I think what we need to assess in all scenario is how I am doing. Every day we learn. It's not that you are master. Every day we have problems. Every day we succeed getting through those problems also. At this stage also, I see all my videos after I complete my surgeries. It might take me 2-3 hours to see them, but I see every day my videos myself and edit them also. And I realize what all things I was doing correctly earlier, now doing incorrectly now, and sometimes improvise. I see other people doing surgeries and learn from them also. That's a very important aspect. And what missing is sometimes we don't see the patient carefully before we jump for surgery. If you examine your patient appropriately, do some good investigations, which delineates the morphology of cataract, the anatomy of entire eye, you will definitely begin with a better surgical note and finish those cases appropriately. My only thing which I like to highlight is see your patient through a slit lamp, through the anti-segment OCT, and sometimes you may require a UVM to see the deeper part like a granules and other areas. But it is your examination which is going to make things really comfortable during surgery also. Intraoperatively, sometimes things change what you have seen. There you have to be aware what's going to happen next and take a safeguard for that and try to get back to the normal position also. I think the next session on that only, what next? how to prevent complication occurring. That I think that will highlight the more issues.
Okay, sir. So we'll be answering that in the next session. Sir, tips for beginners. What would be your tips for beginners? So I'll be coming to you also. Tips for beginners, sir. All right. Sir, boss से शुरू करें आपसे.
नहीं जैसे मैंने बताया for beginners the tip is पहले तो you have to do a hand eye foot coordination with your machine first. That may be dry run, that may be in a experimental area, goat's eyes. Your hand eye foot coordination has to be absolutely perfect to your system. The second is maintaining the integrity of visibility, because things which are visible you are going to do better job in your cases. Sometimes we blame difficult case. We make the difficulty because your microscope may not be giving you a good retro illumination. I've seen people operating without retro being on and they are struggling to see. To make sure you have a good dilatation, maintain the dilatation, clarity of cornea throughout the surgery is also important. We like to wet the cornea, put a viscoelastic coat onto the cornea which gives you clarity also. And most importantly, maintain the entry chamber throughout your surgery. If you understand this concept of maintaining the entry chamber throughout surgery, most complication can be avoided to a stage where you have a difficulties. You may have an Argentinian tear happening. You may have a rexus extension. If you maintain the chamber appropriately throughout every step, the chances of a tear going posteriorly is minimized. You can still come out with a good surgery in these cases. The one tip there is to minimize the entry chamber fluctuation. Second, as Dr. Harbans nicely told us, moderate your phaco energy, phaco power, fluidics as per the surgical scenario coming up. I think if these two people understand two important things, they'll graduate to a better surgeries.
So I think Dr. Titial has very rightly highlighted, and I always tell my residents, you don't have to actually develop hand-eye coordination on a patient's eye. Even if you don't have any synthetic eye or goat's eye, just put on a test chamber, sit on a machine, and see what is the audible sound, how you get the feel of whether you are in stage 1, stage 2, stage 3. If you devote 2-3 hours before and remember each and every button, suddenly you need a reflex, you don't know where the reflex is. So either R is written over there, and whenever we do live surgery, before we start doing, we see the operating microscope, whether it's going up, when it is going down, where the focus is. So every time you go on a sit on a table, you need to know all your buttons and use your seniors by recording your video and show it to them. Any resident who has shown me his video twice, third time he automatically starts analyzing it. So, sir, यहाँ पे ये गलत हो गया, यहाँ पे ये गलत हो गया, यहाँ पे ये गलत हो गया. If you can analyze your own video where you've gone wrong, then you don't need anybody else. You will master the technique very fast. Show your video to your seniors and ask them to analyze your surgical skill.
Dr. Bharti, sir. Thank you so much, sir.
So, one thing I want to say different from the other stalwarts, is first you must understand the technique and technology. For that you have to read as to what you are doing now and where you are. And once you have read, because reading is or studying the whole thing is very, very important. And second thing, my mantra for success is, if anyone can do it, I can do it too. That following that mantra is very important. You have to have confidence in yourself. Must create that confidence by reading and then follow it up with the procedure on the table. Yeah. Thank you.
So the first thing is believe in yourself and then make that belief come true. So Dr. Narang sir and Dr. Anand sir, last two comments.
I've already told about the Rexis, different types.
Thank you, thank you.
Thank you so much, sir. So it is a pleasure. So with this we come to the end of this session. I'm sorry, we'll have to cut it short. Can we have all the speakers for a group photograph, sir? And now I call upon Dr. Bharti, Dr. Harbanslal, Dr. Rohit Saxena, Dr. Rastogi. Can we have the moderators, Dr. Anand, Dr. Ritika, and Dr. Sanjay Mishra? So Dr. Anand is already here, and the chairpersons are here. Dr. Bharti, Dr. Harbans, sir.
Good afternoon, friends. So we are on to the practical relevance in cataract surgery, meet the masters. And we have Dr. Bharti with me. Dr. Rohit Saxena, I don't see over here. And Dr. Inder Mohan Rastagi, who is the co-chairperson. Piyush Kapoor, I don't see. Praful Kumar Marana is here. And Dr. O.P. Anand, welcome. And if they are Ritika Sachdev, Sanjay Mishra, Sanjeev Mohan, Vinod Byala, Vijay Gupta, Ajay Dave, J.S. Chilana, if any one of them are here, please come on the dais. So we have got a lot of stalwarts who will be talking about it. I don't see Dr. Khokar here. Is Dr. Khokar here? Anybody on his behalf? Gaurav Luthra, I don't see him also. So all those which topics are, those whose speakers are not there, we'll be discussing those topics afterward. And I'll invite Dr. Professor J.S. Titial. So we already had a stage set for him about the, has he gone for lunch? Or? Professor Titial? Professor Titial ki talk. Anyway, may I request Dr. Grover? Okay. May I request Dr. Grover to please start this session? Your talk is first, sir. Dr. A.K. Grover. Baki sir abhi aa rahe hain. I got a PCR. What do I do next?
नहीं बेटे वो उसको ऑन करना पड़ेगा
सर अभी आई नहीं डिस्प्ले नहीं आया
अच्छा डिस्प्ले देख लो नहीं बेटे वो अपने आप आ जाता है एक बार डिस्कनेक्ट करके फिर से कनेक्ट करो आ जाएगा पहले इसको मैं ये 1 मिनट इसको डिस्कनेक्ट करके एक बार फिर से कनेक्ट करो इसी से आ जाता है तो तुम्हारा है ये कन्वर्टर
डिस्प्ले सेटिंग में से वो मिरर ऑफ हो जाता है ना कई बार
चलो देख लो तुम्हारा अडेप्टर है तो अपना अडेप्टर पर ये मैं इससे चलाना चाह रहा था जो इसमें नहीं लगेगा ना So posterior, I have a display. So posterior capsular tear is something that you don't want to see, but we all inevitably will face it. So so this is going well, and the beginning of the phacoemulsification in a soft cataract, and the very first piece I create a PC tear. I've got a posterior capsular tear, what next? So when you get posterior capsular tears, the factors that you consider beforehand and keep yourself mentally prepared for are the risk factors. You need to see where, at what stage and how the posterior capsular tear occurred. You need to suspect it early, but what we are going to emphasize today is what to do. So in the what to do, picking up the posterior capsular tear early is the most important, crucial thing to prevent further complications from taking place. And all these observations help us to diagnose it well. The stability of pieces, the rotation of fragment becoming difficult, and your followability gets affected once vitreous comes into the bag. If the posterior capsular tear occurs at the last stages of the surgery, as we have in these cases, we have cleared most of the lens matter, and it is only during the last fragment that a surge has caused a posterior capsular tear. Things are much easier to manage. But a tear occurring early is more problematic and requires a greater effort at management. And we need to be familiar with all the management aspects of handling the nucleus, handling the vitreous, and the placement of implant thereafter. So an early PCR is particularly liable to happen if there has been a capsular excess which has not been complete for some reason, or you have a soft cataract and you've used too much energy with a fragment causing a posterior capsular tear. So once you realize the posterior capsular tear and you've filled the anterior chamber, you withdraw and plan the further management. So most important thing is to be cool and comfortable, not to panic. Make sure this is a posterior polar cataract we are tackling, so we are going very slowly. We are using safe parameters. We have removed the nucleus. We are now taking care of the epinucleus and the last part of posterior capsule. But as soon as we remove the posterior capsule, we will see that there is a pre-existing tear that is seen. Now, the important thing is to stop working at this stage, form anterior chamber with viscoelastic, so that more vitreous will not come because of the positive pressure from behind, and withdraw slowly from AC, and then think and plan your strategy further. Many a times your vitreous face is intact and you can plug the posterior tear with a dispersive viscoelastic like Viscoat. Some central PCCs can be converted some central breaks can be converted into a PCC, and you are able to support the nuclear fragments even if the vitreous loss has occurred at times after limited vitrectomy with a sheets glide or an IOL scaffold, as we'll see in some of the later examples. And then vitreous management at each stage is important to avoid any traction to the retina. Now, you can choose either to continue with phaco if you are an experienced surgeon and you have a limited break, you've been able to support the pieces well, but at other times conversion to ECC is the better step. If you choose to continue with phacoemulsification, you need to have low parameters and handle carefully. Now, this is a capsulorhexis done by femto, and we can see that because of the escape of the fluid, it is not a complete rhexis, and we are trying very carefully to complete the rhexis by manual maneuvers. And we feel quite confident that this is fine, that rhexis is stable, but it obviously wasn't. And as we start doing phaco, we realize that there has been an extension of the tear posteriorly and the lens is unstable. Now, at this stage, you have a fair amount of lens matter left. You can do the limited vitrectomy to make sure that the vitreous is not present anteriorly. And at this stage, you can put in a lens as a scaffold and carry out the rest of the maneuver to remove this remaining lens matter in front of that lens. Conversion to ECC may require peribulbar or parabulbar anesthesia if you feel more confident with that. And then sometimes you need to incise the rexus and create the appropriate incision for nucleus delivery. Creation of a fresh incision is often preferred. There should be no fishing of fragments in vitreous, which is so important. And if there has been a nucleus drop, then the results are very good with the current 25 gauge vitrectomy, and you should not worry too much about it. Just hand over to a friendly surgeon. Now, the important part of vitreous management is a separated port vitrectomy. You should have two separate ports for vitrectomy. Should be using the cut IA mode, medium to low bottle height with the highest cut rate, and a vacuum limited to 150 to 200. Should not let the chamber collapse. And make sure at the end that you make the pupil round. You can use the blunt spatula for sweeping, and intracameral triamcinolone is a very useful method for picking up the strands of vitreous. Now, 3-piece IOL in sulcus can often be inserted if you have the anterior capsular rexus, but at times that may also not be feasible, and you may need to use a quadriflex lens or an iris fixated lens. I usually would use quadriflex IOL in such a situation, but you may use a scleral fixated or a glued IOL as well. Now, an example of the entire process here, you have an early rent here, and we are going to decide to enlarge the wound. But before that, we have delivered the fragments from the bag anteriorly. It's already divided into fragments, so we do not need to do any capsulorhexis extension. And you are able to get the fragments out after extending the wound by viscodissection alone. You may support the fragments if you require with two blunt instruments, or you may at times use a posterior support as well. But any fishing should of course be strictly avoided. Dry aspiration can be done with the phaco tip itself using the IA cut mode, and then you can place the lens in the sulcus. Now, at the end, you again have to make sure that there are no strands, which we are able to do if you put some pilocup in, and if you use triamcinolone, remove any strands, and then close the wound. So skills of a surgeon are best assessed by his management of complications, and in spite of posterior capsular tear, you can manage those cases well with most rewarding outcomes. Invite you all interested in oculoplastics to come to the World Society meeting in Dubai. Thank you.
Thank you, Dr. Grover. Just one question from my side. Most of the time, management of the nucleus is comparatively easier because you can, particularly if it is a little former, you can manipulate and handle it. And even if you leave some amount of cortex, it causes so much of a collateral damage. This is the management of the EP nucleus, which I find is the trickiest of all, because manipulating them, taking them out, collapsing from the capsular axis is difficult. And if you leave them, there's a lot of bulk left behind, which keeps on causing a lot of inflammation post-operatively. So how to handle that, the epinuclear part of the...
So the important thing is, if you can use, if you find that your edges of capsular axis are good, and you've been able to deliver out the epinucleus anteriorly, then you can use an IOL support, IOL scaffold for that. At other times, it becomes very tricky. If you are using an infusion, the epinucleus often tends to go back. So you can do a dry maneuver initially. Just make sure that you are able to suck it out or deliver it out after, if you are enlarging the wound. If you're not enlarging the wound, then of course, there can be a little difficulty if the infusion is on when you start your vitrectomy. And then that is the one time when it tends to go back. So make sure you do whatever you want to do to epinucleus to bring it forward, make it more secure before you start your infusion in vitrectomy. That is one important thing.
Yeah, I wanted to say that, of course, Ashok has told that vitrectomy is the way to go, but what I want to say is that I don't want to add the infusion at all. It's only the suction and then cutting, which I want to use while doing vitrectomy for epinucleus. It's sometimes, you know, if you use infusion, as he said, already it starts going down, but vitreous always is, you know, an issue when you're removing the epinucleus or a cortical thick cortex with the IA. So then the best thing is to cut the vitreous at that point in time with the vitrectomy without infusion totally.
Yeah, vitreous handling is first and foremost important. You should have no vitreous left in the anterior chamber and securely gone back before you start all these maneuvers for delivery of epinucleus and cortex, etc.
So in my personal experience, usually subincisional epinuclear plate is very, very difficult to manipulate and bring it forward. And as soon as you put infusion from the top, epinucleus is going to drop down or going to stay there. So if there is enough of epinucleus, I think all of us need to learn to put the infusion from the pars plana. Because now the fluid will be coming from behind and leaking towards the incision. There will be less chances of epinuclear falling back and will be easier to manipulate. So the pars plana is the way to go so far as I feel, because whenever I try to rotate the epinucleus in a presence of vitreous with the rounded depositor, either you will not be able to rotate it or you will really shake up the vitreous too much.
Pars plana is always a good option wherever you have those. It's a simple maneuver, but the anterior segment people have to get rid of that mindset of not doing it. Just a trocar to be put in.
Thank you, Professor Grover. Now I'll invite Professor Titial, and he'll be talking about one of the very important topics, intermittent cataract encounters Argentinian flag sign. What next?
दूसरा ले आओ फिर।
Dr. Itika, come on this stage.
दूसरा ले ले आगे लो छोड़ो it's not coming huh? डिस्प्ले में जाके इसके मिरर
In the meantime, I would like to just extend what Dr. Bharti said that. So basically, sir was saying dry IA he prefers to do when there is vitreous. So when you prefer a dry IA, is it the viscoelastic that is filling the interchamber, or you have assistant instructed to, because there is bound to be AC is going to be shallow after some time. So how to tackle that?
Are you ready, Dr. Tial? Are you ready?
Yeah, I'm ready.
Go ahead. I'll answer this question later.
Thank you, chairpersons and DOS, especially Dr. Rajendra Prasad,
for doing such a wonderful, webinars, now physical meeting. And this particular talk is, just a continuation of a discussion we had just before the previous session. How to tackle the intermittent white cataract, what all things you encounter, how do we proceed, and what happens next. The basic idea is what happens next in this. The first video which I'm going to show it is from Dr. Namrata Sharma. Would have happened more than a decade back. So this is the intermittent white cataract. Let's see what happens in this particular case here. So this is a cystotome, needle cystotome. You make a nick here, small nick, and without a blink of your eye movement, that tear goes to periphery to periphery. Now this is a situation, what should be done at this particular moment. The idea here is what she's doing is filling the antechamber with viscoelastic, making a nick in the peripheral areas, like this particular area, then make it a semicircular area. So you have a little bit of both sides you have a half capsular axis happening. So this is a technique they described bimanual, making a support from other instrument to make a nick here, then tear it out in a similar fashion as you did. So this was a young patient, and you know that in young patients there are very high chances of intumescence, especially a rapid onset cataract, and this is what this patient was. And once you complete this area, which is gone nicely, and subsequently aspiration can be done in a one go and implant the IOL. The idea here is to maintain the chamber pressure as we talked about. In this particular case, you can see holder-folder technique was used, a three-piece lens, because whenever you have this type of a tear in the capsule, sometimes the foldable lens may not be desirable. But this is a time where we injected the lens in the bag. You can see lenses inside correctly placed. So you can see this was one case where we didn't have a chance to understand what is happening. You could not react to preventing this tear going to periphery. The examination is a very important aspect in these cases. See the entry chamber, shallowness of the bulge of anterior capsule, shallow chamber, and the pockets, interlenticular clefts, which can be seen by anti-segment OCT also. So this is the second case which I was operating. You can see it is the intermittent white cataract. You can see pouting of anterior capsule also. I made a nick. I'm using a high molecular viscoelastic here. Again, you can see the tear is trying to extend to periphery. What should be done at this stage? So I was just thinking without withdrawing my needle, I thought, what should I do here to decrease the pressure going to periphery? I made a cruciate cut in this particular case here. The pressure radiated to 4 areas, and that would have prevented the leak, tear going to periphery, and there's a leak of a fluid coming out. If there's some leak happening, you have a high chances of decreasing the pressure in these cases. Next important thing is not to let this go to periphery and try to make the rotation of flap in such a manner which encompasses the peripheral area also. Here I could achieve this side, but this side a little tough. I'm using a vitreoretinal ILM peeling forceps here. I thought I'll go to periphery, but I could not succeed here. So this is a weak point again. So I'm making a capsule opening a little bigger. So I'll rotate this flap in such a manner it goes to peripheral area and doesn't leave the weaker area. The important thing, whenever you have a tear extension happening, make sure you have a circle at that area so that this becomes a rhexis and doesn't allow further enlargement happening during the procedure in these cases. So this is an opening which is ideally not a suitable opening for an IOL, but it's an opening which is good for doing an emulsification. So I completed the emulsification here, trying to aspirate the peripheral cortex with bimanual aspiration. Subsequently, after implantation, you can enlarge the rhexis to a desired size. So you had 2 areas. One was where you have no opportunity to do anything. Second case, I had an opportunity to do something because I had used the viscoelastic, which made a pressure onto the anterior capsule, retained for a longer period, and I was operating from the side port. So this is what we can examine your patient. This is, I could picturize these images from my IOCT microscope. Similar thing you can see in your anti-segment OCT examination also. The type 1, you have a homogeneous fluid there. These are the cases. The intubation can be decreased by needle aspiration. You can do a micropuncture. You can aspirate, then it will go down. The type 2 is the fibers which is going across the hydrated fiber. The clefts are underneath that, and it becomes very difficult to aspirate these fluid with needle. So these cases should be approached differently, And this is the case, any sort of manipulation will be, can be effective. This is a type 4 where total fluid is there, milky fluid will come out. And the advantage of IOCT is after you make a nick, you know what is happening in these cases. So this is one case. As soon as I made a small opening, you can see the entire bulge of a cortex coming out like a hill. And there's an imminent chance of a rexis going to periphery. This is the same case. You can see I'm making a smaller nick here. As you discussed earlier, make a small rexis as soon as possible with rotational flap. This is the area where I have to put another viscoelastic in the periphery. I normally use a dispersive, which maintains the peripheral pressure. After making a smaller opening, aspirate the cortical fibers. You can see the entire thing has become a flat now, and you can do a rexis subsequently. The idea is to decrease the pressure in such a manner where the convexity becomes concavity, and you can complete the rexis in these cases. The third option, if you have femtosecond laser with you, there you can make the pressure release in a closed chamber. There is hardly any chance of having an Argentinian flap in these cases. So this is, you can see a milky fluid will come out as soon as we make a laser in these cases, and that will decrease the effective, you can say, release the pressure in these cases, and chances of rexis going to periphery very, very minimal in such cases, and you can complete the case very effectively in these cases. The similar thing people have done with a YAG laser application pre-operatively by multiple punctures in a closed chamber, and that also decreases the chances of extension to periphery in these cases. Again, I'll summarize. The anti-segment examination is very, very important to realize what type of case you are dealing with, especially wide cataracts. And if you have access to anti-segment OCT, please do it. That will really delineate the picture like this, and you can applicate your surgical skill in these category of cases of wide cataract. So good examination, good viscoelastic, and good technique will decrease the chances of Argentinian flag in these cases. Thank you for your kind listening.
Thank you, Professor Tayal. Finishing on time, wonderful talk. Only I will like to give just one suggestion to the audience. Whenever there is a capsular rexis extension, there are two types of extension. One is a curvilinear, one is the straight or conal, like Argentinian flag sign. The conals are a little more risk of their running into the posterior capsule as compared to curvilinear. When you are doing a rexis which gets extended, so the chances of getting extended to the posterior capsule are much less as compared to the conal. So whenever you get a conal already highlighted, then in those cases, of course, in any case, you should never allow the chamber to collapse whenever you are doing phaco to prevent the CME or vitreous traction. But in a conal capsular rexis, you must ensure that never ever chamber becomes flat. As soon as the chamber becomes flat, the posterior capsule comes forward and the rexis runs backward.
I think I had to talk in an intumescent cataract, so I didn't highlight the density of nucleus in these cases, because that's another challenge in these group of cases. Normally, we see a softer cataract in an intumescent wide cataracts. The hard cataracts are normally seen in those cases where have more of a fluid-filled cataract, like hypermaturity type of cases. There, the nucleotomy will be really challenging if you have a tear like this, running periphery to periphery. Then you have to take a call, when should you proceed with the phaco, or when should we shift to a SICS type of procedure in these cases. Thank you.
Thank you, sir. Thank you, Dr. Tayal, for a wonderful talk and very self-explanatory videos. I'll now invite Professor Namrata. She'll be talking about optically compromised cornea, how to go about. Dr. Namrata. And in the meantime, till the time, when Dr. Namrata is starting her talk and the presentation, I want to say two things about what I said about vitrectomy for cortex and epinucleus, that you have to keep the bevel or opening of the vitrectomy down towards vitreous so that you do not damage the rexis. And also, when you cut a little bit of vitreous, the whole cortex and the epinucleus starts falling down and getting into the. So you should be very, very careful that you do not keep it up, because then you will not be cutting the vitreous, but you will be trying to suck, and that is not the way to do. Professor Namrata.
Sir, I can't move. ये ना इस पे करना है. I want duplicate here and there. इसको click करना है तब आता है use slideshow. इसको click करो. Cursor ही पता नहीं कहाँ है तुम्हारा. नहीं, I don't want this. I want duplicate show. नहीं. Now it's okay. So thank you so much, Dr. Bharti sir, and it is always a pleasure to present at your own platform, and that is DOS. And I would like to thank Dr. RP sir for this wonderful program and invitation, and Dr. Balla for organizing this. I would be talking to you about phacoemulsification in optically compromised corneas. And optical compromise could be in the form of a leukomatous opacity which is so localized so that the rest of the cornea is clear. Now, I have not edited this part. I just want to highlight the fact that if you do lose the edge of the rexus underneath the corneal opacity, it is difficult to find it. So you should stain it, double it up so that the contrast gets better, and don't leave it under that opacity. Now, because your 3/4 of the cornea is clear, you can do phacoemulsification easily, but do phaco in situ, which means you chop, you eat, you chop, you eat, so that the orange or the red reflex gets better and better. And as you have more of this orange reflex, the things become clearer. And after, of course, doing the nuclear emulsification, irrigation, aspiration, one can then do a foldable intraocular lens implantation. Now, this is a case which I've shown before also several times, but I think the advantage of this is that it encompasses everything that can happen in a corneal opacity. So this is optical adenectomy, this is hard cataract, this is leukomatous corneal opacity, and this is a one-eyed patient. So here, like in this case I showed you, don't lose the edge of the rexus there. And if you do, you have to manipulate the globe. Now, because the optical adenectomy is there, the rexus is eccentric and the crater is also eccentric, because that is the area which is visualized. Now, this is a hard cataract. So again, retroillumination has to be on. For that, one has to be careful. And then do phaco in situ. So you chop and you eat. And notice that as you do phaco in situ, things will get clearer, and there would be nuclear fragments which will get camouflaged underneath the opacity there, which have to be lollipopped in. And then again at the end of the surgery, be careful to see that there are no nuclear fragments which are hiding underneath the opacified area. Now, this is just to showed you the first case, which is a leukomatous corneal opacity, but you can have nebulomacular corneal opacity, and that is more annoying than a leukomatous corneal opacity, because corneal clarity is of utmost importance in these cases to manage them. So this is a nebulomacular corneal opacity, and again I'm trying to make a larger rexus than would be desired, because I know that in cases of corneal opacities, if you make larger rexus, your work becomes a little bit easier, because otherwise it becomes difficult to handle the nuclear fragments. Then whenever it gets blurry, put that blob of viscoelastic, because for that split of a second at least, it will get clear. Notice again in this case that the incision is temporal, because this half of the cornea is the one which is clear. But because it's blurry, not able to make the chops. So in such cases, when you have a central nebulomacular haze, make peripheral chops. So when you make peripheral chops, the advantage is that if you, in such cases, attempt central chops, the nucleus will spring back again. But if you make peripheral chops all around, then it is not going to spring back again. And it is going to become flat rather than become a globular nucleus. It will become like a plate, and so it will become easy to emulsify. So although this didn't look very hazy and doesn't look now because of the red glow, but to do this case, it was more difficult than the first case, which was a leukomatous cornea. Now, this is, of course, a black and a white cornea where tattooing has been done for corneal opacity. So you have to release the synechia. Pupil is small, so use nylon hooks. And again, don't lose the edge of the rexus there. Just get it in one go. Intraopacity microscope does help you if you do lose the edge of the rexus. The nuclear emulsification is done again, and phaco in situ is being done. And this is followed by irrigation aspiration foldable intraocular lens implantation, and removal of the nylon hooks, as well as enlargement of the pupil. So when you enlarge the pupil, always put air bubble and then put pilocarpine and check on the table itself what is going to, from wherein the patient is going to see, what is going to be the patient's area of visualization. So I think this pilocarpine test is a good check to address things, to know what is going to happen post-operatively. Now here nylon hooks is used, the temporal incision is made, and this is the endo-illuminator which is being used inside the eye or intracamerally to see where we are chopping. And this is the foldable intraocular lens which is being implanted, and the endo-illuminator is outside to see again where the rhexis is. Now, some of our cases which we had published also, cataract surgery in haze, and they do well, they don't get 6/6, but they do well so that they do become ambulatory, and sometimes I think that is the aim, especially in high-risk cases. This is again not a very good outcome, but then the patient becomes ambulatory without having to do a corneal transplantation. Now there are times when you have to use endo-illuminators such as this. In this case, the DSEC with phaco and intraocular lens implantation was being planned. So an endo-illuminator is being used, and as you put the microscope light off, the endo-illuminator, the chandelier on, you can actually see what you are doing. And this patient also had a retrocorneal membrane which was present, which had to be dealt with. Can do capsulorhexis in these cases, followed by the nuclear emulsification and foldable intraocular lens implantation. And this is the retrocorneal membrane which is being again cut with the help of the ILM scissors and the ILM forceps. And subsequently, when you do see at the end with the help of the microscope, then the view does get clearer. And like I said, that this was the picture which was eventually there in the intraoperatively on the table itself. Now, this is a case where both endo-illuminator and chandelier has been used, a post-penetrating keratoplasty case where nylon hooks are being used to expand the pupil. Subsequently, the capsulorhexis is being done, and again put viscoelastic when you do that. And nuclear emulsification was difficult to do in this case, so the endo-illuminator was used as well as the chandelier was used, depending upon where the view would get clear, and this is the chandelier which is being used to do it. And both sometimes may be required to get the view which is clear. Irrigation aspiration is done, and this helps you to know in haze that the whole PC is actually intact, and this is followed by a intraocular lens implantation. So I think I would just show you this, that in cases of corneal haze also, that flax is of benefit, because wherever, suppose you're doing a capsulorhexis, in the area of the haze it will not cut, but rest of it will cut. So where the rest of it cuts, you can just make the capsulorhexis there. And likewise, even for the splits or the chops, in the area where it is not chopped, those can be chopped, but the rest of it would be chopped sufficiently for you to allow your surgeries to happen. Again, this was a very hazy case, but capsulorhexis was possible by filling up the gaps, and foldable intraocular lens implantation was possible in this case. This is our review article on phacoemulsification with coexisting corneal opacities for everyone who wants to actually read in detail, and this does give everything including the corneal transplantation. So to conclude, incision placement is important, retroillumination should be on, aids are required like nylon hooks, optical iridectomy, trypan blue dye, endo-illuminator and chandelier. HPNC on the surface is a very good technique to magnify things and also improve visualization. You need dispersive OBD and BSS plus if possible. Eccentric crater for paracentral opacities and peripheral chops for central opacities is required. Phaco in situ generally helps in these cases because it helps to improve visualization. The parameters should be low fluidic parameters should be used, and the patient should be counseled that ambulatory visual acuity is what we are looking at. Thank you very much for your kind attention.
Thank you, ma'am. Any questions from the audience? Next like to request Dr. Gaurav Luthra, sir, to please set up, you'll be taking us through the small pupil phacoemulsification.
Madam, one question, Dr. Namrata. How many cases you operated with phaco and you subject to keratoplasty later on?
That is a data which is going to be difficult to get. But what happens is that sometimes, because of the paucity of good quality donor material, the patient has a cataract and has a corneal opacity also. So in the interim period, you can do this cataract surgery and then wait for his turn for cornea to come. But having said this, sometimes the patients are one-eyed and they don't want a corneal transplantation. So in those cases, they just want a cataract surgery because they had been ambulatory or doing their work, normal activities also. So in those cases, we would just do cataract surgery, because if you do a graft, then the story actually starts after you do the graft, because it's a lifelong follow-up. This is not a lifelong follow-up. This, if you give visual acuity so that, the patient is able to carry out his activities, at least the patient doesn't have to come from far off places again and again for the whole life.
Absolutely correct.
What is your choice of IOL when you're putting in an IOL for a patient who has corneal opacity?
So it's a monofocal intraocular lens. Always, I don't like to put there is no scope of a multifocal lens in these cases. And next you'll ask me, how do you calculate the IOL power? So it's from the fellow eye?
No, because a lot of times when the corneal opacity is quite bad, a three-piece also comes to your rescue if the visualization
No, three-piece
is not,
always helps. I mean, I would always keep a backup of three-piece, because you never know. Sometimes the rexes might, may not be as you desire. And having said this, we've had cases, I can remember at least 6 or 7 cases, and now we would have series of many hundreds of cases, but 6 or 7 cases where we couldn't put the IOL because we couldn't see as much. So we had to leave them aphakic and plan IOL on another day when, you can see where you have to place it. So three-piece always has to be there as a backup.
Thank you, ma'am.
Thank you.
Please.
Same IOL we use for eccentric opacities also, but care group of company can make an IOL with the eccentric optic also for you, which means that the haptics, we've done it in 3 eyes only as of now, which means that they will make asymmetric haptics also, so that one will be short and the other will be long.
So what's your experience so far with that kind of IOL?
That is doing well, but this we've started very recently, so when we have long-term results, I will let you know.
So what are the challenges of centering such a IOL?
Challenges of centering are not really too much, because the material that they are, only thing is you have to enlarge the incision, because the material that they are making it is not foldable, it's a rigid lens.
Rigid lens.
No, I think that I have not, I have not tried that.
In a situation, if you don't have it, and then this is the only way you have done a good surgery, and if you put in the sulcus, it will be eccentric.
Yeah, that I haven't tried, because we are still working
The only
on
problem,
this.
because I have seen some cases where one haptic is in the back, one haptic out, there would be a tilt of the IOL. And if you look actually these cases, you will see very high astigmatism. So, no, it happens.
Tilt will happen.
Hello? Okay.
Very good afternoon to everyone, and I would like to thank the DOS executive and the president, Dr. Ranjit Prasad, for inviting me for this important meeting. Delhi is second home for me almost, having spent more than 10 years studying here. And we can already see small pupils being stretched over there. So, so I was asked to speak on small is beautiful and it can be tackled. So wanting to start on with that, I pulled out a very old video. This is from 2014, but it conveys a message. So sometimes you have these healed uveitis patients with small pupils, and you can see I'm holding conjunctiva with a forceps, which I never do for the last 8-10 years now. But if you watch here, I'm just going from the side port and pushing fluid inside. And just with distending the chamber with fluid, sometimes I can get a pupil which will expand very nicely. This is to just break the sine case. So it's a very small little thing, but I tend to do this a little bit at the start of a case with similar things, and it just opens up the sine case rather than going in and trying to release them like this. So this is a small tip which just at the start of the case can help you. Another situation here, when your pupil is small and the rhexis sometimes tries to go under the iris, and you are getting stuck there. So you can try to visualize using this white tip manipulator and assess where it went. And then of course you need to go under that and get it back. Viscomydriasis will help in this situation. I use Viscoat, it really works well. You can see that it's just pushing the pupil away and allowing me to see. And then I can just move it aside with the white tip manipulator and go with a microrhexis forceps and retrieve it with the Brand's little maneuver or whatever works for you. So this is another small tip that sometimes will help with small pupils, especially for the rhexis if it's running out. Going on, I mean, somebody like Dr. Tityal can write an encyclopedia on how to tackle small pupils, but I'll just try to stick to a few common things. And here we were in a situation where the moment we made the incision, there was an iris prolapse. So at this point, and it was a small pupil, you can see it's getting smaller and smaller because iris, when you touch it, it tends to constrict. So first thing I thought was to release the upthrust. Somehow we had at that point used a wire speculum. I immediately switched to a self-retaining speculum, which will put less upthrust, so you can immediately have less pressure on it. And somehow it's repeated there, I'm sorry. And then you have to see if you can still proceed. You can use your usual maneuvers. You can try phenocaine, or you can try other things medically if it works. I thought it might stay, but it was getting smaller, and once I managed to somehow get a smallish rhexis, which was not good. It was not enough, and the iris was beginning to come out. And it was obvious here now that this surgery will not be able to go on any further. So once I have a rhexis in place, I prefer not to use one of the rings. I prefer not to use the Malugins or the BHEX, which otherwise I would use at the start of a case, because once your rhexis is there, for one time, maybe 10 years back, I had a Malugins ring which went and got caught on the rhexis because I couldn't visualize it. And then there was a situation. So iris hooks are amazing. Somehow I think iris hooks are very easy for everybody to use. They are reasonably priced, and they are very easy to implant. You can put 3 or 4 or 5. You can even put one under the incision to whatever gives you visualization. So very controlled devices, and always should be available for rescue. And as you can see here, it becomes a no-brainer, and you can complete the surgery and get your lens in. And sometimes at this point, you can see my placement of hooks was not ideal. I should have put a hook somewhere here as well, and that's caused some iris trauma, which is because it's trying to come out there. So then you have to sometimes use your left hand instrument to keep the iris away and then put in the lens. So that will usually work out. So going on, this is one of my favorite devices. I love to use the Malugins ring. Have been using it maybe for more than 10-15 years now. It still works very well, just that it keeps getting more and more expensive with every passing year, and you cannot use it for many cases. You will end up using it for maybe 1 or 2 or 3 at the most, and it eventually breaks. So once your ring is in, and some people can actually get these 3 twirls in even with the injection. Sometimes you can't. If you have a very small pupil, they come in 2 sizes, and then you can just get it. And once you have this, it works very well. It's very nice to put, and it's very easy to remove. And now you can actually get it in from a 2.2 millimeter incision quite easily. So once it's in place, it's easy to proceed. And then, of course, once you implant the lens, you have to be a little careful that your lens should not catch the Malugins ring. One time I've had an instance where the Malugins ring got dislodged with the IL injection, and then it can cause situations for you. And then just disengage it, and it's very easy to remove with the injector itself if you want to use it with the injector. And let's see if at this instance I removed it with the injector. Yes, so you can engage it, and then the critical thing is that when it reaches this point, you have to gently press it so that the two of them coincide one over each other, and they kind of engage each other, and then you can pull it back. So that helps you finish the case quite well. This is our very own B-hex ring, and it goes in from very small incisions, and sometimes if the pupil is very tight, you may have to stretch it and then get the ring in. So the ring works beautifully. It can go in from a 1 millimeter side port incision. I like to now use the forceps. This is a slightly older video, but you can engage it very nicely with those forceps which come with the machine. And I'm sorry about the virion coming in the way. To the surgeon, the virion is not so prominent, so it stayed there. But it makes a nice, good pupil, and it's much more reasonably priced, works well. It requires a little bit of learning, more than the Malugins ring for what I understand. I prefer to use the Malugins ring if I can. B-hex works very well too. I'll try to come to our last video. And here was another patient who had a small pupil, a PI, and we did a small stretch to see if this will work. And sometimes it's not a good idea to stretch it far, because then you'll cause a lot of tears. But if you can just get a small pupil, sometimes that's all that is required, and then you can proceed to put viscoelastic, form the pupil. Here I just wanted to show you a small thing which I innovated. Once you get the cataract out through the small pupil, you can do the cortex removal, but sometimes the cortex will remain. So I've devised this small white-tipped infusion cannula, which can be used as an infusion, and you can see that it can just move the iris to the side while also doubling up as an infusion, and gives you very good exposure. And then you can remove the cortex very easily. So it's a very versatile instrument because it doubles up as an infusion and as a white-tipped infusion cannula, which can be used in any of the clockers. And I think since I'm out of time, I did have a couple of more videos, but I'll stop here. And this makes life easy. And you can also see that since we are implanting a toric lens, this white-tip spatula will also give us adequate exposure to check that the toric is in place. So you can see that I'm checking on one side for the toric alignment, and then I'm checking on the other side. So this tends to make you a bimanual, versatile instrument which helps you finish your surgery very well. With that, I'll stop. Thank you so much.
Thank you very much, sir. For experience and yes, small pupil size phaco can be done, but would you recommend the same for beginners or maybe those people who doesn't have that much experience? Won't it be a good idea to go for?
So I think for beginners, what's important is if you're dealing with a small pupil, first of all, don't do it topical. Make sure that you are giving a block, an adequate block, and preparing for the case well. You should prepare with, if you have reached a particular level of expertise, I think iris hooks would probably be the best way. Phenocaine is amazing. I mean, it's definitely worth giving a shot of phenocaine. It tends to save you in many situations, and you can come out of those, and it gives you for a while a pupil which is enough. But I think for a beginner, they have to know their abilities, and then of course, they should know all that is available in the armamentarium, and then whatever they are comfortable. I think iris hooks and the devices would be fairly easy to use for any phaco surgeon who is proficient. And then if they can't, then they should definitely not, try to push a phaco surgery. They can always switch to another surgery that they are more comfortable with. So,
thank you, sir.
Initially, we are using the adrenaline in that irrigating solution, but now the chemical devices are very good. And most probably, but I've seen that it's not the small people. Even though you can do the surgery under adrenaline without any device, but the floppy iris is a definite problem. Once you start moving here and there, then it doesn't allow you to work, in fact. So,
I agree.
Perfect surgery, sir. Thank you very much.
Thank you, sir. Now I would like to invite our next speaker, our own president, sir, Dr. Rajendra Prasad. And sir will be speaking on IOL gone wrong, IOL exchange surgical pearls. In the meantime, any question from the audience?
Okay. Good evening. I'm going to talk about IOL gone wrong, and this is a video. डायरेक्ट कर देता हूँ। ठीक है, so we all have a very high dreams to fly very high, but the landing is a problem. Many times we err in the landing, and this is what happens if you are not landing properly. So ill-judged landing. This is what happens in phaco surgery also. When we put the IOL into the bag, your IOL is not positioned well and not landed well. So you can see here in this particular case, one of the haptic is stuck with the capsular margin, and another haptic is in position. The trick here is do not push and pull the IOL. Always try to dial the IOL. Just dial it, and you can see you can very easily dial these IOLs if you do not push and pull. Because if you push and pull, then you can going to hurt the zonules. And then finally, like you can just replace the IOL into the back. So this very simple technique. Many times what happens, you fight to stay afloat, and your IOL similarly can float on the vitreous and the capsule. Now you can see here, this is the trifocal IOL which is implanted. One of the haptic is, it's a plate haptic IOL. One of the haptic is in the bag, other haptic is gone into the bag, and it's gone actually into the vitreous. So what to do now in this particular case? What I'm trying to do is I'm just taking out this haptic from the bag. Now this is the IOL you cannot dial. So you have to just pull the IOL and bring it on the top of the capsular bag. And as you can see, the moment I brought one of the haptic on the bag, so you can very easily bring the other haptic out of the tear in the capsular bag, which is there, the posterior capsular tear, and finally you can place this IOL on the capsular bag in the haptic, in the sulcus. And this worked very well. So this was the best solution for this particular case. Otherwise, I would have gone for the IOL exchange in this particular case. And this patient did very well. We had to do the capsulotomy later on, and patient regained his full vision. But many times, what happens if you are landing not properly, you go into the deep water, your plane may sink into the water, and similarly, your IOL, when you put the IOL wrongly in a tear, now this is what happens. Your IOL is about to sink into the vitreous. Now what to do in this particular case? So what I'm trying to do is, because just hook and dial, as I said in the beginning, dial it. The dialing is the best way, because don't pull and push. Just dial it. Your another haptic would also come out from the vitreous. So you can see, because one of the haptic, I brought it out, and now I'm going to put it into the sulcus, and see the other haptic has already come on the capsular bag. So this is the simplest way to reposition such IOL without going for the exchange or doing anything else, or the scleral fixated IOL. Now, other situation, off-target crash landing. So if you are not well targeted, you will have this kind of problem. This is a RK patient operated, IOL gone in, was not targeted well. Patient had a very high refractive error post-operatively. I had to do the exchange. And the exchange in such cases is again very, not very simple, especially after the RK, because you don't have the area to go inside and take out the IOL. But another important point is, as I'm trying to show here, is hook and flip. So this is the technique to bring this IOL out of the capsular bag, hook and flip. So just hook it and bring the haptic out of the capsular bag, bring it on the anterior surface of the iris. And this is one technique. You just draw one of the haptic out of the incision, hold it, and then cut it. so that your IOL is not flipping inside. You are not going to damage the capsule, the endothelium of the cornea. So you have to be very careful about the endothelium. And a good amount of the viscoelastic is very important. Now, as you have seen, I have cut this IOL. 3/4 of the IOL is cut. And then I'm going to draw this IOL out of the bag, out of the anterior chamber by dialing and pulling it out. So you can see very simply, you can bring this IOL out of the bag. This was the IOL. And then I'm going to place an IOL inside now. And it's not so difficult now, putting the IOL, and this IOL has gone into the bag. So this was a patient like where there was a very high refractive error, and finally the patient regained his full vision without glasses. The IOL calculation was done with the ASCRS calculator. Now this is another case because the cloudy vision, because if you have a very cloud, you cannot fly very well, and you may err in your flying, and you may get a problem in going to the destination. And this is the IOL which is gone cloudy. Now you can see this IOL is completely cloudy IOL. This was a hydrophilic IOL, and the reason in these cases is the calcification is one of the important points, the fluid going into the lens. And here also what I'll be doing is, after injection of the good amount of the viscoelastic, going to hook and flip. So use a hook and flip this haptic out of the bag. But in this particular case, as you can see, because while I was flipping one of the haptic, I could see the posterior capsular rent behind the IOL. So this could have been the reason for the IOL getting cloudy, because many times these IOL, when come in contact of the vitreous and the fluid, the IOL may go cloudy. And once I took out one of the haptic, and in this situation, I'm trying to bring out one of the haptic out of the wound, main incision, and you can see the rent here. So I'll go inside, and this is another technique. Just hold the IOL from the side pot and then cut it. Hold it and then cut it. So when you cut this IOL, more than 3/4, and then you can simply dial this IOL out of the anterior chamber. And this is how I'm going to bring this out. Now, since this patient had a rent behind, and there was a vitreous also which has come out into the anterior chamber, so this is the IOL. So I'm gone in through the main wound and trying to do the partial anterior vitrectomy. And as you can see here, the vitrectomy is complete. And once the vitrectomy is complete, then I'm going to put in another IOL into the bag. This is gone, okay. So, okay, so this is the IOL which is placed into the bag, and so what is important is when you are putting in the IOL, your IOL should land into position, and the final destination should be on the track and in the capsular bag, so that you get a good post-operative visual recovery in these cases. And I'll finish this presentation here. Thank you very much.
Perfect presentation, sir. A lot of clues we have taken. One more category I have seen in decentered lenses, that is a broken haptic. So lens remain eccentric because of the one haptic was broken. So that lens need to be replaced definitely with the another IOL.
See, actually, because if one of the haptic is broken,
sure,
and then putting this IOL is definitely going to decenter, and there is no way out. You have to take it out and exchange it with the. Because many times I've seen some cases where one of the haptic was broken and the IOL was still inside, and patient would have a decentered vision, and IOL won't work much here. So it's better. And another important situation, like while putting the IOL, because many times it's stuck into the cartridge, IOL may crack. The broken IOL or crack IOL also should not be left inside, because these are the IOL which is going to give trouble later on. So always better to exchange them.
Thank you very much, sir.
Thank you.
Sorry, sir. I invite Dr. Ritika Sachdev. She is going to speak on flax at the rescue. How to tackle difficult situation. Flax is the most advanced cataract surgery now.
Good evening. I'd like to thank Dr. Rajendra Prasad sir and the DOS executive for this kind invitation. I'd be talking about just 3 cases where femtosecond laser really is incremental improvement in the standard of care that we provide to our patients seeking cataract surgery. As we all know, femtosecond laser is the most advanced tool to augment cataract surgery in terms of the final outcome. The 4 important steps that this laser brought to us was a better capsulorhexis, lens fragmentation, incisions and arcuate incisions to correct astigmatism. Mostly we do not use the femto platform for making incisions because we've not found them to be incrementally better. But the capsulorhexis and the lens fragmentation along with the arcuate incisions are what I will be highlighting. We have done more than 10,000 cases with the femto platform over the last 8 years. And with the benefit of the soft fit PI and the liquid optic interface, the outcomes have significantly improved. I'd be starting first with a case of hard cataract. This has already been pre-treated with the femtosecond laser. So there is a good capsulorhexis in place. Whenever there is a capsulorhexis which has been pre-cut by a femtosecond laser, we must pull it centripetally to avoid peripheral extension of tags. Now we see here this is a black cataract, and often chopping is sometimes preemptive and does not produce a full thickness crack. So because this has been pre-cut, you see there is an escape of gas bubbles, and the piece which has been divided, we often use 6 to 8 segments pre-cut program with a femtosecond laser. You see each piece has been pre-cut like a slice of pizza, and even with more superficial chopping, you get a full crack because it is the crack of a hard cataract that is difficult. The iris is slightly floppy, but you can see that this is truly a black cataract. So we do not even think of SICS for such patients. There are people who do say that the femto does not have a significant difference in the effective phaco time. That is true for grade 1 to 2 cataracts, but when the cataract is harder than grade 3, particularly in grade 4, 4+ cataracts, there is a significant reduction in the phaco time, and the most difficult step of producing the crack. You see here, you just have to create the separation, and the full thickness crack comes, and you get the pieces exactly divided like the slices of pizza. You see the crack moves all the way to the center. It does not remain a peripheral crack, and it is a full thickness crack. So this is how each piece comes out. And a lens is implanted. Now this really is the difference. Because of the reduction in the phaco time and lesser manipulation, you get clearer corneas on post-operative day 1. Also, because you know that you will have a predictable fragmentation and rhexis, you do have the confidence to even offer premium IOLs or toric IOLs to these patients. Coming to the white intumescent cataract, the capsulorhexis is really the most common fear factor when we are dealing with the white cataract. You see here that the anterior segment OCT, like Dr. Tityal sir has pointed out, gives you an indicator about how the capsulorhexis will behave. But here, since we are going in with a closed chamber, and because the rhexis has become much faster, the rhexis is usually complete. Unlike in the earlier platforms when the machine started, because the rhexis was slower, as the liquid escaped, the tags were more. So here, because it's a white cataract, we must stain the capsulorhexis to ensure that there are no tags, and post-staining, pull it centripetally. Even if there are a few tags, when you pull it centripetally, most cases you will get a good full rhexis. This is one of those cases where the cataract under the intumescence is harder. Because of the white barrier, the fragmentation does not come through. So you still have to do the chopping, but this is still not as hard as the brown-black cataract, and most white cataracts are amenable to a simple chop. So this is the advantage here. This is another case, again, the similar this is a phacomorphic glaucoma actually, and you see here that the boom again happens. This is the point I'd want to highlight here, that this is the arcuate incision that we are making here, which also allows us to put in, this patient had a crystal lens in one eye. We don't really use this lens anymore. This is many years ago. So even in a white cataract, because you know that you can do a rhexis that can be sized, we know that the crystal lens at that time required a larger rhexis. So it is a perfectly sized rhexis with a coexisting astigmatism less than 1 diopters, which has been treated. Another advantage of flax is in patients with posterior polar cataract. The pneumo delineation really gives you a manipulation-free nuclear disassembly, and the anterior segment OCT allows you to predict how the surgery is going to go. The anterior segment OCT, we have seen, provides a very close correlation to predicting whether you will encounter an intraoperative PC dehiscence basis the preoperative picture that you see on the OCT. So when the PI is latched on, the OCT scan comes in. You will see here that there is a deficiency in the posterior capsule that is almost evident. We, for all posterior polar cases, increase the posterior offset. The offset really is the distance between where the laser fires and the posterior capsule. So you don't want the laser firing too close to the posterior capsule. This is the pre-cut view of the eye, which has been pre-treated with the femtosecond. So the rhexis, of course, has come in. You don't need to do any significant hydro maneuvers. It is a pre-chopped nucleus. You can disassemble it quite easily because you're not using fluidic maneuvers, and there is a pre-existing PC dehiscence. You really are stabilizing it and compartmentalizing both the anterior and the posterior segment as well as possible. So this pretty much is the end of the nucleus, the core nucleus. It is pneumo-delineated, so you still have the epinucleus shell, which is cushioning the PC defect. So this is the epinucleus being taken out. At this time, we will have the PC defect bare. So I'm just trying to put in viscoelastic before moving into the IA. And because there is a through and through rip that we will encounter at the end of the IA, we have tamponaded it with visco to not allow the rip to extend or the vitreous to herniate, and putting in a 3-piece lens into the sulcus. We have shown and published that there is a very strong correlation with the OCT findings on the femto platform with the correlation of an intraoperative dehiscence being encountered, and the planning as well as the pre-cut nature of the procedure of the nucleus does help in optimizing outcomes. So these were the 3 cases I wanted to highlight. Thank you for your attention.
Thank you very much, ma'am, for that wonderful talk. Any questions from the audience?
Dr. Ritika, how much diopter you correct with the arcuate incision by flex?
Sir, we never exceed 1 diopter usually, because the some amount of residual astigmatism is acceptable when you're treating. So there is some regression, and the correction is not as perfect. So 0.75 is the ideal range, up to 1 diopter. There are some surgeons who are comfortable going up to toric IOLs in 1 diopter, but mostly our threshold for toric IOLs varies from 0.75 to 1 diopter.
Thank you. It's really perfect presentation. You have shown very clearly the use of flex in case of difficult cataract situations. And I have used flex in number of cases, and I found that at least 1 or 2 grade case can be done without using any energy. 0 energy you can use. And as far as capsulorhexis is concerned, in majority of cases it has the free floating capsulorhexis. And definitely you have correctly said that intermittent cataract and mature cataract, you must stage the rhexis before taking it out. It's always a savior. Thank you very much.
Now I request our next speaker, Dr. Alkesh Chaudhary, sir. So, sir will be speaking on nucleus and IOL drop. What next? This is a nightmare for all the phaco surgeon.
Uh, Good evening. So finally, after presenting such a good cataract surgery, so I'm coming to the most complication, nucleus drop and IOL drops. So factor responsible, preoperative, subluxated lenses, posterior capsule defect, peroperative PCR, zonal dialysis, postoperative like trauma and rhexis phimosis may lead to all these complications. Accompanying complication can be inflammation, increased IOP, corneal decompensation, vitreous incarceration, residual cortex, nucleus fragment, retinal damage, and CME. Symptoms: unwanted optical image, decreased vision, edge glare, diplopia, streaks of lights, halos, photosensitivity, ghost images. Examination, we go with what is the corneal status, what is the visibility behind, integrity of anterior and posterior capsule, anterior chamber, IOP, indirect thermoscopy for additional RD, Whitham, CME and vitritis. Management concept is total and safe removal of the cortex and nucleus, preserve capsule for IOL fixation, safe and thorough removal of vitreous from the wound and anterior chamber, retrieving IOL without causing collateral damage. Back to front approach is always the best in those cases. So coming to case of a posterior dislocation of the IOL in the back with CTR ring. So we are going for a 3-port vitrectomy. So you can see the IOL lying behind. It is in the back with capsular tension ring. So I removing the whole of the vitreous all around, inducing PVD. And you see I couldn't remove with the, so I modified with the forceps, modified my technique with the bend needle. You can see clearly the bend needle. So I did a fish hook technique with this bend needle going in the cleavage between the capsule and the IOL. See now, going with this bend needle in the cleavage and lifted the lens up. So once the lens is lifted, you see we are removing the lens. It was very slippery. You see again it went down. Even I was using forceps, I couldn't hold, so I again left it. This time I used the limbs forceps, tooth forceps, so that I could remove this lens. Sorry. See now we are removing the lens. Lens is out. You can see in the back lens, and finally removing this CT lens. Now we are fixing the scleral fixation IOL. So final management, we fixed the IOL and this patient finally post-operatively got 6/9 vision. Coming to the next surgery, this was a like PC rent happening and then it was put a multifocal IOL. Usually once PC rent is there and you are not sure this multifocal IOL should be. So planning for a SF IOL, passing the suture in advance, because later on once the eye goes in hypotony, the anterior chamber is open, so to pass these sutures become difficult. So doing vitrectomy, and you see now with the help of a forceps we are lifting the lens at a junction of optic haptic junction so that doesn't break. So lift the lens up and bringing up in the anterior chamber, and finally we are taking out the lens. Now see this lens is out, and surprisingly when I took it out I didn't get a history. It was a multifocal IOL. So if any complication occur, you see this was a multifocal, you can see all the rings around. So these lenses should all be avoided. So again finally we are fixing this SF IOL. Now Coming to now nucleus drop. You see this is a case of nucleus drop. So again we going for the 3-port vitrectomy, 25 gauge, removing the anterior cortex, clearing all the inflamed vitreous. You can see the vitreous mixed with the cortex, and we try to remove as much as epinucleus and the cortex, so minimum fragment, and we try to chew also these fragments if possible. So removing the cortex, inducing PVD, you see small amount of the cortex, nucleus is left now. This small fragment is there after releasing all the epinucleus and the cortex. So now enlarging the wound, because the fragment tip goes to a 20 gauge. So enlarging the sclerotomy, 20 gauge with the MVR blade. Now with the introducing the fragma tip. You see with the help of a fragma tip, and the illumination pipe we use as a chopper, we can break with the help of a illumination tube, so that we can break the small pieces and chew up the. Finally, you can see this whole of the nucleus, everything is clear, removed, and no vitreous mix up with the cortex left behind. So in this case, we fix the retroiris IOL. Coming to next case. This is my very, very old case I managed. This was a mismanaged case of nucleus drop. So in this case, like there was a nucleus drop, I think the person, he was running behind the nucleus and causing all the possible complications. So that time I didn't have this even wide angle viewing system, so we were using contact, you see 20 gauge vitrectomy and contact lens, irrigating contact lens I was using. You see under all vitreous hemorrhage, organized vitreous hemorrhages. Doing total vitrectomy. Once vitrectomy is complete, you see we are completing the vitrectomy, and then there is total RD also simultaneously. And we are trying to find out where is the nucleus. If you see, this nucleus is hidden in the folds of the retina. You can see this big nucleus, hard nucleus, hidden in the folds of the retina. So there were two options: either you use PFCL and lift it up, or I took it out with the help of a fragmatome, just buried fragmatome in the nucleus and took it out. See, I am bringing the nucleus up with the help, removing all the vitreous around. So with the help of a cutter, then finally you see we are engaging the nucleus in the fragmatome, bring it up, enlarge the corneal wound, and with the help of a wire vectis we remove this nucleus. So in case you mismanage, you can see to what extent it can lead to complications. Similarly, once IOL drop, there was a corneal total retinal detachment. IOL was lying behind the retina. So giant retina tear and IOL lying. So you are running behind the IOL and try to remove it. So better just leave it as such, so that with the help of this 3-port vitrectomy, we can give a better results. So you see this hard nucleus lying behind, we removed, then did the VR surgery, silicone oil. We could settle the retina, but vision was almost just finger counting. Postoperative care, we have to see about inflammation, IOP, hypotony due to wound leaks, choroidal. On each follow-up, please evaluate retina. Prognosis is excellent, visual results, and a low rate of complication if proper VR techniques are followed. Late prognosis depend on prevention of corneal decompensation, RD, choroidal hemorrhage, secondary to surgical manipulations. Do's and don'ts: don't run after the dipping IOL or nucleus. You see what can happen. Don't try another IOL without removing the previous IOL, because it becomes difficult to retrieve the IOL lying behind. Do apply extra suture to score wounds to avoid leaking ports and hypotony. because I have gone through all these cases. Once I get just a collapsed eye. So he didn't put any suture, just sent to me. However, we could manage, but it becomes very difficult because that leads to choroidal and other complications. Refer to retina specialist without any delay. Timely right way intervention will give the best results. Thank you for your kind attention.
Thank you, sir. Really, now we are not finding much case of nucleus drop. Thanks God to the advancement in the machine and microscope. And but very, very unfortunate instance, something happened. We always remember the friends like you, and we always assure the patient, don't worry, everything will be okay, and things are still in the hands of, can be managed well.
Yeah, they took
Yeah,
out
that was the
that I
really
have seen.
scaring scenario.
Even a nucleus drop happened. When he sent to me, that took 2 hours, I was almost collapsed. And then person
No, what
asked, "How you are
amazing
going to
surgery.
manage?"
Subretinal and a nucleus
Somehow we
subretinal.
started injecting fluid and making the volume of the eyeball, so it becomes very difficult job.
So what was your approach, sir? What was the surgery that was done?
Sorry?
Did you do a retinotomy and...
No, we did it. We make the first volume of the eyeball by injecting the fluid inside that collapsed eye. Then we put suture, then we made sclerotomy, then we manage. So it becomes all complicated. Luckily, he didn't have a choroidal, but choroidal doesn't take time in such eyes. And may lead to detachment becomes very difficult. Then mess up the things, basically.
Thank you, Dr. Alkesh, for
Thank
this
you, sir.
wonderful talk and management of difficult issues, especially for the intersegment surgeons.
Sir, Dr. Alkesh,
Anji.
there is one school, some people say that if IOL drop is there, you leave it and put a ACR over that. Inert material may not harm. Is it true or wrong?
No, you should not put another IOL
Without
without
implant.
removing
That's
that
right.
IOL.
Some people do say that.
Because I had also similar cases. There were 2 IOLs, one in the lying in the sulcus and one was behind.
This is not advisable at all.
3 IOLs.
नहीं two, one drop AC में डाल दो तो inert होता है.
Remove all those IOLs, whatever is lying behind.
Okay. And with treatment done. Okay.
And we can remove easily, not a problem.
I know, retina specialist can do it.
Thank you, sir.
So, we had a wonderful session from and amazing talks from the stalwarts like Professor Tityal and Dr. Ashok Grover, and a very illuminating talk about illumination in corneal opacities for cataract surgery. Dr. Rajendra Prasad was, as always, very clear about the management of IOL exchange, and Ritika about the flax, which is, amazing technology for cataract surgery. I must thank all the speakers, Rajendra Prasad and Dr. J.S. Bhalla, for organizing this session, which is excellent for the purpose of understanding the management of difficult situations. Thank you all. And I'll invite you are on the dais.
Now I invite Dr. Lalit Verma, Dr. Rajendra Prasad and Dr. Gaurav Luthra to take the stage and start our session 4.
Photo. Sorry, come back. Can I invite all the speakers, please? अरे सर ये तो रेयर मोमेंट है आप डालो और मैं आगे आओ अरे सर
I'll invite Dr. Lalit Verma, please come on the dais. Dr. Gaurav Luthra, Dr. Rishi Mohan, Dr. Rajiv Bajaj, Sandhya Makija, Dr. Bhupesh Singh is here. Yeah. Dr. Rajiv Mohan, Dr. Abhishek Dagar, Dr. Arvind Maurya, Dr. Gagan Bhatia, Vivek Jain, Pankaj Bashne, शांतनु गुप्ता नहीं है जो है वो आ जाएगा So this session is going to be very interesting. This is a clinical grand rounds, challenging cases and panel discussion. So I'll invite Dr. Lalit, please. आइए आइए दोस्त क्या हुआ Luthra, please. Dr. Gaurav Luthra.
Good afternoon, everyone. So I'll be speaking about management of intraoperative DND. Myself, Dr. Prafulla from RP Center. I'm working as an associate professor in cornea cataract refractive services. So when I was doing my senior residency, for me, DMD used to be a ठीक है, just gas डाल दो हो जाएगा. It used to be a very small thing. But over last few years, when I received a lot of desperate calls from my ex-SRs or my friends that ki yaar cataract kiya tha, cornea is not clear, patient is after my life. Then I realized, yes.
Dr. Bhalla, please take seats. Yeah.
This can be a severe problem because it leads to a significant level of patient dissatisfaction. So this is one such case to show you that. So few basic anatomical points, you know.
Dr. Tanwar and Dr. Bali, please photo session later on.
So DM, Descemet membrane, is basically basement membrane of the corneal endothelium. It's 8 to 14 micron thick. Important part is, remember this is attached to the stroma with an interfacial matrix. And this interfacial matrix consists of your glycosaminoglycans. So why this is important? If you leave a Descemet detached for a long time, this glycosaminoglycan component that is gradually lost and it becomes hydrated. So subsequent attachment of a detached DM become very difficult. So that's why this figure is there. So few factors you should remember: old age and endothelial dystrophy patient, when you are operating, at least have a word of DMD in your informed consent. And when your boss wants you to operate 5 or 6 cases with one instrument, again you should be careful about DMD. Normally, if you notice, 50% of cases are small. Even at times you may not detect it. It may be at their side port or maybe main port, but resolves spontaneously. Almost 8% of cases need some long-term procedure like DMEC or DSEC. So this is a paper we did it in 2015. The idea of this paper came when we noticed that a lot of our residents are writing on slit lamp examination, everything is fine, but there is focal edema. So what we did ASOCT, and what we found that there is DMD, even that could be missed with slit lamp examination if not done properly. So based on that review, where we included almost 40 odd cases of DMD, we came out with this classification system. Of course, this is inspired by your macule classification, planar, non-planar. So whenever there is a DMD during surgery, if you see that it's involving the superior half, and if it is planar means less than 1 mm away from the posterior stroma, then simply inject air, that will work. Any other like inferior DMD, non-planar or scrolled, in that case C3F8 works better. So these are a few examples of planar, non-planar and scrolled DMD. So this was the guideline which we came out in that paper, and which I have already told you. This is a video from Professor Namta Sharma ma'am. So this is one of our SR's case where there is DM detachment from limbus to limbus during surgery. So this is one technique of tackling such cases. You do a paracentesis, release some amount of aqueous and inject air, fill the chamber completely, wait for some time and then burp it if you feel your DM is well attached. or you can wait for 1 hour and then burp it in the slit lamp. So the ideal trick is do some paracentesis, don't just inject air, or else that will lead to significant rise in intraocular pressure. So this is one technique. This is another technique which I prefer to do. If there is a DMD, this was a case operated in the morning by one of my ex-senior resident, then the patient was referred to me. It was a difficult case, and you can see the patient had some ocular surface disorder. And when I took the patient to table, you could see the DM was detached from limbus to limbus, and there was significant corneal edema. So what I do in such cases, because the moment you achieve a complete air temperate in entry chamber, the IOP is going to high. So what I do, I use a bimanual technique. Or from one side, I'll insert a 30 gauge needle. You can see here, and this needle will be without any syringe attached to it. It's just a hub. Then from the opposite side, I'll insert another needle which is connected to a tuberculin syringe having either air or SF6 or C3F8. When I'm injecting air or gas from this side, that hub will work to control the intraocular pressure rise. Once I release that, my entire chamber is filled with air. Subsequently, my decision depends on how difficult the case is. If it is a limbus to limbus detachment, patient have risk factor like endothelial dystrophy, I would prefer to have a tamponade for almost 1 hour, then I'll burp the air. However, if it is a simple case of cataract and due to maybe instrument error, then simply 15 to 20 minutes of tamponade is good enough. Then you can release the air. And how much air to leave, it depends on your pupil size. The ideal way is to leave that much air till your pupil dilates or 2/3 of the entry chamber. That should be the goal. So this is another case of Fuchs endothelial dystrophy where I was doing a phaco. This was a case, although the DMD was not that much, but it was just as you can see, phaco has been done, IOL was inserted. This haze is on the cornea, it's not on the IOL or behind that. So there was some descemet detachment here. So what I do in all such cases, inject your air, completely fill the interchamber from the side port and release the air from the main port so that the DM unfolds and it gets attached. At times it may be difficult with air only. What you can do is you can inject small jets of BSS. If that doesn't work, even you can inject viscoat into interchamber beyond the flap if your flap is inverted and fixed. And after that, once the DM is attached, you can remove the viscoat during using bimanual irrigation aspiration. So this is a simple trick. Release the air through the main port. If any flap is there, that will get reattached. So whatever may be the technique that you follow, always remember this. Follow the complete asepsis. Pilocarpinize the patient. Try to find out the area. So I'll just complete in 30 seconds. Try to find out the area where the DM is not detached. And always enter through that part. Sorry. So these are few difficult cases. This was a case of dark where there was double detachment, as you can see here. One was between stroma and Duas layer, one was between Duas layer and DM. Here again, it's the same technique. Inject air into the interchamber, then release some air by releasing few suture. And for the fluid between your DM and Duas layer, you have to make a puncture using a 30 gauge needle. So with this, I'll conclude my talk. Thank you very much for the attention, and sorry for the bad voice.
Thank you, Prafula, for the beautiful presentation. And one very simple question comes in mind when you have this DMD. I asked Namrata also in the last conference that what is the size and the location of the DMD which we can forget? Like we don't need to do anything for that.
See, if you go through the recent literature, there is a paper where they found that even after 3 months of descemet detachment, the endothelium that was there, they were still acting. So for me, if you find a detachment, there is no point of leaving it like that unless there are compulsion. Patient is not suitable for surgery or the patient doesn't want to surgery. But even if the DM is very small, you should try to get it reattached. Why to lose endothelium from that part?
See, actually, there was an article where they have shown that almost 70% of the cases, they get DMD in any form. Like it could be very small, it could be at the incision side or some other side. So do we need actually really
Yeah,
to do
this-
something for all these DMDs, or we can leave
This,
that?
in fact, I told in my initial slide, 50% of DMD are small, and even if you don't do a proper examination, you miss that, which gets spontaneously reattached. But my point is, if you know that there is a DMD, and you have option to treat that, why to leave it like that? It's always better to correct it.
And how many cases were there, like suppose you have a DMD and DMD, the flap is lost. So in how many cases you get the regeneration of the endothelium in that area?
It depends, largely it depends on the age of the patient. If your patient is young, and just few minutes back I was discussing with Dr. Ritika because she knew that this is my topic. So she accidentally did a capsular access in one of her patient and that recovered completely. Why? Because it was a young patient. But if it is an elderly patient, suppose 70 plus and having fused dystrophy or some endothelial compromise, then that is not going to heal spontaneously. It will heal by fibrosis only.
Right. Thank you. Thank you, Prafula. Thank you very much. Yeah. Yes, sir.
Dystrophy, which have got an association with either congenital glaucoma or a keratoconus, antistophoma, congenital abscess of Descemet's membrane, congenital hereditary endothelial dystrophy, keratocongenital sicca, deafness. I have published a case, I have seen a case of a bilateral congenital corneal dystrophy. It's basically heredofamilial, first cousin marriage. And in that particular case, a bilateral congenital corneal dystrophy, I saw it with antistophoma. The right eye at the age of 3 months, keratoplasty was done, and at the age of 3 years, left keratoprosthesis was done. This case is published in one of the rare cases, and an RP Center for Ophthalmic Sciences, bilateral congenital corneal dystrophy with congenital glaucoma in the past has been reported. Bilateral congenital corneal dystrophy with deafness has been reported from King Khalid Eye Specialist Hospital, Riyadh.
Right. Thank you, sir. Thank you very much.
I had a quick question, Praful. Lovely talk, as always. I enjoyed that. Two things. One is we are operating, and intraoperatively you see a Descemet attachment developing. How would you tackle that? That is one thing. Second is you've had a patient who's had a DMD in one eye, and we are now doing the second eye. What would you recommend would be different in your approach to ensure that you don't get a repeat of the same thing again? So those are the two valuable take-homes that I'd like to get.
One eye DMD, other eye you are operating. The important point is please don't use blunt instrument. That is probably the commonest cause for DMD, which often goes unnoticed. And the second one, please be careful each time you are going in with any instrument. Please be careful. I have seen people go with the tip of the needle directing towards the center of the cornea. So that should be avoided. Your direction should be always toward the center of the nucleus if you are doing a phacoemulsification. And of course, you'll have to be extra careful. And I don't remember any other point beyond that. And the first question was intra-op DMD. As I showed you there, if you notice intra-op DMD, please stop there, come out, inject some air, achieve some tamponade for 10 minutes. Most of the time, it gets reattached. And if you feel that DMD detachment is connected to any of the side port or the main port, please change the site of the incision. If you have a DMD, please don't enter through the same incision site again and again. Always it's good to suture that and go through another incision. That you should follow.
Right, right. Thank you.
Thank you. I think that was exactly what I wanted.
Thank you.
Well done.
So now I'll request Dr. Saurabh, I don't see him here. Dr. Kamal Kapoor, are you ready? Yes. Yeah, good. So Dr. Kamal Kapoor is going to talk on subluxated cataract, capsular stabilization techniques. In the meantime, Dr. Titial, can you comment something on the DMD? Is there any relationship of DMD, because we see it's related to the wound architecture. So wound, like when you are putting the incisions, many times we see the DMD at the incision site only. Because central DMD is very rarely seen if you hit with the phaco probe or the instrument, then only. Otherwise, normally DMD is seen at the wound. So any wound architecture you think of not doing and do?
Thank you, Dr. Rajendra Prasad. I think, one of the most important part is how is your wound been, created. And I think we had a publication in that also. If you have the absolutely clean edge of the wound when you're making a tunnel, then there is very little chance that descent membrane will get disrupted or disturbed during your entire procedure. If you do a ragged incision, then you have more chances. So we compared various instrumentation with the femtosecond laser also. We found that if the proximal part wound is clean, then the chances of descent membrane detachment in the wound site is very minimal. So that was 60% to 10% difference. And further progression will be little less. Other important thing was, most of the time, you could have a frill of descent seen during your procedure. But that will increase significantly when you are trying to do a wound hydration towards the end of your surgery. There, classically, if you have a larger descent detachment, then it's better to put suture and inject the air from side port, which Dr. Parful very nicely showed, and get the release of air from the main wound side. Otherwise, the important part is to look into a case-wise. We described if you have a case scenario where the endothelial function is poor, like a Fuchs endothelial dystrophy, or you already done some surgeries, then you have a more chance of wound side descent detachment in these cases. So you're right, if you have a diamond knife, if you have a lasers, if you have a sharp blade, well-constructed wound, there are less chances of DMD happening in the wound side.
Sir, one more point, sir. Sir, while introducing the phaco tip inside, say if you have a tendency in the other eye for the dispersed detachment, normally when we inject when we introduce the phaco probe, should we stop irrigation and start it inside?
That's a very good point.
Because that's most of the times we start the irrigation and then
because if people have seen my surgeries, I never, go with the fluid on any instrumentation. If you've seen my surgery, my chamber is always filled with the viscoelastic, not 100%, little bit. I always go with the, the tip which is not running. I go easily inside the chamber, then I run the fluid. That indicates like your chamber is well maintained. For that, you have to take out the air bubble beforehand. If you are using a phaco handpiece, your test chamber should be on into that. Run the phaco outside so that it takes away all the air bubble from the tubings and the needle tip. They can directly go inside without irrigation on. The chamber has to be filled little with the viscoelastic. And most importantly, you should not, when you're coming out, going out, make sure your irrigation doesn't disrupt the wound area, which Dr. Parful nicely showed that. Good point.
One more point I would like to add is that if your sleeve has been autoclaved too many times, it gets broad at the opening. So while you're inserting with the non-tapered sleeve, which has been autoclaved too many times, it loses its compliance. So even as it slips in, your metallic part will go in, but the sleeve struggles to get in, and that's the time you will have a DMD. And another thing is, if you do this in a hypertonic eye, as Dr. Tityal said, you're asking for trouble.
Also, if I may just add, yeah. Also, if I may add, suppose you
We'll have a tie-up with RP centers.
Suppose you do see a DMD at the wound which is increasing as you are doing phaco, then it is always better to go bimanual, especially for irrigation aspiration, and put a little bit of viscoat before doing that from another port, so that the Descemet's membrane kind of comes and gets stuck up onto the stromal layers.
Thank you, everyone, and the excellent comment by Dr. Tityal. Dr. Kamal, you can start your talk.
Oh, very good evening. Thank you to the whole chair here for inviting me for this session. There are no financial disclosures. I'll be discussing about rings, injectors, so there are no financial disclosures here. So no one likes a sinking feeling, especially if it's a feeling of a sinking nucleus. Maybe few situations, some beings may like things to be sinking. Sharks for sure like sinking ships. So whenever you're on a tricky path, you should actually be walking and seeing what you're getting headed into. Difficult situations can be foreseen, but sometimes even while doing a surgery, you could cause a subluxation. But let's discuss the points where you can anticipate a subluxations. You have diseases like Marfan's, post-traumatic cataracts, trauma, very, very deep anterior chamber, phacodonosis, history of subluxation in the previous eye, post-retinal detachment, very, very high myope, pseudoexfoliation, and patients with colobomas. Now, what are the signs to look for? What are the bad signs you should look for? always dilate these patients. You could, a lot of times, this cataract could have been missed if it was not seen dilated. Probably in a non-dilated or mid-dilated, you would have missed this cataract. And of course, this one for sure, you would have missed. So you cannot actually overemphasize the preoperative assessment when you're going to be looking at a subluxated cataract, and always have an informed consent for these patients that takes some pressure off your head. Tell these patients what all can happen, what all can be required during the surgery, use of CME, CTR, capsular rings. Explain to them that the surgery may be a little longer, some signs like irregular deep chamber, iridodonuses, irregular pupil shapes. And also while doing a surgery, so many times you could have a very weak zonule and there are no signs, there are no donuses. But one good sign could be the moment you start your capsular rhexis, the capsule starts folding like a loose cotton shirt. That's a sign of anterior zonules going. So Witters in AC, loose capsules, we've discussed all of them. So dilated pupil, and then making sure that the patient moves his eyes when the pupil is dilated, when you're seeing the patient on slit lamp, make him make jerky up and down movements. Patients, if you actually suspect that there is a subluxation, you cannot see this patient supine. Now this is a classical case of an irregular chamber. If you see in the lower image, the inferior, the 5 o'clock area of the image is showing a deep chamber. This is patient has a history of trauma. This is an irregular deep chamber. Now this subluxation doesn't look bad, but look at this. So making the patient look in each direction, this is a part of your preoperative evaluation. So this will actually give what is the kind of subluxation you're looking at. Because in this image, probably it doesn't look that bad. You think, okay, it's not that bad. But this is probably the real picture. So making sure that you have a detailed evaluation in all gazes, taking images, making diagrams of these patients, planning the whole stuff, you can actually plan the surgery and you have less chances for surprises. But of course, there could be some very bad ones. So we'll be seeing a few surgeries, which I'll be doing a few of the videos in the sun. So if you have a traumatic zonular dehiscence or zonular break or subluxation, that's usually non-progressive. A traumatic subluxation is far less dangerous, even on the OT table, provided you mapped it well, you planned it well. And an iatrogenic subluxation also is not that bad because you know how much of damage you caused. But the progressive ones are the ones where you cannot predict what has happened. Just 3 days ago, I took out a lens, a CTR, and an IOL complex out of a patient who was half in the anterior chamber. I operated this patient with pseudoexfoliation 9 years ago. So he had come from Jharkhand. So these kind of patients will nevertheless progress. You can do whatever you want, but they will progress. So surgical plan is, if you have less than 1 quadrant, maybe you could put a meridional IOL, which means the longest axis of the haptic of the IOL should be actually pushing away the most part of subluxation of your capsular axis. 1 to 2 quadrants, you could have a CTR or an AC anchor. 2 to 3 quadrants, you can have a CME or 2 CT segments. And more than 4 quadrants, you could have a glued IOL, take out the whole bag, or probably. So these, I will not go into the details, but I'll just probably screen them because I've got some interesting videos to show. So you could have choice of a CTR, you have a CME, you have a double ring CME, you have a left eyelet CME, you have a right eyelet CME. The size of the CME, always do a white to white measurement, vertical and horizontal when you're about to operate a subluxated cataract. But this will help you plan your CME's ring diameter. This will, because if you end up putting a very small ring, it won't serve the purpose. If you put a very large ring, it is going to be more tricky and probably you will subluxate the cataract more. So you could have a 10 millimeter CTR ring which has a zone of between 11 to 12, or you could have an 11 millimeter which has a zone of 11 to 13. So I'll just skip. So how do you tie this CME ring or a CTS? The suture has to go above the eyelet through the capsular bag, above the capsular bag. You use iris hooks and capsular hooks to stabilize the bag. These act like pseudo zonules. Till the time you're doing the surgery, they give you some support, avoid the capsular bag from sinking down. Options of Henderson's rings. These rings are interesting because you can do a very good cortical aspiration through these rings because of the undulated margins. The AC anchor, I've not used this ever, but I believe I've seen some videos. This is an interesting tool to use. Now, general pulse when you do this surgery is operate under a block. Even if you're one of the best surgeons, I would recommend operate under block. Do not over-pressurize because you might be causing more zonular dehiscence. Adequate complete dilatation. Have plenty amount of viscoelastic ready. Use trypan glue, but mind you, do not over put the trypan glue, because sometimes this glue will dye will go into the vitreous, and then you will land up with a task. Always have size checking. I think this is a long session. How many minutes do I have? 1 minute? So I think this is a very detailed descriptive session. Okay. So let's start with the CTR insertion. What should be the vectors of the CTR insertion? You should always make sure that your CTR is not starting from the area, entering the area where there's a maximum subluxation, but by the time more than 40% of CTR is inside the bag, that should cover the maximum area of subluxation. The vectors should be always tangential. Never push the CTR, always rotate the CTR into the bag, let it glide in. If you see the movement of the vector, that's why I recorded this video, the vector is a dialing moment which is tangential to the extreme part of the wound. If you push this CTR, you probably will cause more subluxation here. I guess that's it. Because there was few very interesting videos. Now this is again a traumatic cataract. There's a vitreous which is actually coming in. There are partial zonules there. So I'm using capsular hooks here. I'll just go very fast. Capsular hooks. Never overstretch these hooks. Never place the wound in the area of subluxation, because that is the area where your vitreous is going to come out. Use very low phaco power, low fluidics. You can use a disc flip technique. You can use a nuclear scoop technique. I'm using a nuclear scoop technique here. The surgery is practically over. Always make sure when you do the irrigation aspiration, it should be a tangential irrigation aspiration, especially in the area of subluxation. Don't do a radial irrigation aspiration, because then you will pull the capsule towards you. Always have the irrigation aspiration port going in a tangential manner, and once this is done, I push in the ring, and then the lens goes inside. I think there are plenty more videos, but that's enough. Thank you.
Thank you, Kamal, for the excellent presentation and beautiful videos. I wish you had more time, but
yeah, sure.
we are short of time.
Because I had to build a background, because when I was showing the text, then I would have shown that video, what that text comes from.
I have seen your all videos,
yeah.
But maybe most of the people haven't seen them. But beautiful videos, they have been very nicely presented, and how to put this CTR. Any comments, sir? Dr. Lalit?
I am not a cataract surgeon, but when your subluxation moves, do you any time, if the vitreous is in the anterior chamber, you do first vitrectomy or?
I do first vitrectomy. I have two videos where actually the cataract is a mature cataract, post-traumatic cataract, actually sinking mid-vitreous. So I do my rhexis, I hook the bag up with the hooks, then I do the vitrectomy, and then I put a Sionis, and then I complete the surgery. So I do a sectorial vitrectomy only in the part where the vitreous is coming in. And I have, of course, a retina surgeon standby, just in case things don't go my way.
And I'm sure vitrectomy with clamps will allow.
Yes.
I think Kamal showed some amazing videos, and for this particular, the vitreous thing, sometimes if you push viscoat, the vitreous will kind of go back, allow you space to do a capsular excess, and if it is still coming or it starts coming again, then Tramslon assisted vitrectomy, but never over vitrectomize, because
Absolutely.
then the lens will start,
the bag tends to go
it
back.
tends to go down. And I just wanted a quick question, like if you have capsular hooks, do you think you can delay the CTR? I mean, since you're supporting the equator of the bag?
I would not want to quantize and fixate that thing forever. It's always my gut feeling. Whenever I'm operating a subluxate cataract, I just look at the way the bag starts moving. If on sudden amount of surge, my bag starts coming into the center, it loses the support. A lot of times I can use my own nucleus quadrant to push the bag back in that area. Suppose I'm operating, I had two videos there, it's a hard cataract, and everything is gone. But now when my irrigation aspiration, when the aspiration finishes, the bag from that area compresses back in spite of the capsular bag. So I rotate that nucleus fragment in that area to push back that part of the capsule which was loose.
Perfect.
Thank you very much.
Thank you.
Dr. Kamal. Thank you very much. And now our next speaker is Dr. Gaurav Luthra. Dr. Gaurav, you all know, and I don't need to introduce because he's a very popular surgeon from Dehradun, and he's the director of Drishti Eye Center in Dehradun. Dr. Gaurav is going to talk on special IOLs for a special situation. Sulcoflex and piggyback IOLs. So this is going to be a very interesting subject, and looking forward to your presentation, Dr. Gaurav.
Thank you so much, Dr. Rajendra Prasad sir. It's a privilege to be here on the DOS meeting podium, and very good afternoon to everyone. So I was asked to speak on piggyback IOLs and my experience with that. So piggyback IOLs, I'm sure most of us have used at some point or the other, or continue to use them. And it's basically has several indications, but it requires, and you know, today we have expanded indications and expanded range of piggyback lenses and options which are available to us. So some of the indications may be big refractive surprises, especially if you've had a hyperopic surprise, you may be more keen to do, you know, not a laser-based procedure, but a piggyback lens. Pediatric pseudophakia, so children, once they've been implanted with lenses and as they grow up, they may develop big numbers, and then the IOL exchange may not be a great option, laser correction may not be possible, but if you have a good in-the-bag lens placed in a pediatric patient, piggyback works really well. Dr. Rajendra Prasad showed very nicely how to explant a lens in a post-RK patient, but sometimes in RK eyes you have so many cuts on the cornea, and making an incision and trying to get a lens out may be, you know, sometimes fraught with danger, but he showed it beautifully. And there IOL exchange, instead of IOL exchange, you may want to do a piggyback lens. Also pseudophakes who desire multifocality because they have a multifocal in the other eye, and I've had to do that once. Somebody put a multifocal lens in one eye of a patient who had only a monofocal in the other eye. So then we used a multifocal piggyback. And also today, if you have high astigmatism in a pseudophake and you want to deal with it, you can put a toric piggyback as well. So the considerations for putting a piggyback lens, of course, would be that you have to have a clean in the back fixation of your previous IOL, and where laser vision correction is not an option because either it's not available, surgeon is not comfortable, or the eye is not amenable, the cornea may not be suitable for a laser-based procedure, and where an IOL exchange may not be indicated, just as I said about the RK eyes. So you have to exclude all other causes of what your refractive surprise may be because of, and once you are sure that you have a stable refraction, you can go ahead with a piggyback strategy. So these are some of the indications of different ways of dealing with a refractive surprise. And if you look here, that secondary piggyback implant, if you had more than 3 months, hyperopia greater than 3, myopia greater than 8, and astigmatism greater than 5, then you know it's probably a good idea to go with a piggyback, among other indications. So several piggyback options are now available. Rayner makes Sulcoflex IOLs, which are made in many different designs, including the multifocals and the torics and several others. Our Indian company, the Care Group, makes very good Sulcofix lenses, which I've used fairly often, and also the IPCL kind of a lens which can be fixed into the sulcus. These are the Rayner calculation methods, and however you have to be careful about interlenticular opacification. In the few cases that I have done, thankfully I have not had this develop right now, and you have to be careful about the material that you're using and the lens design that you're using if you want to avoid this. This is the Gill's nomogram, which is for myopes and hyperopes, and this can tell you the rough way of trying to judge how to go about choosing the right power for your piggyback lens. So I wanted to just share one interesting case amongst the several that I've done. A 21-year-old boy whom I had operated at the age of 5 years, when he had come to us with a corneal trauma with a perforation which was repaired almost 16 years back, and subsequently about a year or two later he had developed a cataract which was also operated. Child continued to do well till he now presented to us pseudophakia in one eye and significant anisometropia. So he had in the pseudophakic eye a -7 and 7.75 with a -3 cylinder at 10 degrees, and in the fellow eye it was a 5.25. He had been prescribed glasses for almost 2-3 years, and somehow he was not happy and not comfortable, and he was taken up for right eye piggyback lens, and he wanted refractive surgery in his left eye, so he was taken up for an ICL because the other eye also did not have great corneal thickness. These were his pentacam maps, so a 455 and a 460 with significant astigmatism, and on the eye trace you can see that the 9.5 almost with 2 diopters of cylinder here and similar one there. So for the right eye we did a calculation and we decided to use this toric multifocal piggyback lens from the care group for the right eye and ICL for the left eye. We went ahead with this implant and this was the surgery. So it's fairly straightforward, so I don't think there's much science. If you have a good and I find this as a very useful option for some of these pediatric patients who come to you after almost 10-15 years of their previous surgery. They may have significant anisometropia, and instead of going for an IOL exchange, and sometimes they've had a YAG, they may have a big opening of the PC, and it may be traumatic to pull the lens out of the bag. So piggyback lens really works well. And in this child where we did this toric multifocal implant, it actually came out really well with very gratifying results with unaided 6/9 vision in the piggyback eye with almost 90% correction of the astigmatism as well. And so here goes. This is the Sulco Fix. I also really like the Rayner Sulco Flex. However, since that's much more expensive, sometimes patients can't afford it. And this lens is tolerated very well in the sulcus as well. It's a 4-point fixation lens and goes well and does well. So once you've got the haptics in, it's fairly easy to position them and then rotate it into position. Stays in its position fairly well as well. I have a follow-up of almost 1.5-2 years on this child now, and has had a very good stability of the toricity. And so this will do well, and you can see this on the OCT. He has a fairly good vault and the pseudophacos there. Fellow eye, we did a ICL, and that did well. So finally, this child looked good. This is the slit lamp picture of that patient, and here sitting with the toric. And so 6/9 parts unaided in the pseudophakic eye with the piggyback, and the left, of course, with the ICL will do well. This was the post-op eye trace, and you can see fairly good corrections on both eyes, and patient looks fairly satisfied. So it's a very gratifying surgery, and to summarize, I would say that I think piggyback lenses have come a long way, and from the time that I started operating, when we used to try to wonder what kind of a lens to use and how to go about it, the calculation is fairly straightforward. You have to just go with the refraction and some of the other data, and you can get a very good outcome. And now you have several of these designs available, and it's made much easier for us to do that. So thank you so much.
Thank you, Dr. Gaurav, for the excellent presentation. And I'll just have some comments from the panel. Dr. Rajiv, any comment on?
Gaurav,
Okay.
can I add a point? Gaurav?
Kamal, yes.
I've used a lot of these Sulco Fix lenses. They are amazing. One point I think Gaurav just slipped to, you have to do the white to white when you order this lens.
Yes.
Because if you order a little larger lens, these Mickey Mouse ears are so difficult to put in. I burnt my fingers with the first case I did. I didn't know that you had to do a horizontal white to white also.
You're right.
And
because,
it was very tricky to put. But once you have it right, this is an amazing lens. It corrects your emetropia, it corrects your astigmatism, it also does multifocality for you. So a lot of my old patients who want a multifocal and they have residual refraction, I do this lens. It gives fantastic results.
It's pretty good, yeah. And they have this calculation sheet which
Yeah.
I showed, which has all these things, including the white to white. So you have to be meticulous with your data.
Yes,
You can't be,
calculation.
yeah. Great, good.
Any problem of IL opacification, contact opacification?
So this is
has been described here.
Right. So in the past when we were like probably during my college years or sometimes we used to have this situation of interlenticular opacification and everything. But now with the newer design of these lenses, which will have a decent vault because they are only peripherally supported, and with the material, we used to have problems with the silicon matching it with the acrylic lenses and all those issues at that time. But today, all of those about 10 odd piggybacks that I've done, 10 to 15 is all that I've done. I haven't had a single patient with the interlenticular opacification so far, but I mean, it's always a worry, and you always have to keep that in mind. But I would love to hear if you have experience with any patient where, what to avoid and how to.
We have seen actually. Because
I have seen long back, but somehow I've been lucky and maybe, but it is an issue definitely.
See, the best part is there are two tips here. You mismatch the material. Don't use a similar brand. You could have an hydrophobic and a hydrophilic. And the best part is, even this interlenticular patient, I had in one patient, this lens in the sulcus is dialable. You can dilate, do 2-3 dialings, and then you just inject some 27 gauge fluid from one side. A lot of these cellular particles, one case I have a video where they just come out from the side. So it's not such a bad thing till I think becomes opaque and calcified, then I don't know how to manage it.
So now, sir, so what is your preferred technique now? Laser surgeries or piggyback?
So, I think people who do laser surgery, they find it very easy to do, corrections which are amenable to a laser. Where I would not do I would definitely love to do a laser correction if it's required. So if it's in the early post-op period, I'll probably just do an IOL exchange or dialing or whatever. If it's in the long term and it's a hydrophobic which is stuck inside, I will probably think about a laser correction. But if it's a hyperope, high astigmatism or something, or a cornea which is not amenable, for example, in this child, it was just a 455 cornea. So I would then think piggyback. So yeah, I think you have to use all the things in your armamentarium and what fits best to a particular patient.
And also, I guess the age of the patient. If it's a very old patient, you have an IOL surprise, -6, the corneal biomechanics after the age of 55, 60 is a totally different ball game. So I would still put my bet in an elderly patient for a piggyback than a corneal procedure.
But we should always keep this in the back of our minds that this is a good option and it works in many patients where we otherwise think that we can't do anything for them.
Thank you, Dr. Gaurav. Thank you for the presentation. And now I think next speaker is Professor J.S. Titiyal. Dr. Titiyal is going to talk on IOLs in the absence of capsular support, angle, iris, or SF-IOL.
ये तो लगा था पहले भी तूने क्या किया था पिछले बार एग्जीक्यूशन में कुछ और ही मिल गया किसकी टांग कहाँ लगी कुछ नहीं समझ आ रहा Thank you very much. It's like, operating the system without a support. My talk today is, it will be more of a debate on our various types of IOLs which may be required in absence of capsular support. So this talk, I think, nicely managed by, people who have made this program, debating between angle-supported, iris-supported, or scleral-supported lenses, on the table decision when you have this situation coming on, especially in a difficult situation which normally face. No financial disclosure from my side. So this is what we are talking about. If you have an IOL fixation to be done in the absence of a capsular support, then we have three areas. One is angle-supported lenses, which has been there for many, many decades with a lot of modification in design. And most suitably now we have a multiflex design which has been accepted and well tolerated by many, many of our patients. The second option is iris. The iris fixation can be anterior or a retropupillary fixation, and which also have been there for a very long time, maybe 3-4 decades now. The other area of interest is the scleral area, which is scleral fixation, can be sutured, glued, or a now Yamani technique coming up in these cases. So let me take you through these three areas of fixation of these lenses in absence of support. So what are those points which may be giving you a decision-making factors? One, I would definitely say the experience of surgeon. And second important is the IOL availability on that particular time on the operation theater, which is a major challenge nowadays. Age of the patient, as we discussed the previous talk, Age of the patient is also a very important consideration. Then your iris or a pupil status. That will determine which type of fixation you're going to do in these patients. As far as cornea is concerned, sometimes we do feel cornea would get an endothelial compromise. Maybe because of surgery, or patient may be predisposed as such with a fuchs endothelial dystrophy. Then other comorbidities which may decide in your cases. So let me take you through this nomogram. So if you have a look into anterior segment anatomy, it has to be checked appropriately. The pupil is circular and iris is intact, so you have all these options. So if you have no glaucoma, no iritis, maybe all sort of combination of ACIOL, retrofixation, or a scleral fixation may be all right. But if you have shallow anterior chamber, potential for corneal decompensation, in those situations, SF-IOL is a better option. AC-IOL and iris-fixated IOL should be avoided in these cases. So if you have a glaucoma surgeries, again, you may require a glaucoma patient, may require filtering surgery. In those cases, we should not disrupt the conjunctiva or a tenons in those cases. There, I think the AC-IOL is again out because glaucoma will get worsened in these cases. Yamanis or iris-fixated lens will be better in these cases. Iritis, again, SF-IOL should be choice. Post-vitrectomized eyes, iris-fixated IOL or ACIOL may be choice because chamber may be deep in these cases, and you might go for these lenses without fear of damaging the sclera, which may already be damaged because of BR surgery in these cases. With a large iris defect, corneal decompensation happening, too much of manipulation on the table, patient may require endothelial keratoplasty. In such cases, transscleral haptic fixation is a better option in these cases. To summarize the point I have talked about, what are the things which may be factored to avoid particular type of fixation? AC-IOL, if you have a corneal compromised situation. Other eye is already compromised, endothelial fixed dystrophy, you have a peripheral antisynechia, large iris defect, ACIOL should be avoided in these cases. There, iris-fixated IOL may be an option in these type of cases. If you have iris deficiency is much more. You can't put iris fixation in these cases, especially post-traumatic cases, chronic uveitis patients, where you already have a lot of iris atrophy, aniridia patients, you cannot put iris-fixated IOLs, both anterior and retrofixation. Scleral fixated IOL, again, patient with like Marfan's syndrome, where you have a thin sclera, posterior segment pathologies, anticipated glaucoma implant in future trabeculectomy in these cases, you should avoid SF-IOL in these cases. Looking into a complication-wise, if you look into three areas of fixation, the three important complications related to one particular part will be AC-IOL, we fear endothelial failure. Iris fixated, we looking for a disinclination. For scleral fixation, many complications are important, but vitreous hemorrhage, detachment is a major factor for a concern for putting particular type of IOL. Other complications like cystoid macular edema, UGS syndrome, may be there in all type of fixation in these cases. So these were three areas, but if you have a case scenario where you feel all three are possible, ACL implantation can be done, retrofixation can be done, and scleral fixation can be done, then what? Which one you will choose in these category of cases? So there will be few factors. One is knowing the long-term outcomes of a particular type of fixation in your patients, or people have reported those cases. Second, as I said, will be an experience of surgeon in a particular type of procedure. Third is the age of the patient. Older patient, maybe like you can fit AC-IOL in these cases, and availability of IOL in these cases. So let me take you through the literature on the long-term outcomes. So this is a very recent study, 2020, a meta-analysis done. If you look into all types of fixation, there were 8 types of fixation techniques being described in this. Visual outcomes were comparable in all types. But the risk of CME, that is a very important aspect, was maximum with the sutured SF-IOLs and iris-fixated IOLs. That means these cases do have an inherent inflammation going on, and that will increase the CME in these cases. Chronic uveitis, again, more with the antechamber IOLs. Retinal detachment is again more with a sutured type of fixation. Let it be iris-fixated sutures or a sutured SF-IOLs. Chronic glaucoma, again, were more with the scleral sutures, especially with the 10-O nylon suture, 8-O nylon suture cases in this case. So this was visual outcome-wise. If you look at complication in these category of cases, IOL tilt, maximum with the suture-fixated IOLs. Long-term IOL dislocation, again, more with the suture-fixated SF-IOLs, around 28% of cases, especially 10-O Prolene sutures. Glaucoma, overall, you will see glaucoma in all cases. But again, it's more with the suture-fixated cases of SF-IOLs. CME seen in all group of cases. And similarly, detachment, which is a major threat in all cases where you have no support. It's more with the, again, suture fixated IOLs in these cases. So if you see the complication wise, it seems suture fixated SFIOLs has a maximum complication in these group of cases. This is one study compared only the scleral fixated type of lenses, 3 types: transscleral fixated, intrascleral fixation, and iris fixated. There again, the visual outcomes are comparable. Iris fixated has the lowest risk of intraocular hemorrhage. But if you look into endothelial cell damage, maximum with the iris fixated IOLs. This is our study published by Dr. Rajesh Sinha, where we compared suture versus the transscleral haptic fixation. And there also we realized if you have a good transscleral haptic fixation, you have better outcomes in terms of tilt and decentration less. Also, the CME and macular thickness was less with the transhaptic fixation compared to suture fixated lenses. And this study, we did a UVM for all cases to look for tilt and decentration and the IOL movement in these cases. So if there's an IOL movement, definitely you have a more chance of uveitis and CME in these cases. To look into a entire literature that has given 2 literature. One was the meta-analysis. Second was meta-analysis only for a fixated, suture fixated versus transscleral. We realized antechamber, iris fixated, they all have a good visual acuity in terms of outcome-wise. But there is no clear-cut superiority if you look into the accepted type of fixation, that is ACIOL versus the transscleral haptic fixation. It depends on our surgeon's expertise, IOL availability, the status of eye and comorbidity, which will decide which type of IOL we want to use in these cases. So I'll say ACIOL, yes, it is a time-tested lens. People have used in the pediatric cases also. There's a study from Japan. 10-year results of ACIOL in pediatric cases had a better result than a lens in the bag in those cases. Iris fixated again is getting commoner because of retrofixation is getting popular in India, and the long-term results are yet to be known because they've just started 5-10 years, and we have seen these lenses will have a higher chances of iris atrophy happening. Mild trauma might cause a disincubation in these cases. There's a higher risk of CME in these cases. Similarly, SFIOLs, I would say suture SFIOLs are totally out of practice now. It has to be transscleral haptic fixation or Yamanen's technique if possible in your cases. Thank you for kind listening. Rest is up to the panel to decide which is type of technique they want to use.
Dr. Gaurav, your preference?
So actually, I do all the techniques, less and less of ACIOLs now. Over the years, ACIOLs have gone down drastically. Yet in a situation where you do a very clean ACIOL, I'm not against it. But I think for me, both SFIOLs and retrofixated iris claw, I enjoy putting retrofixated iris claw where there's good iris support. It takes very little time and it's very less traumatic and it's tolerated very well, and I feel that that's a very underutilized technique as well. But yes, when you want to do a proper vitrectomy and we want to give a great result, and sometimes if I'm retrieving a lens, like if there's a subluxated pseudophakia or a bag, then I will definitely go for refixating it to the sclera, and that works really well. So it depends on the situation, and I think sir is, as a master, he's already given all the things which are required to decide.
Gaurav, there are 2 types of situations which I didn't highlight here. One is complication happening on the table in a normal case and you lose everything. One is a case where you already anticipate you won't have a bag support there, like a large subluxation cases, or you have a post-trauma cases, where you plan your cases, like you're going to do fixation in it. Those are planned cases, you might achieve results. The difficulty comes when you have a complication on the table in a normal case, you have nothing in your hand. Unfortunately now, ACIOLs are not available in the market also, because the people are not making ACIOLs now. They were very good, in fact. Now you have to depend on a fixation of a lenses, either transscleral or the retrofixation now, 2 options.
Yeah, very, very rightly said by Dr. Tetiar, like if you are planned, it's always better. So I think if you happen to have a complication during the surgery, it's always better to postpone the case for the IOL implantation at the next stage. And many times you see, even if a small amount of the capsular support is left, when it fibrosed, and it gives you a good support to the IOL later on. So on the table, you may decide, okay, you go in for this ACIOL, which is very, very harmful and to the patient.
Yeah, I think you're right, absolutely right, RP. Sometimes, in a haste of movement, you try to do so much of vitrectomy and try to take out everything and lose everything in those cases. Maybe little conservative, he pointed out very nice point. If you have a difficulty, your anterior segment is getting disorganized, your AC is not forming well, it's better to leave the case, put sutures and decide subsequently, which is a very good idea. You can assess the posterior segment, you can assess the visual potential, you can assess the endothelium, glaucoma. Maybe after 8 weeks, you can do a secondary IOL, which may be very comfortable. Very nice point.
Yeah, thank you. And yeah, Dr. Gagan?
So I just wanted to ask that these were two situations, or there's always a third situation where, as a posterior segment surgeon, I'm asking, so where, you have the secondary IOL positioning to be done as a primary procedure. So you probably have a case which has gone wrong and been referred. So what would your preferred choice be where you have probably you need to, decide between a secondary IOL and a DSEC, both. So what would be your preferred choice of IOL in a combined procedure?
No, as far as we are, as an anterior segment surgeon, if I have to do a combined keratoplasty and IOL in those cases, I would require a stronger support of IOL, because whenever I'm doing a DSEC or a DMEC, the air pressure can be sometimes challenging for an IOL to be retained. In such cases, the transcranial haptic fixation is always better, because you have a very strong fixation there. The iris retrofixation, people say it will be all right, but I normally fear sometimes I've seen one inclination going down. Then you have a very difficult to pick up that. You require a vitreoretinal support to lift that posterior claw and clip it. The suture fixation we are totally out of practice now. Other area which we have worked out, a patient with vitrectomized eyes sometimes we do a pars plana IV infusion in these cases to support pressure from behind. There, any type of lens will suffice because you have a support from behind. So there you can do ACIL, you can do retrofixation, you can do a suture fixation also. That supports IOL as well as the DSEC lenticule.
Right. Dr. Rishi, you have any?
I think pretty much everything has been discussed. I think Dr. Tyal has just given a fantastic overview of how these lenses have been used. I think we are older school surgeons. I think the AC IOLs must be in our hundreds by now. But yes, over the years, as Gaurav was saying very rightly, the number of AC IOLs has dropped drastically as better and better IOLs have come in. And I think scleral fixation is the way to go. I agree. Suturing is out. It has to be direct haptic fixation, either in a tunnel or a Hoffman pocket. I think you need to be familiar with every technique. I don't think there is, everything is so individualized and you have to customize it based on what's in front of you happening on the table. I still think that a sulcus fixated lens, if there is some capsular support, is very forgiving. It does tend to withstand anterior and posterior pressures and displacements. One doesn't have to necessarily fixate it in any way. A nicely fixated sulcus lens, if you've got a good capsule available around, is very, very stable. And very often when we're doing regrafts and so on and trying to reconstruct, we have patients who come up with the lens already there. Then the debate is, shall we fiddle with it, take it out and replace it, or just leave it there? And more often than not, that lens sitting there does very well and never gives problems later on.
Absolutely. No, I have so many DSEC done in AC IOLs, and they're doing pretty well. So endothelial decompensation may have happened because of other reasons rather than AC IOLs. If it's done properly, it is a very nice device for at least for older patients.
Very right. Thank you, Professor Tijal, for the beautiful presentation. Now, the very important topic by a very important person, our President AOS, Dr. Lalit Verma. And the topic, it's of interest to all of us because all the cataract surgeons, and his talk on endophthalmitis, I've seen him talking at, you have to really listen it properly because this is going to be a wonderful and very, very useful to all of us. Dr. Lalit Verma.
Thank you, RP, for adjusting this talk of endophthalmitis in a cataract session, and thank the entire DOS for this. Endophthalmitis is disastrous, especially if it happens to your eye. You are the operating surgeon. And if not treated in time, it can result in thisis bulbi. Therefore, always treat early or refer early if you can't manage yourself. I'm not going to talk in detail about endophthalmitis because the talk given is slightly, then and now. So I have to compare these two entities. But I will just start with now what we are doing in endophthalmitis. So there are some preventive considerations which are listed in this white box. That is preoperative considerations and peroperative. And all of you are doing, betadine, drape, to isolate lashes, good construction, suture if in doubt, very important. Because wound is the main thing, because wound construction is the main thing. And when in doubt, please suture. And intracameral antibiotics has taken the entire world by storm. In fact, most of you are giving intracameral antibiotics. Once it comes to treatment, now what we are doing is intravitreal antibiotics only. And if injected early, organisms are sensitive and you are lucky, results are pretty good. But vitrectomy needs to be done if either to debulk the cavity, or if the organisms are not sensitive and results of first injection are not very good. This is just to show you that this was a patient who was injected Vanco and Kefta, and results is pretty good. Therefore, the thrust is always to give 2 antibiotics properly in time. The results can be very good. But if not, I do not encourage multiple injections of interval injections. I have a very low threshold to go inside the vitreous cavity, primarily because of small gauge vitrectomy, everything has become much simpler, and response also can be very, very good. And we always do a complete vitrectomy. We never encourage core vitrectomy. A radical vitrectomy is the answer in this infectious eyes, because if you leave behind anything, it can have possibility of recurrences. So this was one patient who had a corneal abscess. Multiple injections already had been done. So with radical vitrectomy, what we could achieve is this. You see the abscess became a corneal opacity, and ultimately at the end of 4 weeks in the silicon-filled eye, we had this 6/24 vision. So I will not bore you with this vitrectomy steps. So, but whenever we do a vitrectomy in an endophthalmitis eye, you see the infusion has to go straight ahead or a 6 mm cannula, and then you make 2 stab incisions primarily to, to clean up the anterior chamber. Because if the AC is not complete, you can't do a precise job in the vitreous cavity. So after first stab, you put in the visco to protect the endothelium. Then some time is spent to, clear the AC. And in this particular patient, there was so much of purulent material in the anterior chamber that it took some time, and a lot of adhesions were there from connecting the abscess with the intraocular cavity. And ultimately, this IOL had to be taken out to facilitate the vitrectomy. And this IOL had 1 haptic only. And then we went ahead and do a vitrectomy in this now aphakic area and remove every bit of the muck in the anterior chamber. And then I do not hesitate to do a depression vitrectomy because, as I said, vitrectomy has to be complete, vitrectomy has to be thorough and total. So now you will see we are depressing in all the 4 quadrants, and to take out every bit of the, now you have the glow, and ultimately this patient had some useful vision at the end of vitrectomy. So these were the 10 tips we keep giving to all the people, that these stand tall today. These 10 tips we suspect differentiate from TAS. This country recently had a lot of episodes of TAS from a particular hydrophilic IOL. Then please talk to the patient, prompt injection, and document all your findings, because ultimately, and don't hesitate to take a peer review from a higher center, but these are things which will ultimately save you in the court of law. But what about then? Because RP gave this topic then and now. So what I could identify was, then means in the past, there were pre-antimicrobial era from 20s to 40s, then we had systemic antimicrobial era, then we intravitreal antimicrobial era. So today where we are standing is the intravitreal microbial era, but if you dig into the past, we had pre and systemic also. And in pre, you'll be surprised to see all sorts of funny things which were used at that time. You see, these are things of history now, and nobody does all these things, and I will not even read all these things lest they get imprinted in your mind. And the incidence of endophthalmitis at that time was pretty high, that is 2%. When the antimicrobial era came from 40s to 70s, the systemic antibiotics and local application, they brought down the incidence to 0.1%, from 2% to 0.1%. And the lower rates primarily were because of aseptic technique and minimal traumatic surgery and perioperative antibiotic prophylaxis. This was the analysis done by Allen in 74. In came this intravitreal era where the drug was deposited at the site of infection, that is vitreous cavity, and the pioneering work was done by Payman et al. A lot of experimental studies on rabbits, and ultimately, the whatever dosages and all we follow now is because of the experimental work done by Payman et al. In the early 70s. Further, what has happened now is small gauge partial vitrectomy has been added to improve both anatomical as well as functional outcomes. The other thing which has assumed importance is silicone oil, especially in the very severe patient of endophthalmitis, is a very, very useful adjunct. The other thing is previously patients of endophthalmitis were admitted, but nowadays it's an outpatient job and you can follow up the patient on an OPD setting. So I just try to tabulate, today, then and now. You see, if you see then, you see incidence was pretty high. If you see incidence 2%, now the incidence is much, much lower. And the preventive measures in the past were topical antibiotics and boiling and all chemical sterilization, but now the thrust is on betadine, steroid rape to isolate lashes, and intracameral antibiotics. Treatment settings from IPD to OPD. Treatment point of view, previously the thrust was on systemic antibiotics. Now the thrust is on intravitreal, complete vitrectomy, and silicone oil. Antibiotics, there were few choices in the past, but today we have a lot of newer antibiotics which have come, although the problem of emerging resistance also is there. And today studies and data are available. Today we have a lot of multicentric trials. Previously we had retrospective case series only. Previously the chronic onset endophthalmitis was not recognized at all, but today we know P. acne can cause low virulent bacteria, can cause endophthalmitis. Prognosis was poor, and this end result of thyroid bulbi was not so rare. And today, the results have improved quite a bit. Prognosis is pretty good. MLC and court cases, thanks to this bad mouthing done by colleagues, have increased now. Previously, people, destined it, to their fate about this. So I'll just finish my talk by saying this was one patient. This eye slide dug out more than 30 years back. This patient was treated with drops. Ultimately, this eye got lost and no injections was given. This eye I dug out specifically for this talk more than 35 years back. And this was a patient who had multiple interventions, very aggressive interventions, and we would save this eye in 6/9 vision. So thank you very much, RP, for having this talk here.
Thank you, Dr. Lalit, for describing so beautifully endophthalmitis then and now. And it seems to be a lot of difference and a lot of changes which has happened in the treatment and diagnosis of endophthalmitis. I have because in a routine clinical practice, what we face the problem anterior segment surgeons, you operate the case, on the next day I see few cells or maybe a little more cells in the anterior chamber, and with some amount of, say, occasionally a very little hypopyon. So how long I should wait to confirm whether it's a TAS or endophthalmitis, and how should I proceed in such cases?
So you yourself have the answer. What kind of surgical trauma you caused, that has to be there. Because if it was a routine surgery and then it happens, then I think the maximum waiting time and the treatment will depend on the glow which is there. If on retroillumination you have a good glow, or with infrared you can see with the retina or the vitreous clearly, then I would presumably start this patient on intensive steroids. But waiting time, as you said, how long? It's not more than 24 to 36 hours. And if the patient, is plus, then you continue your treatment. If patience is minus, that means any of these parameters, what you said, fibrin, hypopyon, or pain. Pain is very important, chemosis, lid edema. If anything of them, or the smile on the patient face has gone, then you immediately inject intravitreal antibiotics. So answer is, waiting is 24 to 36 hours or maybe even less. So one thing is very important, as soon as the patient walks, Dr. Sahab, pehle se acha hai. That is very good. But if the lid edema, chemosis, anything has increased, or the cells or hypopyon, anything has increased, immediately go inside. Immediately means sacrifice the OPD and go to the operation theatre floor and do it.
And yes.
But very important is to talk to the patient and relatives. I'll tell you one story which, I must have told in the past also. Yes, Dr. Bharti, first your question.
Yeah, my question is without doing any trap, vitreous tap or something, when you are giving the intravitreal, what is your take on giving only antibiotics or antibiotics with steroid as a first injection?
So, very pertinent question, Dr. Bharti. By and large, we avoid steroids in the first intravitreal because in contrast to EVS study, in this country, fungus is not so rare. Okay, unless and until you are pretty sure that this is bacterial. Intravitreal steroids, normally we give oral steroids because the penetration of steroids in the vitreous cavity is pretty high in comparison to antibiotic. So there are studies available where it has been documented. We also did one study in RP center where we had steroid in one group and, then the 20% difference was there between two groups of the functional outcome. Because all these, endophthalmitis have itis part. What steroids do is to take care of the inflammatory component and the functional outcome is better. There is another study from L.V. Prasad also wherein they also documented that more patients achieve 6/60 vision rather than in patients of steroid group rather than no steroid group. The only caveat there is you have to rule out fungus, which may not be. Remember, fungus can also present on day one. It's not that only bacteria present on day one.
Okay, so primarily no steroids. And
I would not. In last more than a decade, 1.5 decade, I have not given steroid in the intravitreal injection. What I do is we give intravitreal antibiotics, 2 of them, support them with systemic treatment also. The EVS study did not give systemic treatment because at that time this higher generation antibiotics are not there. Now we do give systemic treatment also along with them and add steroid after seeing the first post-op day of intravitreal injection.
Thank you.
But believe me, we haven't regretted this regimen.
Sir, excellent presentation, Dr. Lalit. There is a little suggestion for you. सर अगर आपकी स्लाइड किसी एडवोकेट ने देख ली उसमें वर्ड लिखा है मर्डर सर प्लीज रिमूव द मर्डर अदरवाइज ही विल पिक अप दिस मर्डर ही विल से दे आर मर्डरिंग द आई एम टेलिंग यू थैंक यू सर
Suggestion well taken.
So would you
Suggestion very
recommend?
well taken, but aim was to emphasize. I will remove this here. Yes.
Do you recommend vitrectomy for a low virulent infection also? Do you recommend vitrectomy for a low virulence infection also?
Yeah, in fact, more in low virulence. Because more in low.
Presenting even after 6 months, would you recommend it?
Yeah, they respond to vitrectomy the best. Because you see chronic endophthalmitis, which I was hinting, by and large, most of these people have already been treated with multiple injections, steroids, cycloplegics, and they tend to reoccur. And these are the people who generally require IOL removal as well as vitrectomy. The reason I'm saying IOL removal is because the organisms is lurking inside the capsular bag. And unless you make an opening in the bag, either with a cutter and infuse vancomycin in the bag, these people don't respond. So most of the people do not do that. They give intravitreal injection. The response is much less. Therefore, you end up removing the IOL sometimes. And after removing the IOL, vitrectomy by and large is not very difficult in these patients. Most of the time is spent in removing this bag. So you have to remove the entire bag and then only there is a long-term remission.
Sir, also from then and now, do you think that we have changed from Vancomycin to maybe colistin, tazobactam as a primary drugs?
Yeah. So by and large, you are right because Cefta ki sensitivity has reduced from 85% to nearly 50%. Cefta used to be very good antibiotic for gram-negative and Vanco for gram-positive. Vanco has still maintained over 90% of sensitivity, but Cefta sensitivity for gram-negative has come down by more than 30-35%. And hence the relevance of your question, people have shifted to better antibiotic like imipenem or piperacillin or colistin. So they have shifted. And that is the reason, Gagan, in the recent chart what we gave from AIO side, we have included all these newer generation antibiotics also. The previous chart which I had circulated long time back did not have these newer antibiotics. And you are very right that sensitivity of gram-negative has come down. vancomycin. It's more of theoretical. I haven't seen, but I have read about it quite a bit. So therefore, the prophylactic use of intracameral, antibiotics, vancomycin lost its popularity. Cefuroxime lost popularity because of non-availability of single units, although they have come now. But
because they are doing compounding.
yeah.
Yeah.
So HORV or hemorrhagic occlusive vasculitis, vancomycin, I have not seen because we hardly use, because in this country we rarely see people using vancomycin as a prophylactic agent. It started from Canada actually, where vancomycin was propagated by Gilbert group actually, where they reported
They were using routinely.
Yeah.
Yeah.
So they reported, and here in this country people use Moxie as the preferred this thing.
And antifungal, because that is quite bad in the villages and the peripheries of India, and that's the most common, and we don't discuss much about it. Antifungal drug is the first choice. Which one?
There's no doubt in today's mind that the preferred antifungal today is voriconazole. All these azoles are fungistatic drugs actually. They are not fungicidal drugs. So amphotericin B is the most potent of them, but amphotericin B we keep as a second line drug. And response of fungal endophthalmitis despite the intravitreal voriconazole, despite multiple injections of amphotericin B, vitrectomy, revitrectomy is required in majority of the fungal, especially if it is severe.
In the villages, the voriconazole.
But I have had patients who have responded only to oral voriconazole also. They have responded. But if it is a severe fungal endophthalmitis, especially fusarium, you have to have vitrectomy done. Then keep these patients on regular antifungal intravitreals.
Actually, voriconazole is used in the lands by the farmers. Use the voriconazole in the lands for the farming, and when they get the infection, that is already resistant. That's the practical problem, and how we come about it, I don't know.
So therefore, I said if you compare the bacterial and fungal, the percentage of patients of fungal requiring vitrectomy is more than 80%, whereas bacterial requiring vitrectomy is maybe less than 40-50%. Right.
I mean, now the more vitreoretinal surgeons are there. I think when patient is a really VIP, I think most of the people are trying to keep everything ready for vitrectomy, complete vitrectomy. That gives a much better results as compared to waiting for injection, and then of course we can give injection to save time. Otherwise, I think many people are
so therefore,
going for
the
that.
threshold of going inside has reduced quite a bit. So we no longer encourage first intravitreal, second intravitreal, third intravitreal. So we, after first intravitreal, if the things are going south or going down, don't hesitate to go inside.
That you said very well. Yeah, after one injection, if no improvement, keep ready vitrectomy.
True. Dr. Namrata, you can any highlight on TAS, like because since we are discussing now endophthalmitis, so because how much concern we should be about that situation, and what is the status now?
So TAS has taken us by storm for the last 3-4 months, and now it has subsided thankfully. So for the TAS, actually there are so many things which have to be blamed, and one cannot pinpoint on a particular thing. And as far as the AIOS is concerned, all the possible steps have been taken under the leadership of our President, Dr. Lalit Verma sir. So we have reported this already to the higher authorities, which include the Pharmacovigilance Department and the CEDESCO, and had meetings also with them regarding the same. Also, samples have been sent to 2 labs. One lab report says that none of the IOLs had any features of endotoxin on them, and the second lab samples are awaited.
So
and besides,
once this report came to us, once AIOs came to know about TAS happening all across the country, and hydrophilic lenses of one particular company were blamed. So we have taken 7 steps actually till date. One was an advisory issued on 13th of December. We issued that advisory to all the members about be careful about these batches, and this was followed by an open forum discussion with a lot of people who were facing this. And after that, we requested all the members to send us those samples because we never wanted to be biased. In between, few members had got this endotoxin levels investigated at Chennai also, Arvind Hospital, and where it was found that 5 out of 9 had more endotoxin levels. But once AIS office got these samples from all across the country, plus we spoke to big institutions also, like RP Center, like Chitrakoot. Somehow they were not getting tasks from the same batches of IUL. You see, I spoke to Alkesh, not Alkesh, but Dr. Jain and Dr. Sen. They said they have done more than 7,000. They did not, with the same batches, did not. And same was true for RPC. They were not getting. So reports are erratic. Therefore, I wanted an unbiased kind of investigation. So we after sending letters to DCGI, after sending letters to Care Group, that this is an alarming thing and AIS will not be a silent spectator in this. So we did send samples to the DCGI approved laboratories. We can't send it to, we did take help from TTL also at that time, but we sent it to DCGI approved laboratories. The first report came 10 days back. The second report should come tomorrow or day after. And the first report which has come has did not find endotoxin levels above the recommended levels. So by and large, like Tityal was saying, it has now died down. So I spoke to Dr. Chetan Parekh also, who was spearheading this WhatsApp group, and he also said, "Sir, ab zyada nahi ho rahe." But believe me, AIS is quite aware of all these things, and because of this, at least we created task registry. Not only task registry at AIS website, we are going to have other adverse events registry also, so that members, whenever they have it, they should report, so that we can, take some action or investigations can be started. Yes, sir.
Dr. Lalit, no discussion on endophthalmitis is complete unless we've spoken of cluster endophthalmitis.
On cluster?
Cluster endophthalmitis. So I think that is one which causes a lot of dread, and there is a difference in the etiology, spectrum, and how it is handled, and particularly your advisory as AIS president to what a person should do when he is faced with a cluster endophthalmitis.
So first step, because the talk in 7 minutes was then and now. So we could not have covered cluster in this small 7-minute talk. Then and now, I have to compare then and now. And I did not discuss about even sporadic, what to do about cluster. We didn't go into depth of endophthalmitis at all. Aim was to compare what was happening then and what was happening now. But as you rightly said, no talk on endophthalmitis is complete without cluster, because it is a cluster which creates, more scare. More scare not only for the surgeon, but for the entire hospital facility also. And the cluster by definition is if, you have 3 consecutive, 3 patients in a single OT, which is getting infection. Because what is given in books is red alarm, yellow alarm, and green. So if you have 3, then is a red alarm. Then you have to necessarily, by law, close the operation theatre. Operation theatre has to be closed, and you have to, inform the authorities and inform AIS also about this has happened, so that plus treat these patients. If not at your setup, maybe you can refer these patients, document that you have referred, and also investigate the entire of your hospital facility. Have you purchased anything new or a cheaper ringer lactate? This is what we have generally found. Investigate from where the infection is coming from, and authorities have to be informed, government has to be informed, and generally speaking, in all these clusters where, I have gone, fluids have been implicated, or something which has been changed in, last couple of days or weeks have been implicated. Even air conditioning, has been implicated, or the number of exchanges, one of the epidemic was blamed. So there are lot of things which have to be investigated. So one line for people who, if they get cluster, is to close down the OT. Inform, investigate, treat, and refer.
Thank you, Dr. Lalit.
Close down till. What if you don't find the answer? What if you don't find the answer?
Another team comes to investigate all your, methods of autoclave, indicators, everything has to be investigated. And till the time you have next 2 consecutive or 3 consecutive culture negative, and till the time you have to close that.
Usually that's what happens.
Generally
you
it
have an
happens,
episode and
if you are
everything starts
proactive,
coming normal and then you can't figure out and then you need to start.
I know, Kamal, these are, mandatory required. Generally, it happens in 7 to 10 days. It takes so much time for the team to come investigate, because if you are yourself investigating, take care of all the logbooks, all the fluids, everything has to be tested again. And those, whatever fluids, they have to be sent again. So this generally takes 2 weeks' time. And then you have to send repeat cultures. And then if they come negative, then you can slowly start the OT.
Thank you, sir. Thank you very much. Thank you, Dr. Lalit, for the excellent presentation and such a nice discussion we had on endophthalmitis, which is, I think, one of the very important subject to all of us. And I really thank you. And thank you all the panelists with us here on the dais and all the speakers. And I think this session was very, very fruitful to all of us and very excellent. Thank you very much. Thank you all for joining here. And now we have a tea break for half an hour. And after that, we'll be starting our award ceremony. So please be here, take the tea, and then you'll have to come back here. Thank you very much.